Of our pre-session, I request all the candidates to keep their microphone mute and their video off. This session will be divided into two parts. First part will be the presentation of their paper, and that will be for 6 minutes. And after that, there will be a question and answer discussion session, which will be for 2 minutes. I welcome our judges for today's session, Dr. Dipesh Gupta sir and Dr. Mamta Mahavia ma'am. Dr. Mamta Mahavia ma'am, Designate Professor, Netaji Subhash Chandra Bose Medical College, Jabalpur. She is an executive member, ISA MP State Chapter, elected in Mpisacon, Jabalpur. Elected as State Treasurer in MP ISA election 2021. She have 10 national and international publications to her name. I welcome Dr. Mamta Mahavia ma'am. Our second judge for today's session is Dr. Dipesh Gupta sir, Professor Designated, Gandhi Medical College, Bhopal. His areas of interest is pain management and regional anesthesia. He has 5 national and 2 international publications to his name. His achievements: he is a present honorary secretary, ISA Bhopal City Branch. He is the past treasurer, ISA Bhopal City Branch. He chaired and judged sessions in various state conferences. Welcome, Dr. Dipesh Gupta sir. Sir, I request and ask permission from our judges to start the session. Sir, can we start the session, ma'am?
Yeah, you can start.
Thank you, sir. So our first part
is Dr. Mamta here?
Yes,
Dr. Mamta is also here. Okay.
Yeah.
Ma'am, can we start?
Yeah, please start.
So the first participant for today is Dr. Ankit Srivastav. Dr. Ankit Srivastav, he is an SR from Vidisha. Dr. Ankit, I ask you to unmute yourself and start sharing your screen.
Yeah, good morning, everyone. Good morning, respected judges. Am I audible?
Yes, Ankit, you're audible. You have 6 minutes, so keep up with the speed. And
yeah,
after
sure.
that, 2 minutes will be for the discussion.
Yeah, exactly.
You can start your presentation.
So, okay, yeah. Good morning, everyone. Today, my topic of discussion is comparative study of hemodynamic response following laryngoscopy and endotracheal intubation using a direct Macintosh laryngoscope and a video laryngoscope of King Vision King Systems Incorporated. These are my designated people who did this research with me, my guide and my co-guides over there. Right. So what is laryngoscopy and intubation are the two essential procedures when general anesthesia is administered to a patient. Okay, and we all know that adverse responses in cardiovascular, respiratory, and other physiological systems can be provoked due to noxious stimuli produced by laryngoscopy and intubation. However, intubating a trachea is the gold standard in airway management because it is the safest method of protecting the airway and delivering anesthetic gases. And direct laryngoscopy and tracheal intubation is done mostly by the Macintosh laryngoscope, and it has been the gold standard device till now. And while using Macintosh laryngoscope, we all know that a relatively high forward and upward force is applied on the handle to visualize the glottis to make the oral, pharyngeal, and laryngeal axis into view. And ultimately, what happens in endotracheal intubation performed by intubating devices using indirect or the video laryngoscopy need comparatively less degree of manipulation of the airway, as at least in theory, we expect less hemodynamic stress response by using such devices. The aims and objectives of the study were towards the superiority of the video laryngoscopy over direct laryngoscopy using baseline parameters, usually the heart rate, SBP, DBP, and the mean arterial pressure. Objective is to compare the hemodynamic stress responses during laryngoscope and endotracheal intubation using King System King Vision laryngoscope as compared to Macintosh laryngoscope in ASA grade 1 and 2 patients receiving general anesthesia for elective surgeries. The material method study design was done in my place, Durgapur Hospital, West Bengal. Study population was at males and females, physical grade 1 and 2. And they are scheduled for elective surgeries and LGA requiring urotracheal intubation. Study duration was 1 year from 2018 Feb 2019 Feb. It was an intervention randomized study. Inclusion criteria was adult males and females of age group 35 to 50 years, airway ASA grade 1 and 2, patient posted for elective surgery. Exclusion criteria was BMI more than 30, 3 and 4 were not included, age group less than 35 and more than 50, short TMD, restriction and extension, protruding front teeth and Malampati score more than 3. Now, this was the type. We had taken 50-50 groups, a total of 100 people were taken for the surgery by randomized control trial method by a computer-generated random software. And the results were exactly found were, in the group, the ultimate results were these ones. You see the clockwise arrangement of the graphs, the heart rate, systolic, diastolic, and the mean arterial pressure. We see that the red one is the group B, King Vision video laryngoscope, and group A is Macintosh direct laryngoscope. The one with the King Vision video laryngoscope showed a greater reduction in the hemodynamic parameters when they were used after the baseline, after induction, and just 1 minute, 2 minutes, and 3 minutes after intubation. And you see the same thing in the systolic blood pressure. The ultimate reduction is seen in immediately after intubation and 1 minute, 2 minutes, and 3 minutes and 5 minutes after intubation compared to the Macintosh direct laryngoscope. Same thing with the systolic and the diastolic and the mean arterial blood pressure. So we can conclude this particular thing that the particular reduction in the mean arterial pressure, the heart rate, systolic and diastolic blood pressure was more compared to Macintosh direct laryngoscope. Okay, the studies were done as I told just now. With the Tempe et al., the Circular et al., and CoDD et al., the STM et al., this all showed the same thing as compared to our study that after 1 minute, 2 minutes, 3 minutes, and 5 minutes after intubation, yielded better outcomes in King Vision video laryngoscope group. The future scope, as we all have seen, that included only Malampati grade 1 and 2 patients, the ASA physical state group grade 1 and 2 patients. Further study can be done on patient with difficult airways 3 and 4 and with different comorbidities, the ASA 3, 4, and the emergency group, to evaluate whether using King Vision video laryngoscope can be advantageous in reducing intubation time and obtaining hemodynamic responses to laryngoscope in intubation. Conclusion, now we had compared the hemodynamic responses to endotracheal intubation using Macintosh laryngoscope and King Vision video laryngoscope in patients that were presumed to have normal airways, MPS grade 1 and 2. KVVL showed special advantages over the Macintosh one in terms of time taken for endotracheal intubation and hemodynamic responses following the same. It was concluded the time taken for intubation with video laryngoscope was shortened, thus probably with the advantage over the Macintosh one in terms of decreased hemodynamic response. And also King Vision video laryngoscope offered less intubation and reduced hemodynamic response in patients with ASA grade 1 and 2 as compared to Macintosh one. These are the references found. Only 4 references I've taken. Thank you for the patient listening.
Thank you, Dr. Ankit. That was a very nice presentation and very well timed. Now over to our judges for question and answer session.
Dr. Ankit,
Sir.
The method used for randomization was computer-generated software.
Yes, sir.
What is this method of randomization called?
Sir, it was a SPSS software exactly taken with a statistician. I had no directly intervened the one with the same.
Okay, how did you calculate the sample size?
So it was the prevalence and the incidence one, the way, the 4 PQ by L square, the ratio. That was the method actually.
Okay. So what do you think is the reason for stable hemodynamics using this video laryngoscope over Macintosh?
So one thing is when we actually use the Macintosh laryngoscope in patients even with airway grade 1 and 2 or ASA physical status grade 1 and 2, the upward and forward force will cause a sympathetic stimulation of the human body. And that's why the hemodynamic responses change when we use Macintosh one. And with this one, what happens is the blade of the video laryngoscope is aligned along with the oral airway or the oral anatomy of the patient. So when we actually insert this indirectly we can see the glottis opening at a very far area, and directly up to the vallecula also. The thing is we can see the that tracheal opening at that time. So the upward and forward force is not needed for the King Vision video laryngoscope, and that's why the hemodynamic responses with the King Vision video laryngoscope is less.
So you want to say that the force required is less in video laryngoscope as compared to Macintosh?
The one which I have used, the King Vision one, actually has this particular thing.
Okay. Okay, over to Dr. Mamta.
You have used in difficult cases or in simple cases?
Ma'am, actually in simple cases, just to compare the hemodynamic responses with the Macintosh one, because in the previous times we were finding that the Macintosh laryngoscope had a little bit of more hemodynamic responses when we generally used in airway grade 1 and 2 patients also, and ASA grade 1 and 2 patients also with normal hemodynamics that time. So after intubation, what happens is the thing actually goes up. Okay, time's up.
Okay. So you can use in difficult cases also.
Yes, ma'am. We can use in difficult cases. After the study, also we have tried in difficult cases in some of the ENT surgeries and some of the oncosurgeries as well, and it yielded good results even then, in view of the glottic visualization and obviously in view of the hemodynamic responses also.
Okay. So in point of hemodynamic responses, this laryngoscopy you find the better.
Ma'am, the video one, the Kingvision video laryngoscope, which I've used personally in my institute that time, it was much better compared to the Macintosh one because the same thing. In direct stimulation of the sympathetic stimulation is not that much compared to the Macintosh one there.
Okay, your topic is good and you have nice presentation.
Thank you, ma'am. Thank you so much.
Thank you.
Thank you, sir.
Thank you, Dr. Ankit.
Thank
A
you.
message to all our participants. On Hall A, there is some lectures going on of respected teachers around the country, and there are associated questions, quiz associated with all those lectures, and there are attractive prizes in that session also. So all of you are requested to join that and try to answer the questions, try to attempt these MCQs, and you will be rewarded. We'll move on to with our next participant, Dr. Sonali Gupta. She's a second year, Gandhi Medical College, Bhopal. Dr. Sonali, you can unmute yourself and start sharing your screen. Dr. Sonali. Dr. Sonali, first unmute yourself.
Ji sir, can you hear me?
I think there is someone else in your room who is also logged in. Kindly ask them to turn off their mic or turn off their speakers.
Ji sir. Sir, now can you? Good morning, sir.
Stop. Good morning, Sonali. Make it full screen. Make your presentation. Yeah.
Sir, shall I start with my presentation?
You can start with the presentation after you make it full screen. Your presentation is not in the full screen mode.
Ji sir, now it is visible, sir.
Yes, now it is visible. You can start with your presentation, Sonali. You have only 6 minutes, so be fast.
Ji sir. Sir, good morning, sir. My topic for paper presentation is evaluating the effect of oral clonidine and tranexamic acid on bleeding and surgical field quality during endoscopic ENT surgery. My moderators are Dr. Shikha Mehrotra ma'am, Dr. Urmila ma'am, and Dr. Nilesh sir. Introduction: bleeding during functional endoscopic sinus surgery is an important issue for both anesthesiologists and surgeons due to high vascularity of sinuses and nasal mucosa. Despite the low rate of major surgery Despite the low rate of major bleeding during functional endoscopic sinus surgery, maintaining maximal visibility of the surgical field for surgeon is of great importance. In some cases, even small amount of blood can affect the endoscopic view, resulting in possible complication, extended or even incomplete surgery, and therefore a lower success rate. My primary objectives are to compare the efficacy of clonidine and tranexamic acid on bleeding and surgical field quality during endoscopic ENT surgeries. And secondary objective is to compare any hemodynamic changes and any effect on duration of surgery in both the study groups. Material and method: study type is observational hospital-based study. I took 60 patients. Study was done at Hamidia Hospital, Gandhi Medical College, Bhopal. Inclusion criteria are ASA grade 1 and 2 patients, age 18 to 60 years, suffering from rhinosinusitis with or without polyposis. Exclusion criteria: history of previous sinonasal surgery, underlying disease with increased risk of thrombosis, chronic systemic diseases that would not allow controlled hypotension, those using calcium channel blockers, anticoagulants, digoxin, aspirin, beta blocker, and other medication that may interfere with the study protocol, and high preoperative systolic or diastolic blood pressure over 160 mmHg and 90 mmHg respectively. Eligible patients were randomly divided into two groups. In the first group, IV tranexamic acid 50 mg per kg diluted in 100 ml normal saline was given, infused in 10 minutes after induction. In the second group, 0.2 mg oral clonidine was given 1 to 1.5 hours before surgery. This group also received 100 ml IV normal saline 10 minutes after induction. Randomization was performed using table of random number. Both surgeon and patient were blind to group allocation. The operation was performed by single surgeon and by the same method.
Dr. Sonali,
Yes, sir. So hang.
what happened?
तो वो स्लाइड थोड़ा हैंग हो गई है.
Okay. Don't panic. Try to fix.
Sir, shall I continue?
Yes, Sonali, you can continue, but we need to see your screen. We need to see your slides. Otherwise, it won't be possible. Sonali, try this. Hello, Sonali.
Yes, sir. Sir, actually slide hang हो गया.
हैंग हो गया, कोई बात नहीं. ऐसा करो कि अपना जो तुमने स्क्रीन शेयर किया हुआ है उसको स्टॉप करके दोबारा से शेयर स्क्रीन करो और दोबारा से प्ले करो.
जी सर, जी सर. जी sir, now it is visible.
Yes, Sonali, continue.
So methodology part, standard pre-anesthetic assessment was done and procedure was explained to the patient. The same anesthesia protocol was also used in the two groups. Volume expansion by 3 ml per kg of isotonic crystalloid before anesthesia induction. Pre-medication with IV ondansetron 0.1 mg per kg, IV glycopyrrolate 0.01 mg per kg, IV fentanyl 1 to 2 micrograms per kg, and midazolam 0.05 mg per kg 3 to 5 minutes before intubation. Induction was done with propofol 2 mg per kg and atracurium 0.5 mg per kg. Intubation was done using Macintosh laryngoscope and appropriate size endotracheal tube. Oropharyngeal packing was done. Maintenance was done with nitrous oxide and oxygen in ratio of 50 to 50, isoflurane and injection atracurium 0.1 mg per kg. At the end of the surgery, muscle relaxant was reversed with neostigmin 0.05 mg per kg and glycopyrrolate 0.01 mg per kg. A 30-degree reverse Lindbergh position was also used for all patients during surgery, and epinephrine 1 and 2000 soaked pledges were used and used according to the surgeon's satisfaction. Parameters studied are duration of surgery defined as the time between delivering the patient to the operating room and completion of surgery, pre and post surgical hemoglobin level, heart rate and blood pressure every 15 minutes, Quality of surgical field based on Bazard scale and surgeon satisfaction level based on Likert scale were recorded in both groups. Likert scale was scored from 1 to 5, very bad, bad, average, good, and excellent. And Bazard scale was as follows: 0 for no bleeding, 1 for minor bleeding, and that does not need suctioning. 2 for minor bleeding, that needs infrequent suctioning. 3 for minor bleeding, that requires repeated suctioning when surgical field is threatened by bleeding for a few seconds after removing the suction, or for moderate bleeding that require repeated suctioning when surgical field is threatened by bleeding directly after removal of suction, and 5 for severe bleeding that require continuous suctioning when bleeding severely threatens the surgical field and severity of the bleeding is greater than the extent that can also be resolved by suctioning. Results: a total of 60 patients completed the study. 21, that is 25% patients had chronic sinusitis without polyposis, whereas 39 had chronic sinusitis with polyposis. 30 cases were in tranexamic acid group and 30 in the clonidine group. Regarding demographic characteristics, baseline hemodynamic data and preoperative hemoglobin level, no significant difference was recorded between the two groups. Based on chi-square test, the number of chronic polyposis and chronic sinusitis cases did not significantly differ between the two groups. The mean pre and post-operative hemoglobin level also revealed no statistical meaningful difference between the two groups. The difference in hemoglobin level drop was again insignificant between the two groups. Comparison of mean arterial pressure and heart rate between the two study groups demonstrated no statistically significant difference. The quality of surgical field based on Bazard scale showed no significant difference between the two groups at 30 minutes, 60 minutes, 90 minutes, and 120 minutes time point. Surgeon satisfaction of surgical field during surgery also showed no significant difference between the clonidine and tranexamic acid group based on the 5-point Likert scale. Based on Bazard scale, surgical field quality was associated with systolic blood pressure only at the 30-minute time point. No association was found between either systolic or diastolic blood pressure at the other time point. Moreover, the mean anesthesia time and mean surgical time were not significantly different between the clonidine and tranexamic acid group. Comparison of demographic and perioperative data between the two studied groups. Comparing mean age in tranexamic acid group was 43.41 and in clonidine group was 39.86. BMI in tranexamic group was 24.29 and in clonidine group 26.59. Pre-op hemoglobin 14.31 tranexamic group and clonidine group 14.27. Post-op hemoglobin 13.21 in tranexamic group and clonidine group 12.67. Duration of surgery 140.45 minutes in tranexamic group and 143.28 in clonidine group, and hemoglobin drop was 1.14 in tranexamic group and clonidine group 1.4. Surgeon satisfaction based on Likert scale was compared in tranexamic acid group and clonidine group. Discussion: blood loss reduction and increase of visibility of the surgical field are of great importance to surgeon to increase the success rate of endoscopic sinus surgery. Anesthesiologist has a major role in improving surgical condition to make visualization of the surgical field better. In this way, surgical complications such as optic nerve or orbit damage, CSF leakage, or even internal carotid artery injury can be further avoided, which could lead to reduced surgical costs and lower rates of anesthesia-related comorbidities. Clonidine and recent study observation. Clonidine is an alpha-2 blocker that reduces blood pressure both centrally and peripherally. It increases coagulation due to platelet activation, thus improving surgical field visualization by reducing bleeding. As a central effector, clonidine can reduce post-operative pain, nausea, vomiting. It also lowers systemic blood pressure by constriction of peripheral blood vessels and so decreases the blood flow to the nasal mucosa. In a comparative study by Cardassian et al., a better surgical field and lower morbidity of patients undergoing PES was reported in the clonidine group. And similarly, in a Turgal et al. Also showed that pre-medication with clonidine provides a more vivid view of the surgical field, decreasing blood loss while significantly increasing surgeon satisfaction when PES is performed due to nasal polyposis. Tranexamic acid, the positive role of Trenexa has been proven in the treatment of digestive and urinary system bleeding, primary amenorrhea, thrombocytopenia, hemophilia, and von Willebrand disease. Tranexamic acid prevents fibrinolysis by blocking the lysine binding site of plasminogen to fibrin. The study by Coy et al. Showed that during bimaxillary osteotomy, a single IV dose of Trenexa 20 mg per kg administered preoperatively resulted in significant reduction of intraoperative bleeding. Same results were reported by Efterhan et al. In orthognathic surgeries. However, use of 0.05% Trenexa in an irrigant fluid demonstrated no meaningful difference in intraop bleeding compared with placebo during orthognathic surgeries. In contrast, the administration of 15 mg per kg IV Trenexa significantly reduced intraop bleeding volume compared with placebo in the study by Nui et al. No thrombotic event or alteration in coagulation parameters were encountered. Post-operative no meaningful difference in the rate of nausea vomiting was mentioned between the two groups. Conclusion: pre-medication with oral clonidine and IV tranexamic acid has the same effect on bleeding during PES and surgical field visualization and surgeon satisfaction. I have included references right.
Nice presentation, Dr. Sonali. Over to our judges.
Madam?
Yeah. Nice presentation, Dr. Sonali. It was disturbance in between, but overall it was okay. And hello.
Ji, ma'am.
Okay. You have chosen 2 drugs which are of different groups. Tell me the mechanism of action of both the groups.
Ma'am, I've taken 2 drugs from different groups as Trenexa reduces bleeding by antifibrinolytic mechanism, and clonidine is a centrally acting alpha-2 blocker which reduces blood pressure, and also it has little antiplatelet action, so it has a platelet adhesion activity, so it will induce coagulation also, so bleeding is reduced. I have taken tranexamic acid as studies are done less on tranexamic acid group, and clonidine is a drug on which study has been done significantly. So I was trying to just compare if tranexamic acid can be used as a pre-medication.
Okay. The dose you have chosen were comparable? One was oral, one is IV.
Ma'am,
yeah.
Oral clonidine, because ma'am, I'm using. Sorry, ma'am, I can't get your question.
नहीं, doses जो आपने ली, एक oral and एक IV, तो both were comparable. Hello. Hello, Sonali.
Ji, ma'am.
Okay. Which drug was better in your sense?
Sorry, ma'am, which drug was?
कौन सी ड्रग आपको ज्यादा बेटर लगी, क्लोनिडीन और ट्रेनेक्सामिक एसिड?
Actually, on comparison, both were found to have same effect. मतलब tranexamic acid was also giving us quite good results, and clonidine group was also giving quite good results. But with Trenexa, it is better because we can give it during operative period. Intraoperatively, we are giving it after taking the patient in operation theater. But with clonidine, we have to give it 2 hours before, and then we have to monitor for that 2 hours also. So if patient develops sudden hypotension or for that reasons.
Okay, that means tranexamic acid is much better than clonidine. What was your conclusion?
Ma'am, considering the study and everything, they were both same, but
आपका फाइनल क्या रिजल्ट निकला? What you concluded?
ma'am, both drugs were equally effective, and none was considered to be superior, but just it can be given IV Trenexa after in operation theater.
Okay. Okay. Thank you. Over to Dr. Deepesh.
Dr. Sonali, how did you assess the blood loss in this in this study?
Blood loss, I have considered the suction, which was the surgeon did repeated suctioning or not, and the soaked cotton swabs or mops which were there, and the wash was considered, which was given.
Okay. Okay, the time is up. You can call the next candidate.
Yes, sir. Thank you, sir. The next candidate is Dr. Vinay Yadav, second year, Allen Medical College, Bhopal. Dr. Vinay Yadav, unmute yourself and start sharing your screen.
Hello.
Yes, Dr. Vinay.
Hello. Good evening. Good morning.
Good morning, Vinay. Vinay, just go to the first slide.
Yeah.
Yes. And make it full screen. Yes. Now you can proceed with your presentation. Your time starts now.
My title is Observational Study of Perfusion Index as Predictor of Hypertension Laparoscopic Surgery Following Induction by Propofol. Under the guidance of Dr. Nupur Chakraborty, Head of Department, Dr. Sudan Saxena, Senior Resident, Department of Anesthesia, Land Medical College. Introduction. Hypertension during propofol induction is a common problem. Perfusion index is an indicator of system vascular resistance. Is said to be predictive hypertension following GA and subarachnoid blood. Calculating using infrared spectrum as a part of plethysmography. Wave processing. Simple, cost-effective, and non-invasive method of assessing perfusion index determined by the percentage of pulsatile to non-pulsatile blood flow in the extremities. Perfusion index is useful in monitoring depth of anesthesia, hypothermia, successful epidural placement in parturient, adequate relief from uterine obstruction, response to fluid therapy in critically ill intraoperative patient, and adequacy of circulation in ward. Vegetation reflecting higher baseline PI associated with reflection in blood pressure following anesthesia. Aim and objective to evaluate of PI can predict hypertension following propofol induction to find out a cutoff value beyond which hypertension is more common. Methodology. Sample size 60 patients taken belonging to ASA grade 1 and 2 undergoing laparoscopic surgery under general anesthesia, excluding criteria patient with hypertension, vasoactive medication, difficult airway, and pregnancy. Pre-medication consists of glycopyrrolate and midazolam and related 150 mg on the morning of scheduled surgery. Investigation, PI, heart rate, blood pressure, and oxygen saturation every 5 minutes, baseline to 10 minutes following induction of anesthesia with a titrated propofol and after endotracheal intubation. Hypertension was defined as a fall in systolic blood pressure by greater than 20% of the baseline, mean arterial pressure less than 60%, severe hypertension, mean arterial pressure less than 55% was treated. Electrocardiograph, non-invasive BP, pulse oximetry were recorded. Baseline value, heart rate, systolic blood pressure were recorded. IV infusion of renal lactate was started at 100 ml per hour. IV fentanyl 2 mcg per kg was administered followed by propofol injecting slowly at a rate of 10 mg per every 5 seconds. Titrated of response to verbal communication vecuronium 0.1 mg per kg IV was administered. The parameter was recorded every 5 minutes until 5 minutes. The lungs were ventilated with 100% oxygen for 5 minutes before the trachea was intubated with the appropriate size endotracheal tube by a concerted anesthetist. Maintenance of anesthesia was established with 50% nitrous oxide oxygen along with the isoflurane 0.6%. Hemodynamic parameters were recorded at 1 minute interval to 10 minutes after intubation. Hypertension was defined as a drop in systolic blood pressure less than 30% of baseline, absolute mean less than 60%, less than 60 mmHg. Mean MAP less than 55%, less than 55 mmHg. Severe hypertension was treated immediately. Intravenous fluid administered 10 ml per kg and mefenterpine 6 mg IV bolus. Bradycardia was defined as heart rate less than 50 beats per minute or decrease less than 30%. Below baseline value which are lower was treated atropine 0.6 mg IV bolus. The incidence of hypertension was calculated in 2 shots 5 minutes after induction anesthesia. Effect of the induction agent. The first 15 minutes after induction. Primary outcome, a cutoff value of baseline perfusion index below which hypertension at 5 minute induction could be predicted. Secondary outcome, positive and negative productive value at 15 minutes. Result baseline characteristic, age 31.26 plus minus 90, weight 58.46, sex male female ratio 60 and 40, ASA grade 1 and 2, 65 and 35, systolic blood pressure 121.68 plus minus 36.78, diastolic blood pressure 76.58 plus minus 11.32, mean arterial blood pressure MSG 86. PI index 1.76 plus minus 1.44. First, within 5 minutes after induction, the incidence of hypotension with systolic blood pressure criteria 28%, with mean arterial blood pressure criteria 30%. Incidence of severe hypotension 80%. ROC curve sensitivity is y-axis, 1 minus specificity is x-axis. Baseline PI index less than 1.05 predictive incidence of hypotension at 5 minutes. Sensitivity high, negativity predictive value, and moderate is society. Result overall association of PI and hemodynamic variable recorded a weak negative correlation with systolic blood pressure, diastolic blood pressure, mean arterial blood pressure, and heart rate. However, systolic blood pressure was only independent predictive value with correlation of coefficient of R minus 0.5 to 8, P less than 0.001. Discussion and our observation support with concept as there was a correlation with PI and incidence of hypertension. PI less than 1.05 was associated with a higher incidence of hypertension. Baseline PI was not found to be associated with hypotension via mean arterial pressure criteria, but show a weak to moderate significant negative correlation with systolic criteria. Defining hypotension is a function of baseline. Systolic blood pressure is probably physiological in this context, as if perfusion index is a derivative of vasoconstrictive state, whereas absolute mean arterial pressure does not consider only operative vasomotor tone of the patient. Sukia et al. Sukia et al. 2010 show negative association found low baseline PI to be associated with greater reduction in mean arterial pressure after propofol waged induction. Compensatory vasoconstriction due to relative hypovolemia may result in low PI value, and propofol by virtue of vasodilatation can cause hypertension in such patients. Difference of magnitude of correlation between first 5 and 15 minutes probably due to the hemodynamic effect of endotracheal fluid causing BP to normalize, thus reducing the incidence of hypertension. Clean et al. In 15 reported similar observation. Baseline PI less than equal to 0.82% predicting of hypertension in response to progressive fluid withdrawal by a continuous veno-venous hemodilation in patients with acute kidney injury. ROC analysis in our work predicted to hypertension below the threshold of 1.05, which is close to the value obtained by one guidance criteria, 2013. Mechanism of propofol-induced hypertension involve action on autonomic nervous system with effect the sympathetic as well parasympathetic components. There is also evidence of the direct effect of propofol to endothelium-dependent and endothelium-independent pathway. Therefore, it may be safely stated that PI depend on systolic blood pressure, and their associated bimodal low PI was present with both high and low systolic blood pressure. Also, PI can predict hypertension better based on baseline systolic blood pressure than mean arterial blood pressure. Finally, if a perfusion index is greater than 1.05 at baseline, 98% patient will not experience significant hypertension. Reduction in systolic blood pressure less than 30%, 5-minute induction of anesthesia with propofol. Conclusion: perfusion index could be predict hypertension following propofol induction, especially before endotracheal intubation. Very high negative predictive value. Thank you. Thank you for patience.
Thank you, Dr. Vinay. That was a very new topic and a very nice presentation. Over to our judges.
Dr. Vinay, what do you mean by perfusion index?
Perfusion index.
How do you define it? Yes.
Yeah.
How do you define perfusion index? Hello.
Hello, Dr. Vinay. Hello.
Hello.
Dr. Vinay.
Hello. Can we hear?
Yeah.
Yes, we can hear you. Hello, Dr. Vinay. Hello. Hello, Dr. Vinay. Hello, Dr. Vinay. Sir, what should we do?
Let's wait for 50 seconds more.
Yeah, I think
Yes,
network
sir.
disturbances.
There might be some problem, internet problem over there.
He's not also in the participant list now. I think
Okay.
he's having some
He has
technical.
left. It's maybe.
Should we start next?
Okay. For the next candidate. Himanshu, you are not audible.
Sir, Dr. Yogita is the next
Okay.
participant.
Okay.
She's from People's College of Medical Science, Bhopal. Yes, Dr. Yogita.
Yeah, yes, sir. Yes, sir.
Yes, you can start sharing your screen now.
G. Am I audible?
Yes, Dr. Yogita, you're audible.
Am I visible?
You're also visible. Your screen is also visible. Make it full screen, and now you can start with your presentation. Time starts now.
A very good morning to everyone. Myself, Dr. Yogita Sote from Bhopal. The topic is effect of relaxing music on anesthesia in patients undergoing abdominal surgeries under general anesthesia. To introduce music therapy, an innovative approach that has proven effectiveness in many medical conditions, also beneficial in managing surgical patients. Why music? It is because it is older than language, and its therapeutic contribution is a non-pharmacological, inexpensive, and safe technique. The effect of music on hormonal secretions and nociceptive reflexes. Surgery and anesthesia are generally unpleasant experiences for patients and are the source of stress and anxiety that can hinder the desired therapeutic goal. Despite the long history of beneficial use of music for therapeutic goals, the harmless tool is not yet well exploited in the daily anesthesia practice, reflecting the lack of recommendations. This paradoxical situation justifies the need for the further studies encouraging the clinical use of music therapy in this stressful field. Furthermore, one of the frequent and serious mishaps of perioperative period is awareness during general anesthesia, which could have a better outcome with music therapy. The aim of my study is to evaluate the effects of music therapy under general anesthesia on patient satisfaction, anxiety levels, intraoperative awareness, and the intensity of pain during recovery from abdominal surgery. Methodology: after obtaining institutional ethics committee approval and patients' informed written consent, this prospective randomized study was conducted in the operating theatre of People's College of Medical Sciences, Bhopal, from June 2021 to September 2021. All patients scheduled for abdominal surgery age 18 to 50 years. Exclusion criteria were cognitive or psychiatric disorders, hearing impairing diseases, and chronic treatment with analgesics. Patients were randomized into two groups, Group A and Group C. The patients operated on during even days were included in the experimental group, while the patients operated during odd days were included in Group C. In the operating room, all patients had standard monitoring like electrocardiogram, non-invasive blood pressure, and pulse oximeter. All patients had a headphone linked to an MP3 player with different types of music samples to satisfy all tastes. Patient choice was reflected in all cases. Instrumental music was chosen by the anesthesiologist involved in the study for patients who had no particular preference. Anesthesia induction was carried out by intravenous injection of fentanyl at a dose of 1 to 2 microgram per kilogram of body weight, propofol titration, and eventually atracurium at a dose of 0.15 milligram per kilogram of body weight if a tracheal intubation was considered. Anesthesia was maintained by isoflurane in a mixture of 50% oxygen and 50% air. The music was started immediately after induction anesthesia for Group M patients, and the volume was set at 65 decibels. Music was maintained throughout the surgery until the end of the intervention. Anticipation of analgesia was made by 1 gram of paracetamol infusion 30 minutes before the end of the surgical procedure. After awakening and tracheal extubation, patients was transferred to the post-anesthesia care unit. We collected socio-demographic parameters, hemodynamic parameters at the entrance to the operating room immediately after induction of anesthesia and every 15 minutes until the end of the procedure. We also assess the quality of awakening by Richter scale, patient pain on awakening by visual analog scale, and patient satisfaction by Ivan-G scale, and intraoperative awareness 24 hours after surgery. The primary endpoint was patient satisfaction 24 hours after surgery. The secondary endpoints were intraoperative hemodynamic stability, intraoperative awareness, postoperative pain and anxiety. Categorical variables were investigated by chi-square test, numerical variables by ANOVA. The significance level was set at 0.05. In this study, 60 patients were included and assigned to 2 groups of 30 patients. These are the characteristics of my group of group M and C as per the patients and as per the surgery, duration of surgery and duration of anesthesia. The frequently chosen music by our patients was classical Indian music, Bollywood and Western music also chosen by some patients, and the anesthetist chose instrumental music for only 4 patients. The comparison of the 2 groups, this is the comparison between the 2 groups. For systolic blood pressure, you can see here in group C patients, there is so many ups and downs in systolic blood pressure, while there is no ups and downs for AM group. This is the diastolic blood pressure comparison between 2 groups. Here also you can see the ups and downs in group C, and while there's no ups and downs for group M. This is the pulse rate figure showing the pulse rate between the 2 groups, but here it is insignificant. This is a table showing different types of study parameters as per Richter scale less than 5. Calmness is more in group M 77.14%, it is agitation is high in C group 55.7%. VAS is less than 3 in M group 51.42%. Patient satisfaction is higher in M group 81.42%. Intraoperative awareness is also higher in group C, that is 11.42%. To discuss, we tried in this study to evaluate its under anesthesia effect on patient satisfaction, reduced anxiety levels, intraoperative awareness, and density of pain during recovery from abdominal surgeries. Our study shows a significant improvement in patient satisfaction in group M. These all were the studies according to which we conducted this study in our institute. In our study, the recovery quality was better in the intervention group, who showed a significant reduction in the level of stress and anxiety. The mechanism of action of music therapy on pain is multifactorial, involving attenuation of conduction in afferent fibers, mnemonic encoding, stimulation of endorphin production, and action of psychotherapy. To conclude, music therapy, an innovative approach that has proven effectiveness in many medical conditions, is also beneficial in aging surgical patients. This is a Richter addition score to grade the group M and group C patients. These are the references of my studies. Thank you and have a good day.
Very nice presentation, Dr. Yogita.
Thank you
Over
so
to the
much, sir.
judges.
Dr. Yogita,
Yes, sir.
what do you think
Good
could be
morning,
the
sir.
reason? Good morning. What do you think could be the reason for very stable hemodynamic in the patients who are given music therapy?
Sir, actually, music therapy works on the subconscious mind. Actually, when we take an example, if we are stressful and we think what we are so depressed, we just listen to music, to the relaxing music, and we find we suddenly come out or overcome from the depression area. Just same mechanism or here is on patient subconscious mind, sir.
So it has got some effect on different areas of the brain or some specific area of the brain?
Yeah, sir. Different areas of brain, yes, are definitely there, but it's very difficult to express me, sir. What are the areas which involve in the mechanism when patient listening music while he or she is anesthetized?
Okay, ma'am.
Is there any
Good morning, ma'am.
hormone secretion correlation between music therapy and anxiety?
Yes, ma'am. Because what we its music is definitely work on some hormone secretion. What hormone secretion is definitely I don't find in my study, but there is some nociceptive reflexes also which involve in the patient anxiety as well as pain.
Okay, it was nice presentation and good topic.
Thank you so much, ma'am.
Yeah, what was your method of doing? Means before means in pre-operative. Before
during PSC, we just explain the patient what music you like, when you like, then he or she replied me कि मैम मुझे भजन पसंद है ऐसा, तो हम उसके वो मैम नोट कर लेते हैं, और जब वो एनेस्थेटाइज हो जाता है तो फिर हम yes ma'am, yes ma'am.
Okay, and which song he want to listen?
मैम कुछ पेशेंट्स से तो बोला था मुझे भजन पसंद है, और जो यंग पेशेंट है जो स्पेसिफिकली लेप्रोस्कोपिक सर्जरीज के लिए आते हैं लैब पॉली के लिए, उन पेशेंट्स ने बोला था कि मुझे सिर्फ बॉलीवुड का रिमिक्स म्यूजिक पसंद है, तो उसको मैंने डाउनलोड किया था मैम नेट पे से, और उसको फिर अपने फोन पे लगाया था.
आपने कब से कब तक इनको सुनाया?
मैम मैंने जब पेशेंट को ट्यूब डाल दी, सर्जरी जस्ट शुरू होने वाली थी, उसके पहले मैंने उसको ईयरफोन्स लगा दिए अपने मोबाइल से, और उसके बाद जब सर्जरी खत्म होने वाली थी और मैं पेशेंट को एक्सट्यूबेट करने वाली थी, उसके दौरान मैंने उसको निकाल कर रख दिया था. तो मैंने इसका टाइम नोट कर लिया था, और पेपर पे उसकी हेमोडायनामिक स्टेबिलिटी पूरी लिख रही थी.
Okay, good.
Thank you so much, ma'am. Have a good day, ma'am.
Okay.
Dr. Yogita,
Thank you.
instead of headphones, you should have used loudspeakers so that surgeons can also be benefited with it.
Thank you so much.
Thank you, sir.
Thank you so much. Thank you so much, sir.
Next will be Dr. Deepali Mandloi. Dr. Deepali.
Good morning, everyone. Am I audible?
Yes, Dr. Deepali, you're audible. You can share your screen with us now.
Okay. Is my screen visible?
Yes, your screen is visible. Dr. Deepali Mandloi is third year MGM Medical College, Indore. Dr. Deepali, you can start with your presentation.
Good morning, respected judges and everyone. The topic of my paper presentation is comparison of efficacy of dexmedetomidine as an adjuvant to 0.5% ropivacaine versus 0.5 ropivacaine in intraclavicular brachial plexus block for distal arm surgeries. My study is done under the guidance of Dr. Arora sir, the head of the department, my guide Dr. Basant, and my co-guide Dr. Pooja ma'am. Aims and objective. My primary objective was to compare the onset and duration of analgesia between these two groups. Secondary objectives were to evaluate the hemodynamic variations, rescue analgesia requirements, and complications, if any. Coming to the introduction, peripheral nerve block is an essential tool in the field of pain management. Long-acting blocks with local anesthetics, such as ropivacaine or bupivacaine, are beneficial for improved post-operative pain therapy, but the duration of sensory block is still not sufficient to avoid the post-op use of opioids. The aim of prolonging the duration of peripheral nerve block is to treat the post-operative pain, which is a key issue in regional anesthesia. Successful pain management enhances the early ambulation and reduces the hospital stay. Alpha-2 receptor agonists are increasingly being used in anesthesia for their sedative analgesia and cardiovascular stabilizing effect. Dexmedetomidine is a highly selective, newer prototype of alpha-2 agonist of approximately 8 times being more potent in comparison to clonidine. It has analgesic, sedative, antihypertensive, and anesthetic sparing effects when added to local anesthesia for regional or peripheral nerve block. It prolongs the duration of the block and duration of analgesia. The materials which are used is 0.5% ropivacaine, injection dexmedetomidine 50 mics in 0.5 ml, peripheral nerve stimulator, anesthesia workstation with supply, oxygen supply, multi-para monitor with BP, heart rate and SpO2 monitoring, 20 gauge IV cannula, IV fluids and emergency drug tray. The study was being conducted in the Department of Anesthesiology in MY Hospital, Indore. The type of study is randomized control study. The sample size were 30, 15 in each group, 15 in the group of ropivacaine and 15 in the group of ropivacaine plus dexmedetomidine. The scale was visual analog scale. The inclusion criteria were ASA grade 1 and 2, patient aged 18 to 60 years, patient undergoing elective surgery in hand, wrist, and forearm. Duration of surgery is 1 to 2 hours. Exclusion criteria were patient refusal, patient having hypersensitivity towards local anesthetic drugs, patient receiving alpha adrenergic antagonist, patient with a psychiatric or neurological deficit, patient with head injury. Statistical analysis, appropriate software, that is SPSS 2020, was used for both qualitative and quantitative variables. P-value less than 0.05 was considered as a statistically significant. Procedure, after selecting the patients, they were randomly allocated in two groups by CHET method. 0.5 ropivacaine 30 ml in one group and 0.5 ropivacaine plus injection dexmedetomidine at a dose of 1 mg per kg was there in the second group. A thorough evaluation was carried out and required clinical and lab investigations were done accordingly. Each patient was taken in OT after taking informed consent, connected to multi-para monitor. Vital signs were recorded. IV access was secured with 18 gauge or 20 gauge cannula and appropriate IV fluids were started. Patient were received nerve stimulator guided infraclavicular brachial plexus block via landmark technique. So the coracoid process was filled and 2 centimeter medial and inferior to the coracoid process was my entry point. Assessment, after the procedures, as the sensory and motor block was assessed every 15 minutes till the surgery continued, then 4-hourly post operatively till the motor block was worn off. The sensory block was assessed by cold test swab and pinprick test. And it was graded as 0, 1, 2. 0 means normal sensation, 1 is loss of sensation to pinprick, 2 is loss of touch sensation. The motor grading was done using modified Bromith scale. 0, no movement in wrist, fingers and elbow. 1 is finger movement only. Second is flexion of the elbow against gravity. Block was considered as successful when sensory block is 2 and motor block is 0 within 30 minutes after injection of local anesthetic. Intraoperatively, vitals of the patient and visual analog scales were recorded. Post-operatively, the first rescue analgesia was given when visual analog scale was more than 3. Post-operative hemodynamic changes were also seen like BP, pulse rate and SpO2. So these were my observation and results. As we can see in the diagram, the mean onset time for sensory blockade was around 16.73 minutes for ropivacaine group and 14.87 minutes for the dexam group. So dexmedetomidine group had earlier onset. Also for the motor blockade, the dexmedetomidine group has earlier onset of 17 minutes as compared to 19.5 minutes in the ropivacaine group. Also, the mean duration of analgesia for the ropivacaine group was 409 minutes, that is approximately 6.8 hours with the ropivacaine group, and with the dexmedetomidine group, it was 639.9 minutes, that is approximately 10 hours. So the duration of analgesia for this RD group, that is dexmedetomidine group, was around 10 hours. Discussion, all the patients were comparable in regards to their demographic data. Dexmedetomidine group had quicker onset and the longest duration of sensory and motor blockade as compared to ropivacaine group. Dexmedetomidine group, but it has a higher incidence of bradycardia. In my study, there were 2 patients which were managed by injection atropine 0.5 mg, and hypotension. There were 4 patients which were managed by IV fluids and ephedrine 10 mg bolus when there was no response to fluid administration. Post-operatively, VAS score was lower in dexmedetomidine group than that in the ropivacaine group. Any intraoperative or post-operative complications such as pneumothorax, vascular puncture, somnolence were not recorded. Conclusion, our study provides a strong evidence that dexmedetomidine as an adjuvant to 0.5 ropivacaine is effective in lengthening the duration of analgesia with minimal side effects. It was associated with prolonged onset and duration of sensory and motor blockade. Thirdly, there is lesser consumption of post-op rescue analgesia in this dexmedetomidine group, and it can be safely used and effectively and safely used to improve the quality of regional anesthesia. These are my references. Thank you.
Over to our judges.
Dr. Sonali, Dr. Deepali.
Good morning, sir.
Good morning. Why did you choose intraclavicular nerve block over supraclavicular nerve block,
Sir,
which is
because
equally
in
effective?
our institution, there are less studies being done on the intraclavicular block. Also, I wanted to perform intraclavicular block. That's why I chose.
Then how did you take care of the tourniquet pain of the patient? Because in every surgery of forearm, tourniquet is mandatorily, they apply tourniquet, definitely. How did you take care of that tourniquet pain?
Sir, In my patients, there were, sir, T2 block was being performed, but it was tourniquet, matlab T2 block.
Sorry, क्या हुआ था?
Sir, I didn't perform T2 block, but there were no, sir, as such, I didn't find any patient having pain for tourniquet.
Okay, what is the maximum
Mostly
duration of action?
the maximum duration of action for the dexmedetomidine group was approximately 10 hours. I went after the surgery was of 1 to 2 hours. In 2 hours, the surgery was completed, and after that, I visited 4 hourly. So approximately in 10 hours, the effect of that dexmedetomidine group was worn off.
So why do you want to give a dexmedetomidine? Why don't you want to give anesthesia for 10 hours when the surgery lasts for 1 to 2 hours?
So for post-op pain relief, so that the post-op opioid consumption will be decreased and the patient can have early ambulation and early
So
mobilization.
doesn't it often the pain which is associated with compartment syndrome, which is very much required by the orthopedicians? Compartment syndrome को तो mask कर देगा अब in case जैसे होता है forearm surgery. Don't you think this is a disadvantage with dexmedetomidine or for longer duration of anesthesia or analgesia?
Yes, sir, it is a limitation and it may be a disadvantage.
Matt?
Okay, Dr. Deepali.
Good morning, ma'am.
Good morning. How Dexmed adds Mpisacon to improve the duration of action?
Ma'am, basically it has got two actions, the central mediated action and a peripheral mediated action. The central mediated action means it releases, it decreases the sympathetic outflow and it blocks the nociceptive transmission. And by peripheral, it has also in studies, it has got a peripheral mechanism. It inhibits the compound action potential and overall it inhibits the it causes direct inhibition in the nerve transmission.
Okay. Did you find any side effect of Dexmed?
Yes, ma'am. Basically, bradycardia and hypotension that were also very in only 2-3 patients I got. So hypertension were managed with the IV fluids, and if not responsive, I have given 10 doses.
Okay.
And bradycardia was managed with injection atropine 0.5 mg.
Okay. What other drugs can be used in place of Dexmed?
Ma'am, in place of Dexmed, we can use clonidine also. Magnesium sulfate can also be used, ma'am. And soda bicarb can also be used.
Okay. Okay. Thank you.
Thank you so much, ma'am.
Next, please.
Next participant is Dr. Kamna Dubey, 2018 batch, MGM Indore, third year. Dr. Kamna, you can share your screen. You can unmute yourself.
Good morning. Am I audible?
Yes, Dr. Kamna, you're audible.
Yes.
Go to the first screen and
Yes.
slide share.
Good morning, respected judges and everyone. My title is a randomized prospective control study of effect of thoracic epidural with 0.2% ropivacaine on propofol consumption in breast surgeries on the basis of BIS monitoring. My guide is Dr. K.K. Arora sir, and my co-guides were Dr. Parul Jain ma'am and Dr. Deepali Varicha ma'am. Introduction. The combination of epidural anesthesia with general anesthesia technique has been widely used for the management of major abdominal and thoracic surgery for decades. Epidural block reduces the sedative hypnotic requirement in general anesthesia through various mechanisms. The BIS spectral index was proposed by Aspect Medical System in 1994 to monitor level of consciousness among the patients receiving general anesthesia and sedation. This algorithm processes the EEG in near real time and computes an index value between 0 and 100. A patient is considered appropriately anesthetized when the value is between 40 and 60. This is the picture showing BIS monitor applied over the patient. Ropivacaine is an amide local anesthetic, a lever enantiomer with relatively less cardiovascular and CNS side effects as compared to bupivacaine. In our study, we are evaluating the clinical effects of the epidural ropivacaine on the requirement of propofol based on bispectral index. This study is testing the hypothesis that epidurally administered drugs can reduce the general anesthetic requirement. And in our study, we used BIS monitoring for confirmation of this hypothesis. Aims and objectives. The primary objective was to study the effect of thoracic epidural on the dose requirement of propofol on the basis of BIS monitoring. The secondary objectives were: first, added analgesic, that is injection fentanyl requirement in both the groups; second, total muscle relaxant, that is injection atracurium requirement in both the groups; and third, recovery sedation score of patient in both the groups. Methodology. The study design was randomized prospective control study, which was performed in MGMMC Indore. 60 patients were randomly allocated in two groups with 30 patients in each group by CHIT method. Group C, control group; Group T, thoracic epidural group. Inclusion and exclusion criteria. Inclusion criteria was ASA physical status 1-2 and patients of age group between 18 to 65 years. Exclusion criteria: patient refusal, any contraindication to regional anesthesia, patient who had undergone thoracic spine surgery, pregnant and lactating females, obese patient with BMI more than 35 kg per meter square, or patient with any other comorbidity. Monitoring and sedation, BIS monitor and Ramsay sedation score. Procedure. After ethical committee approval and taking written informed consent with the patient, patient was taken into OT and connected to multipara monitor. Group C was induced with general anesthesia according to standard protocol, and Group T induced with thoracic epidural plus general anesthesia. Thoracic epidural was performed with an 18-gauge 2E needle through T5-T6 interspinal space via median approach with patient in sitting position under all aseptic precautions. Epidural space was identified with loss of resistance technique. Catheter was fixed with the 5 cm mark of catheter in epidural space. After negative aspiration, test dose was given. Supplementation done slowly with 0.2% ropivacaine, 8 ml. BIS monitor was then connected. Scores and vitals were recorded. Assessment. Propofol infusion at the rate of 50 mics per kg per minute in both the groups was started after induction for maintenance along with oxygen, nitrous, 1% isoflurane, and injection atracurium as and when required. If the intraoperative BIS value remained to be above 60 persistently, bolus of propofol at 0.5 mg per kg was given, and if it was remained to be below 44 persistently, propofol infusion was switched off. Vitals were recorded at regular intervals. 10 minutes before the end of the surgery, the propofol infusion was switched off and the amount of drug administered was recorded in both the groups. The patient was then reversed. Statistical analysis. Unpaired t-test was used. This is the picture showing a patient with thoracic epidural placement. Observation and results. This is a bar graph showing comparison of mean propofol requirement between Group C and Group T, which is showing more propofol consumption in Group C than thoracic epidural group. This bar graph is showing comparison of mean analgesic requirement, that was injection fentanyl, between the both groups, which is showing more injection fentanyl requirement in Group C than Group T. This is the bar graph showing comparison of mean total muscle relaxant consumption between the two groups, which is showing more injection atracurium dose in control group than in thoracic epidural group. This bar graph is showing distribution of women according to Ramsay sedation grade. Better sedation scores were observed in patient in which thoracic epidural was placed. Discussion. All the patients were comparable with respect to their demographic profile and duration of surgery. Our study indicated that in patients aging 80 to 65 years, thoracic epidural decreased the intraoperative anesthetic requirement measured on the basis of BIS monitoring. Total propofol consumption was more in Group C than in Group T. P-value was 0.001%, which was statistically significant. Total requirement of muscle relaxant, that was injection atracurium, was more in Group C than in Group T. P-value was 0.001, which was statistically significant. Rescue analgesic was required in Group C, in which duration of surgery was greater than 60 minutes, while no rescue analgesics was required in Group T in similar duration of surgery. Sedation score was better in Group T. Conclusion. It can be concluded from the present study that thoracic epidural block reduces consumption of IV propofol during maintenance phase of targeted BIS monitored patients aged 18 to 65 years, posted for breast surgeries. Second, no rescue analgesic requirement in Group T. 3, total dose of muscle relaxant is less in Group T. 4, sedation score was better in Group T. These are the references of my study. Thank you.
That was very nice presentation, Dr. Kamna. Over to our judges.
Thank you.
Dr. Kamna,
Yes, sir. Good morning, sir.
do you have BIS monitor in your institute?
Yes, sir. We have, sir.
How do you measure?
Sir, we connect the gel electrodes which are available with the BIS monitor. These are applied on the forehead of the patient. Then, so there are 4 electrodes, 1, 2, 3, 4, and the order of placement is given on the monitor, how to place it. Then, sir, score comes. When the monitor is connected to the patient, score comes. If the patient is awake, sir, then the score is approx 90, 100, around this.
Okay.
And when the patient is anesthetized, slowly, sir, scores come down. 80, 70,
So what
60.
is the adequate score for general anesthesia?
Sir, it is between 40 to 60.
Okay. Madam?
Did you find any complication of thoracic epidural?
Good morning, ma'am. Ma'am,
morning.
no, ma'am. Actually, I was the observer only. When the epidural was placed, I was not present in the OT for the double blinding of the case. Sir, ma'am, immediate complications were not observed. And after post-op also, sir, ma'am, there were no complications were observed. Patient was pain-free and the sedation. Yes, ma'am.
What could be the complication of thoracic epidural?
Ma'am, the most common complication can be dural puncture because generally, ma'am, we perform lumbar epidural, and in thoracic epidural, the space comes very fast, ma'am. So dural puncture is incidence is very is more, and the ma'am unfortunate complication is last. Local anesthetic systemic toxicity if it happens, but the more common is, ma'am, dural puncture.
Okay, thank you.
Okay,
Thank you
next
so much,
candidate.
ma'am.
Our next participant is Dr. Nishtha Sharma, third year, Allen Medical College, Bhopal. Dr. Nishtha, unmute
Yeah,
yourself
good morning,
and share
sir.
your screen. Good morning. Unmute
Am I
your
audible,
screen.
sir?
Yes, you're audible. You can share your screen now.
Yes, sir. Sir, shall I start?
Yes, make it full screen and then start.
Yeah. Good morning, everyone. The topic of my presentation today is observational study on non-rebreathing face mask versus low-flow oxygen supplementation via nasal prongs in additional to non-rebreathing face mask versus high-flow nasal cannula in improving oxygenation in limited resource settings during COVID-19 pandemic. The guide of my research was Dr. Rupesh Jain, professor, and Dr. Hemendra Bharadwaj, senior resident. Introduction. A novel coronavirus is responsible for acute and rapidly evolving illness, which WHO termed as COVID-19 disease. 14% of such patients required ICU and required hospitalization, and out of which 5% required ICU admissions. In this situation, where the oxygen demands and the delivery devices demands increases to rise with limited resources, we performed easy to incorporate techniques. In our ICUs, we used high-flow nasal cannula as recommended by the guidelines for acute hypoxemic respiratory failure in COVID-19 adults. Also, we use non-rebreathing face masks, which can deliver FiO2 up to 80% if there is a proper adequate seal and if the flow rates are adequate. But despite this, there is some entrainment and air leak, and there is mismatch in air and oxygen mixing. So we incorporated additional low-flow oxygen therapy through nasal prongs. This will minimize the air entrainment and increase FiO2. The aim of my study was to compare the effectiveness of NRBM with additional low flow and high flow in improving oxygenation of patients. Objective was to compare the improvement in oxygenation in all the 3 modalities, that is before and after, and then comparing NRBM alone with NRBM with additional low flow and NRBM with additional low flow with high flow nasal cannula. Methods and materials. This is a retrospective study in a 40-bedded ICU in Allen Medical College Research Center. Patients were divided into 3 groups, H, N, NL. H was incorporated with high flow nasal cannula. In group N, the oxygen therapy was through NRBM, and through NL, additional low flow oxygen through nasal prongs were added. The first ABG was taken as the patient was admitted in ICU, and the oxygen therapy accordingly was started. The target SaO2 was taken as 90%. The before and after values in the ABGs, that is SaO2, PaO2, and PaCO2 were taken. Also, the outcome of the patients in next 72 hours, that is requirement of higher modality, that is endotracheal intubation or NIV use, was also recorded. The inclusion criteria was age above 18 years, ICU length of stay more than 3 days, and also the patients who were relatively stable in the defined modality for next 2 hours. Patients whose ICU length of stay was less than 3 days. Also, the patient who was unstable in the current modality was excluded from the study. Statistical analysis was done using JNU PSPP 1.4.1 software and Microsoft Excel 2007. The pre and post ABG was compared using paired t-test in the group, and the unpaired t-test was used to compare the two different groups for the ABG values. The results was written in means plus minus standard deviation, and a p-value less than 0.05 was taken statistically significant. Now the result, a total of 72 patients data was taken from the records, 24 in each group. The mean age of the patients in group N, that is NRBM, was 43.29. In group NL, that is with additional low flow, was 44.08, and in group H was 42.08. This is the histogram representing the age variation. The male is to female ratio in group N was 10 females and 14 males. In group NL was 9 females and 15 males, and in group H was 7 females and 17 males. Now the pre and post values in group N, after applying the paired t-test, the significance, that is the p-value less than 0.05 was taken significant. Only in the value of PaCO2, a significant p-value could be achieved, and there was a significant difference in the mean between before and after the therapy. And there was no improvement in the values of PaCO2 or SaO2. While comparing the pre and post values in group NL, that is with additional low flow, there was significant improvement in PaO2, PaCO2, and SaO2 values with P less than 0.05 in all the three groups. In pre and post modality in high flow nasal cannula group, all the three values, that is PaCO2, PaO2, SaO2, was significant with P values less than 0.05 in all the three parameters. In comparing the group, that is N versus NL, in this, it can be clearly seen that there was significant improvement, that is less than 0.05 in the final values of PaO2 and SaO2, thus making this assembly, that is NRBM with low flow oxygen, a better option. In the group, so that is NL versus H, that is NRBM with low flow versus high flow. High flow was better modality, as in the PO2 final, there was a significant difference in improvement of oxygenation in group with high flow nasal cannula with p-value 0.001 in PaO2 and SaO2, the p-value was 0.001. Also, the need for higher modality was least in the group H, that is with the high flow nasal cannula, that is 20.83, followed by in group NL 45.8, and maximum with group N, that is 62.5. Now the discussion part. In acute respiratory crisis, the peak flow rate requirement of the patient increases, which cannot be provided by NRBM alone. This is a need for higher modality, but due to lack of the devices during COVID pandemic, we incorporated different techniques like adding low flow to the NRBM. This improved the oxygenation. The possible cause could be improvement in oxygenation, could be due to the proper mixing of air and oxygen and a proper venting out of the exhaled gases. Although this assembly of the delivery system was a good choice, but it cannot be said that it is a replacement of high flow nasal cannula. On the other hand, high flow nasal cannula is proven to decrease the death space. Also, it provides a PEEP on higher flow rate and reduces the risk of intubations and ICU admissions. This has been proved by various studies. In our study, we found that using NRBM alone improved PO2 with significant p-values, but did not improve PaCO2 or SaO2. Whereas after additional of low flow, PO2, SaO2 and PaCO2 has significant improvement with p-value less than 0.05. In comparing the oxygenation parameters of group N versus NL, significant improvement in PO2, SaO2 values were noted, which makes this assembly a good alternative as a rescue during the unavailability of high flow nasal cannula devices. Whereas on comparing NL with H, high flow nasal cannula devices proved superior among all the three modalities, and it is a established modality for the patients of acute hypoxemic respiratory failure. The limitation of my study was, as it was a retrospective study, it is difficult to provide conclusive evidences. Due to lack of randomization, there can be a selection bias. In our study, we did not account for the final outcome of the patients. So to conclude, NRBM with low flow can be used as a rescue measurement whenever there is a resource limitation or there is unavailability of devices like high flow nasal cannula, but it cannot be an alternative to the devices, thus making high flow nasal cannula as an established modality for the same. These are my references. Thank you.
Over to our judges.
Nice presentation, Dr. Nisita.
Good morning, ma'am. Thank you, ma'am.
Good morning. What are the criteria of using low flow nasal cannula, NRM and HFNC?
Sir, ma'am, any patient landing into the hypoxemic respiratory crisis can be used, but depending upon their the peak flow rates, this therapy can be decided. If the patient is having high peak flow rates requirement, the high flow is a better device. If the patient's peak flow requirement is less, we can switch to NRBM or NRBM with low flow. So depending upon the peak flow rate requirement, the therapy can be decided.
Depending on SpO2 and respiratory rate, breathlessness.
Ma'am, in our cases, we have taken SaO2 as target of 90%. The second ABG after 2 hours, if the patient was not having a target SaO2 of 90%, we automatically switch the patient to higher modality, and we switch the patient to the higher modality. And ma'am, we exclude the patient if it was before 2 hours. And also we excluded the patients, those who were not in the ICU for more than 3 days.
Okay. And what success you got in both the groups?
Actually, I wanted to see whether the NRBM with low flow oxygen can be an alternative to high flow, but my theory proved wrong. And it cannot be used as an alternative, but yeah, definitely if there is unavailability or there is resource limitation, we can definitely use this thing as this assembly as a rescue, especially during the time of pandemic and COVID situations like that, where we dealt with all the resource limitations.
Okay, thank you.
Yes, ma'am.
Go to Dr. Dekesh.
No questions.
Good morning, sir.
No questions. You can call other participant.
Okay. Thank you, sir.
Thank you, sir. Thank you, ma'am. Our next participant is Dr. Praveen Kumar UK. Our next participant is Dr. Praveen Kumar UK. Praveen Kumar UK, you can unmute yourself now and share your screen. Dr. Praveen Kumar UK. Dr. Praveen, can you hear us?
Call the next part.
Yes,
call the next participant then.
Next participant is Dr. Priyanka Jaiswal. Dr. Priyanka Jaiswal, are you ready with your presentation? Dr. Priyanka Jaiswal,
yes,
unmute yourself and
yes,
start.
I'm audible, sir?
Yes, you're audible.
My screen visible, sir?
Dr. Priyanka is third year. SSCM, Reba. Yes,
My
Dr.
screen
Benjamin.
visible, sir?
Yes, your screen is visible. Make it full screen and start your presentation. Dr. Priyanka, you can start your presentation.
Yes, sir. Yes, sir. Good morning to all respected. This is myself, Dr. Priyanka Jaswal from Department of Anesthesiology, Shamsha Medical College, Reba. I'm going to present a comparative study of Macintosh, McCoy, and video laryngoscope for orotracheal intubation. Introduction. Airway management is considered a major responsibility and vital skill for anesthesiologists. Difficult and unsuccessful tracheal intubation is one of the important cause for morbidity and mortality in both emergency and operative setting. Laryngoscopy play an important role in the administration of general anesthesia and securing the airway in emergency conditions. They range from simple rigid scope to complete fiber optic video devices. In 1941, Robert Miller device is studied to improve laryngoscopy while elevating epiglottis. A curved laryngoscope blade designed by Robert McIntosh in 1943 is provide more room for intubation and manipulation if required. The McCoy laryngoscope is designed to elevate the epiglottis, which is sensitive and require less lifting force during laryngoscopy. The video laryngoscope is a modified laryngoscope that expands the angular view of larynx with the help of an optical system V2, which consists of prism and lenses. There are many methods for assessing difficult intubation like Cormack-Laney grading and total time for intubation. A new objective scoring system has been proposed by Adjan et al. In 1997 as intubation difficult scale score, which is a function of 7 parameters including Cormack-Laney grade. Amson objective. Aim of our study was to compare Macintosh laryngoscope with McCoy and video laryngoscope in terms of Cormack-Laney grade, IDS score, and time for intubation. Our study was a prospective and randomized study which was conducted in Department of Anesthesiology, Shamsha Medical College, Reba. Our study period was April 17 to March 18. Material methods. We included patient with ASA grade 1 and 2, adult patient, while patient reported patient with ASA grade 3 and 4, modified Mullen-Petty grade 3 and 4, mouth opening less than 2 finger, incisor distance less than 3.5 cm, thyromental distance less than 6 cm, history of bleeding dialysis were excluded from our study. After getting clearance from Institutional Ethics Committee, 90 adult patients posted for elective surgery under general anesthesia were randomized equally in 3 groups. 30 participants were allocated in each group. Group 1 Macintosh group, Group 2 McCoy group, Group 3 video laryngoscope group. A thorough examination along with airway assessment was done. All patients were kept nil by mouth for at least 6 hours prior to surgery. Standard monitoring applied to the patient. All patients were pre-medicated with injection glycopyrrolate 0.01 mg per kg IV, injection midazolam 0.05 mg per kg IV, injection fentanyl 2 microgram per kg IV. Pre-oxygenation was done with 100% oxygen for 3 minutes, and patients were induced with injection propofol 2.5 mg per kg IV, injection oxynicolline 1.5 mg per kg IV. Then intubation was done by laryngoscope assigned to the group in optimal position. Initial attempt was made to the quasi-endotracheal tube to the vocal cord. Its difficulty was encountered during intubation with particular laryngoscope. Then alternative intubating technique were used. Lifting force during laryngoscopy, external insulin pressure was also applied to insert the tube. Glottic exposure and position of vocal cord were noted each time. All the patients were successfully intubated in our study. Correct placement of endotracheal tube was confirmed by auscultation and ETCO2 value. Cormack-Laney grade and total time for intubation were noted, and intubation difficulty scale score was calculated for each patient. Maintenance was done with 30% oxygen, 70% nitrous oxide and sevoflurane, and injection rocuronium 0.6 mg per kg IV. At the end of surgery, patient reversed with injection neostigmine 0.05 mg per kg IV and injection glycopyrrolate 0.01 mg per kg IV, then activated. Statistical analysis. All the measurement data were presented as mean plus standard deviation. Statistical processing was performed using SPSS version 20. The categorical data analyzed by using chi-scatter, while quantitative data by 1 day ANOVA. The data with p-value less than 0.05 considered as statistically significant. A result and observation. In our study, CR grade 1 was 20% in group 1, 40% in group 2, 50% in group 3, while CR grade 2 was 26% in group 1, 30% in group 2, and 37% in group 3, while CR grade 3 was 33% in group 1, 17% in group 2, 13% in group 3, and CR grade 4 was 21% in group 1, 13% in group 2, and no cases in group 3. Intubation difficulty scale score, mean IDS score was 3.3 in group 1, 2.26 in group 2, and 1.56 in group 3, which was statistically significant. Total time for intubation was mean time in group 3 was 100.7 seconds, while 93.8 seconds in group 2 and 83.6 seconds in group 1, which was statistically insignificant. Discussion, Cormack-Laney grade and IDS score. The finding of our research demonstrated that TrueView laryngoscope performed better than the Hinstep, McCoy, and conventional Macintosh laryngoscope in patient by reducing the mean IDS score. TrueView laryngoscope resulted in significantly better protic view with lower chroma clanigrade and had a significant less optimization maneuver during intubation than Macintosh and McCoy group and offer easier intubating condition. Similar to our study, Andeep and et al. Found that mean IDS score was lesser in Gladyscope group as compared to the Macintosh group, respectively, which was found to be significant. Similarly, Aziz and et al. Also found that lesser CL grade in CMAC group as compared to the direct laryngoscopy group. Total time for intubation. In our study, we found that endotracheal intubation using TrueView video laryngoscope required longer time to intubation when compared to using Macintosh laryngoscope. Similar to our study, Lee and et al. Also found that mean time to intubation was significantly shorter with Macintosh group as compared to the TrueView group, but the view of larynx was better with the TrueView group as compared to the Macintosh group. Similarly, Varak and et al. Also found similar result. Conclusion: this study has concluded that TrueView video group laryngoscope provide better intubating condition as compared to McCoy and Macintosh laryngoscope with lower IDS score and improved CL grading. These are my references. Thank you.
Dr.
Hello.
Priyanka.
Good morning, sir.
Yeah, Dr. Deepesh, proceed.
Yes, ma'am. What was the position in which you tried intubation in these patients?
So in most of the cases, we tried in neutral position. In some cases, we tried in sniffing position also.
So why different position in different patients?
Sir, in video group and micro groups are usually we tried in as much as in neutral position because to check because in emergency condition we need to give in try in neutral position because of cervical injury. So we try to give in a neutral position so we can use in emergency cases also.
No, but you did this study in elective patients, no?
Yes, sir.
So don't you think that changing the position of head and neck can change the results of your study? Can confirm the results of your study?
Yes, sir.
And why do you think the time required for intubation is lesser in Macintosh with Macintosh as compared to TrueView?
Sir, because in TrueView group we need to assemble the things and
no, the things are already assembled.
Sir, because when the intubating, sir, we have to see a screen and accordingly go to it will take little more time, or it is indirect scopic, and Macintosh is a direct laryngoscope, so directly we seeing and inserting.
Have you used TrueView laryngoscope?
Yes, sir.
Okay, madam.
What is the advantage of McCoy and video laryngoscope over Macintosh laryngoscope?
In McCoy, ma'am, because of its hinge tip, we need less lifting force to elevate epiglottis. So lesser chance of injury to oral cavity and all.
No, in which cases? In normal cases, you want to use Macintosh laryngoscope?
Actually, in our study, we did in elective cases, ma'am. So according to result, we can use in emergency and difficult cases, ma'am.
Yeah, in difficult cases, you will be better with McCoy and
video, ma'am.
Yeah. Then also in which cases, like in less mouth opening?
Actually, in our study, we did in elective and Malampati grade 1 and 2 cases.
Okay. Okay, thank you.
Next one, please.
Sir, Dr. Praveen is ready. Can we
Yes.
give him?
Okay. You can call him.
Yes, sir. So, Dr. Praveen, you can unmute yourself and start sharing your screen. Dr. Praveen. Dr. Praveen, can you hear us? Okay. Sir, I think he is not in the panel also, not in the participants group.
Then call Dr. Akansha Bigro.
Yes, ma'am. Dr. Akansha Bikrol.
Yes, sir. Good morning, sir.
Good morning. You can share your screen now.
Yes, sir.
Dr. Akansha, can you hear us?
Yes, sir. I think I'm having some difficulty in sharing my screen.
Okay. Try again.
Hello. Hello.
Hello.
सर एक्चुअली किसी पार्टिसिपेंट की स्क्रीन ऑलरेडी शेयर हो रही है, तो मेरी शेयर नहीं हो पा रही है स्क्रीन.
Okay, let us check.
Sir, I think Dr. Priyanka's screen is still showing.
As I can see, there is no one else whose screen is sharing. So try connecting again. Dr. Akansha, you can start now. Make it full screen and start.
शेयर हो रहा है ना, इसको फुल स्क्रीन करना है.
Dr. Akansha, for full screen, you have to go at the bottom of your screen.
Yes, sir.
And where it is written 58%.
Yes, sir.
Just next to it, left to it, left 50, left to the 58%. Left, yes, 58% के left में जो की है उसको press करिए. To the left.
Yes, sir.
Yes. Press it.
Good morning, judges. Myself, Dr. Akansha Bikrol from MGM Medical College. I'm presenting my paper today on time interval effect of total dose requirement of propofol for induction of anesthesia. It's a randomized controlled study. Propofol is most commonly used intravenous induction agent today. Propofol is a sedative hypnotic drug commonly employed for sedation because it permits rapid recovery of mental function with a relatively low incidence of unwanted side effects. But because of lack of analgesic property, it cannot be used as sole induction agent. Fentanyl is most commonly used opioid for analgesia, may reduce the total dose of propofol and its dose-related side effect. This concept of balanced anesthesia, in which the administration of the propofol when peak level of the fentanyl is reached, has been used to incorporate administration of an opioid prior to the propofol, which markedly reduces the dose of the propofol and improves the hemodynamic stability. Fentanyl, a potent synthetic mu receptor agonist, is most widely used intravenous opioid for intraoperative analgesia. Methodology. This comparative randomized controlled study was conducted in the Department of Anesthesiology, MGM Medical College and MY Hospital. We included 60 patients, 18 to 60 years of age, scheduled to undergo elective surgery using general anesthesia. Patient with ASA physical status of more than 2, where severe cardiopulmonary disease, renal or liver impairment, history of seizures or peripheral neurological disease, allergy to the study medication, and those receiving vasodilators or medication that were excluded from the study. Randomization was done using CHIT method. 60 patients divided into 2 groups. Group P was a propofol group. They receive injection propofol 5 minutes after the injection fentanyl administration. And group F, where fentanyl group, they're receiving injection propofol immediately after the injection fentanyl administration. A thorough pre-anesthetic evaluation of all the patient was done. Written informed consent was obtained from each participating patient. On arrival of patient in the operation theater, all the baseline hemodynamic parameter, heart rate, systolic blood pressure, diastolic blood pressure, mean arterial pressure, saturation and ECG were recorded, and 18 gauge IV cannula was secured, and ringer lactate was started at the rate of 10 ml per kg per hour. An oxygen with simple face mask was attached. All the patients were pre-medicated with injection glycopyrrolate 0.2 milligram and injection midazolam 1 milligram. Injection fentanyl 2 mics per kg was administered intravenously. According to the randomization, group P was given injection propofol 5 minutes after administration of injection fentanyl, and group of F was given injection propofol immediately after injection of fentanyl. Propofol was injected slowly at the rate of 1 ml per 3 seconds while communicating verbally with the patient. Induction of anesthesia was considered as complete when the verbal contact was lost. Statistical analysis. Quantitative data are expressed as mean and standard deviation, where categorical variables are presented as number and percentage. Unpaired t-test was applied, and p-value less than 0.05 was taken as statistically significant. Result: the demographic parameter, that is age, sex, weight, and ASA physical status, and the baseline hemodynamic parameter were comparable among the group. Hemodynamic parameters, heart rate, systolic blood pressure, diastolic blood pressure, and mean arterial pressure showed considerable variation in the F group as compared to the P group when values taken at immediately at 3 minutes, at 5 minutes, and 10 minutes after administration of the propofol. As they were low in the group F as compared to the group P, dose of the propofol required per kg body weight or induction of anesthesia was significantly lower in group P compared to the group F. That was shown by p-value less than 0.001. Comparison of the total propofol consumption between the two groups is shown by this table, in which the p-value came significant, less than 0.001. And the comparison of the mean arterial pressure between the two groups at different time interval. As we can see through this table, in P group, after 5 minute administration of the propofol, the p-value was significantly lower as compared to 3 and 10 minutes. These are the line diagrams showing the systolic blood pressure between the two groups. There is a more dip in the F group as compared to the P group. Similarly, in diastolic blood pressure and the mean arterial pressure, this is showing that if we give the fentanyl 5 minutes, if we give propofol after the peak effect of the fentanyl is achieved, then the hypertension effect of the propofol is reduced. Discussion: in the present study, propofol administration 5 minutes after fentanyl resulted in a significant reduction in the dose of the propofol when compared to the propofol injection immediately after fentanyl. Systolic, diastolic blood pressure and mean arterial pressure were considerably lower in the F group as compared to the P group. Hemodynamic variation were more significant at 5 minutes. Our study was supported by a randomized controlled trial conducted in 2019 by Van Laar Dadlog on the effect of varying time interval between the fentanyl and propofol administration on propofol requirement for induction of anesthesia. Conclusion: administration of injection propofol 5 minutes after fentanyl causes marked reduction in the dose requirement of injection propofol along with significantly decreased incidence of hypertension. These are my references. Thank you.
Hello.
Good morning, ma'am.
Yeah, Dr. Akansha. Nice presentation.
Thank you, ma'am.
And, what is the action of fentanyl with propofol?
Ma'am, fentanyl acts as an analgesic. If we fentanyl is a mu1 receptor agonist होता है, ma'am. तो अगर हम fentanyl को propofol के साथ देते हैं, तो जो propofol में सेडेटिव और हिप्नोटिक होता है, लेकिन उसका कोई एनाल्जेसिक इफेक्ट नहीं होता है. लेकिन अगर हम उसको propofol के साथ देते हैं, तो ये propofol की जो कमी रहती है एनाल्जेसिक की, उसको कवर करता है. हेलो.
जो इंटरनेट कनेक्शन.
Hello, जी मैम.
There is disturbance in internet.
Pardon, ma'am.
Hello.
जी, hello. हाँ, ma'am.
Ma'am, we are able to hear you, ma'am, but your screen is stuck.
Hello.
Hello, sir. Yes, sir. So you're audible, sir. So ma'am is having some difficulty with the network.
Dr. Akansha.
Good morning, sir.
Yes. So why do you think the dose requirement in case when propofol was given 5 minutes after fentanyl?
Yes, sir.
Okay, why is it better? You found what could be the reason for this reduced dose of propofol or stable hemodynamics?
Sir, basically propofol जो रहता है वो हाइपोटेंशन कॉज कराता है. So अगर हम fentanyl देते हैं तो डोज रिक्वायरमेंट propofol की कम हो जाती है, तो जो हायर डोसेस की वजह से साइड इफेक्ट्स होते हैं वो भी कम हो जाते हैं. इसलिए हमने propofol.
दोनों ही केसेस में आपने fentanyl दिया है?
हाँ सर, मैंने दोनों केसेस में fentanyl दिया है, बट
तो ऐसा क्या हुआ कि 5 मिनट बाद अगर आपने propofol देना शुरू किया धीरे-धीरे तो उसमें कम डोज लग रही है आपकी और उसमें हेमोडायनामिक्स स्टेबल है, कोई रीजन है इसका?
सर पीक इफेक्ट अगर propofol fentanyl का जब पीक इफेक्ट आता है उसके बाद अगर हम देते हैं तो फिर उसमें हेमोडायनामिक स्टेबिलिटी ज्यादा रहती है कंपेयर टू हमने मतलब इफेक्ट नहीं आने दिया fentanyl का और हमने तुरंत propofol दे दिया.
So ideally it should be given at least 2 to 5 minutes after fentanyl. Propofol should be given.
Yes, sir. Yes, sir.
ठीक है. And other group you gave it immediately after fentanyl.
Yes, sir.
So जब इफेक्ट ही नहीं आया fentanyl का तो फिर उसको देने से क्या फायदा? Propofol साथ में देने से. So it should always be given after its peak effect is achieved.
Yes, sir.
Okay. मैडम नहीं कनेक्ट हो पा रही है. ठीक है हिमांशु. It's okay.
Thank you, sir.
Sir, Dr. Praveen को एक बार और try करें.
हाँ एक बार और कॉल कर रहा हूँ.
Dr. Praveen, unmute yourself and share your screen.
Yes, sir.
Yes, you can start with your presentation. Make it full screen. Press F5. Praveen, press F5.
पढ़ नहीं पाएंगे ना.
प्रवीण स्टार्ट करिए.
वो पढ़ लेंगे.
Hello.
Yes, Praveen, start your presentation. Your time is already started.
Yes, sir. Good morning, sir. My title is hello. Am I audible, sir?
Yes, Praveen, your time is already started.
Yes, sir.
Start.
My topic is intravenous injection of ephedrine compared with the phenylephrine for the preparation of intravenous injection of ephedrine compared with the phenylephrine for the prevention of hypotension during spinal anesthesia in cesarean section. Prospective randomized controlled double-blind study. My guide are Dr. Rasmi Pal ma'am and Dr. Ritu Paranik ma'am and the HOD Dr. KK Arora sir. Introduction. The hypotension following spinal anesthesia is the most common complication in patients undergoing lower segment cesarean section. It is associated with the nausea, vomiting, dizziness, may interfere with the surgical procedure and can cause fetal bradycardia and acidosis. Managed with the preload with the fluid, proper positioning, left uterine displacement, and the administration of vasopressor, crystalloid, colloid, and the vasopressor, including the phenylephrine, mephentermine, mephentermine, ephedrine. The phenylephrine is effective as vasopressor in restoring the maternal arterial pressure during spinal anesthesia and does not have detrimental effect on the fetus and does not cause tachycardia. Ephedrine stimulates the alpha and beta adrenergic receptor. The IV administration of ephedrine causes increase in the systolic and diastolic blood pressure, heart rate, and the cardiac output.
Dr. Praveen, you're not changing your slides.
The methodology. The study was conducted in a prospective randomized control and double-blind manner in the Department of Anesthesiology, MJ Medical College and MY Hospital, Indore. For a duration of 12 months for the timing of approval of ethics committee, 150 females in the reproductive age group belong to ISA grade 1 and 2 scheduled to undergo LSCS under spinal anesthesia will be randomly allocated into 3 groups. In each group, there is a 50 patients. As per seal envelope technique, group 1 includes phenylephrine, group B is ephedrine, and group C is 0.9% normal saline, and the rescue vasopressor is mephentermine. Observation: all the vasopressor maintain the arterial pressure effectively within 20% of baseline value. The mean value of heart rate was higher in the mephentermine group, followed by the ephedrine and phenylephrine group. The main value of systolic blood pressure, diastolic blood pressure, and mean arterial pressure were higher in the phenylephrine group, followed by the mephentermine group. And hello. The heart rate
keep on presenting.
The heart rate generally remained low throughout the study period in the phenylephrine group A, and incidence bradycardia was more in phenylephrine group. The heart rate generally remained low throughout the study period in phenylephrine group, and the incidence of bradycardia was more in phenylephrine group as compared to other two groups. The incidence of tachycardia was same in both ephedrine and mephentermine group. In one case to each group. The ephedrine group, 2 cases developed the hypertension. The occurrence of nausea, vomiting were similarly comparable in all of the 3 groups. Conclusion. The conclusion, we found that all the 3 vasopressor, ephedrine, mephentermine, and phenylephrine are effective in IV bolus for maintenance of maternal arterial blood pressure within 20% limit of baseline. So the phenylephrine has the quicker peak effect in compared to ephedrine and mephentermine, and it caused the reduction in the heart rate, which be advantageous in the patient whom had tachycardia is undesirable. All 3 vasopressor has no significant adverse effect on Hello.
Yes, continue.
The incidence of The incidence of tachycardia were same in the both ephedrine and mephentermine group. In the ephedrine group, two cases. The occurrence of nausea and vomiting were similarly comparable in all of the three groups. As compared to ephedrine and mephentermine, it causes reduction in the heart rate, which may be advantageous in the patient whom tachycardia is undesirable. All three vasopressor has no significant adverse effect on neonatal outcome. These are the differences. Sorry.
Dr. Praveen?
Yes, sir.
What is the title of your study?
Sorry, sir.
What is the title of your study?
Sir, comparison of ephedrine and phenylephrine intravenous for the prevention of hypotension during the spinal anesthesia in cesarean section.
But in this whole lecture, you have divided the participants into three groups.
Yes, sir. There is a third group is we are giving 0.9% NaCl. It is the rescue group in which we are.
No. Your third group, first group is phenylephrine, second group is ephedrine, third group is mephentermine.
Yes, sir.
In the whole study you have mentioned.
Yes, sir.
But it is not mentioned in your topic. Why?
Sir, because we are giving mephentermine as a rescue vasopressor, sir, that third group.
No, when you are comparing two groups, why are you using mephentermine as a rescue blood pressure maintaining agent?
Sir, as we
you are doing study between two groups, phenylephrine and ephedrine, and both are capable of counteracting this hypotension.
Yes, sir. In one group, sir, we are not. We are just giving a 0.9% NaCl. If there is a hypotension occur, we can give the mephentermine. In that case.
Okay. I don't think this study design is right. Now, how did you perform a double blinding in these patients? Double blinding.
Sir, we have chosen randomly 50 patients in phenylephrine group and 50 other patients in the ephedrine group.
Okay. How did you do double blinding? This is a double blinded study, no?
Yes, sir.
तो कैसे किया आपने double blinding?
Sir, randomly we are selecting the patient randomly, and each 50 and 50 cases.
वो randomization हो गया आपका. फिर आगे आपने study करी, फिर blinding कैसे करी उनकी?
We just compare with all these three groups.
चलिए ठीक है. What is the cause of hypotension during spinal anesthesia? This is the last question.
Sir, during the spinal anesthesia, there is a vasodilatation. Due to the vasodilatation, there is a pooling of blood in the lower extremity that causes the hypotension, and it already caused the fall in the blood pressure and heart rate.
Okay, thank you.
So this is last candidate.
Okay, thank you, Himanshu.
Thank you, sir. Thank you, ma'am, for giving us the time, and thank you all the participants. We will end our session C, and we will move on to the session D, that is free paper presentation. Thank you, Dipesh, sir. Thank you,
Okay, thank you. Bye.
Okay, thank you, everyone.
Thank you, ma'am. Thank you so much. After finishing with the free paper section C, we'll move on to section D of our free paper presentation. And for that, we have our two judges, Dr. Ruchi Tandon ma'am and Dr. Jaideep Singh sir.
Good morning, everyone. Good morning,
Good
students.
afternoon, ma'am. Good afternoon. Welcome, ma'am.
Thank you so much. Himanshu, I'd just like to put 2 points for the participants.
Yes.
Please try to stick to the time, first of all, and all the students, please be ready with your presentations one after the other. We will not wait for you to join if you're not there. Okay. So
Yes,
I think we should begin as early as possible. Who's the first candidate? I think it's Tanya Durve.
Tanya Durbe is the first candidate. Every candidate, you will be allotted 6 minutes for your presentation and 2 minutes for the discussion. Tanya Durbe, you can unmute yourself. Dr. Jaideep sir, welcome.
Yeah, good afternoon, Himanshu. How many candidates in this session?
So we have 9 candidates, sir.
Okay, let's start.
Dr. Tanya
Morning,
Durbe,
Jaideep.
you can.
Good morning, ma'am.
Chalo, start karo.
Hello, sir. I'm audible, sir. Hello.
Yeah, you are audible. Please continue.
Yes, Tanya, your time start now.
Good afternoon, all teachers, respected teachers and seniors and batchmates. My topic for paper presentation is comparison of intrathecal naltrexone hydrochloride and clonidine hydrochloride as an adjuvant to hyperbaric bupivacaine in lower limb orthopedic surgery. My moderators are Dr. Shikha Mehrotra ma'am, Dr. Urmila ma'am, and Dr. Rajni ma'am. Introduction. Subarachnoid block was local anesthetic is commonly used regional anesthesia for lower limb orthopedic surgery. If bupivacaine was used alone, patient do experience pain during prolonged surgery due to their limited duration of action. Because of this concern, the preemptive mixing of adjuvant with local anesthetic for regional anesthesia is provided a better alternatives. Nalbuphine is highly lipid soluble and partial agonist and antagonist opioid with agonism at kappa receptor and antagonism at mu receptor. Its affinity to kappa opioid receptor result in analgesia, sedation, and cardiovascular stability without undesirable side effect of mu receptor. This inhibits the release of substance P and also causes postsynaptic inhibition of interneuron and ascending nociceptive spinothalamic tract. Clonidine is a mixed alpha-1 and alpha-2 adrenoreceptor agonist with predominant alpha-2 action. It is lipid-soluble and can easily penetrate the blood-brain barrier to provide effective and extended analgesia by binding to presynaptic C fibers and postsynaptic dorsal horn neurons. Analgesic effect of clonidine is contributed by the inhibition of spinal substance P release and augmentation of acetylcholine release. Primary aims is to provide the to evaluate the onset of analgesia and evaluate the duration of analgesia, and secondary objective is to compare the characteristic of spinal block and compare the hemodynamic variation and adverse effect if any. Material and methods. Our study design is prospective hospital-based study, and sample size is chosen as a anesthesiologist and anesthetic procedure of 60 patients. With ASA grading 1 and 2, age 20 to 60 year are scheduled for elective lower limb orthopedic surgery under subarachnoid block. Inclusion criteria are patient belonging to ASA grading 1 and 2 and patient of either gender between 20 to 60 years of age and patient going for elective lower limb surgery. Exclusion criteria are patient refusal, ASA grading 3 or more, coagulation abnormalities, severe hypovolemia, increased intracranial pressure, local sepsis in spinal lumbar region, history of allergy to steroid drug, pre-existing neurological disease, cardiovascular, metabolic, hepatic, respiratory, and renal diseases. Procedural study was conducted in Gandhi Medical College and Associated Hamidia Hospital. After obtaining written informed consent, patients were allotted into 2 groups. Following an NVM of 6 hours before surgery, all study patients were preloaded with Ringer lactate 10 to 15 ml per kg over a 10 minutes after peripheral IV access with 18 gauge IV cannula was obtained and routine monitoring initiated with preoperative baseline reading of non-invasive blood pressure, pulse rate, and saturation are noted. Patients were placed in sitting position under all the aseptic precautions. Spinal anesthesia was administered at L3, L4 interspace using 25 gauge spinal needle. A volume of 3.5 ml of drug was injected over 30 seconds. Study group 1 received intrathecal bupivacaine, hyperbaric bupivacaine 0.5% 3 ml with 1.6 nalbuphine hydrochloride, and study group 2 received intrathecal bupivacaine 0.5% 3 ml with 30 microgram clonidine hydrochloride. Total volume of drug administered intrathecally was made up to 3.5 ml in syringe by addition of sterile isotonic NS in both the group. Onset of sensory level was monitored every minute till the maximum sensory level was achieved, and then after 1 hour at a half hour interval using response to cold stimulus method. Onset of sensory block was taken as a time taken to attain sensory level of T10 dermatome. Onset of motor block was taken as a time taken to achieve modified bromase grade 1 from the time of subarachnoid injection. Duration of surgery and 2-segment regression time using response to cold stimulus method was noted. Time for motor block to regress to modified bromase grade 1 was also noted. Duration of analgesia is the time from the intrathecal drug administration till the patient score was more than 3 was noted. Regular monitoring of blood pressure, pulse rate, saturation, and sedation score was done at 2, 5, 10, 15, 30, 60, 90, and 120 minutes interval, and post-operatively at 30 minute interval until the administration of rescue analgesia. Post-operatively, pulse rate, non-invasive blood pressure, and saturation was noted at regular interval of 30 minutes the first 4 hours, and once every 2 hours for the next 8 hours, and only 4 hours for the next 12 hours. Statistical analysis is all the statistical data was noted was done with the statistical programming software SPSS. The continuous variable such as age, weight, height, blood pressure, heart rate, and time were presented as a mean and standard deviation, and the categorical variable, that is ASA grading sedation score, were presented in frequency and percentage and were analyzed with the chi-square test. For frequency, if the p-value is more than 0.05, it is not significant. If the p-value is equal to 0.05, it is just significant, and if the p-value is less than 0.05, it is statistically significant. Analysis and result: the onset of sensory block and motor block was comparable in clonidine and nalbuphine group, but the significant faster in clonidine group when compared to nalbuphine. The 2-segment regression time was significantly prolonged in both clonidine and nalbuphine group, was significantly longer in clonidine group. The duration of motor blockage was significantly longer in clonidine group than the nalbuphine group. Intraoperatively, heart rate, systolic blood pressure, diastolic blood pressure, and mean arterial pressure was comparable among both the groups, and post-operatively, heart rate, systolic blood pressure, diastolic blood pressure, and mean arterial pressure was significantly lower in clonidine group in comparison to nalbuphine group up to 4 hours. However, after 4 hours, the values are comparable among both the groups. Adverse effects such as hypotension, bradycardia, nausea, vomiting, and pruritus are found, but the incidence of the adverse effect was not statistically significant among both the groups. Discussion: Spinal clonidine doses from 15 to 450 microgram have been used in diverse clinical scenarios. Based on the studies done by Chopra and Talwar, Khandelwal et al., we have chosen 30 microgram of intrathecal clonidine versus 1.6 milligram of intrathecal nalbuphine as an adjuvant to hyperbaric bupivacaine. Duration of analgesia is more when bupivacaine was used in combination with clonidine compared to nalbuphine. These results coincide with the Chopra and Talwar and Khandelwal et al. Study present who received 30 microgram of clonidine in combination with bupivacaine. The total duration of analgesia in the nalbuphine group was more when compared to Ahmed et al., in which the total duration of analgesia was 199.8 plus minus 25.9 minutes. The present study demonstrated that the clonidine produces a longer duration of post-op analgesia and compared to nalbuphine.
You have to wrap it up. Your time is already exceeded.
Yes, sir. The present study demonstrated the addition of clonidine prolonged the time of regression time and when compared to nalbuphine. Demographic data was comparable in our study. The present study was there is a significant difference in the hemodynamic parameters and adverse effect, which is supported by the Bansal et al. Studies. A low dose clonidine is not associated with hemodynamic instability as evidenced by Datta et al. The present study adjuvant have reduces significant faster onset of sensory and motor block when compared to the patient receiving bupivacaine only. However, it is comparable between nalbuphine and clonidine, while Bansal et al. Demonstrated that faster onset of sensory and motor block is due to nalbuphine. In present study, the duration of motor block was higher in comparable in both clonidine and nalbuphine group, but our result demonstrate the increased duration of motor block due to clonidine as substituted by the other study, which is done by Ahmad et al. Conclusion was clonidine 30 microgram and nalbuphine 1.6 mg as intrathecal adjuvant to 0.5 hyperbaric bupivacaine for subarachnoid block were clinically effective for providing adequate surgical condition with comparable hemodynamic effect, and clonidine clonidine when used as an adjuvant, it results in longer duration of sensory and motor blockage and 2-segment regression as compared to nalbuphine without significant adverse effect and hemodynamic alteration. Clonidine was more efficient than nalbuphine for enhancing the post-operative analysis. Thank you, ma'am. Thank you, sir.
Nice presentation, Dr. Tanya. Over to our judges.
Okay, Tanya, that was a good presentation. I just have very quick, we are already running short of time. My questions are, why did you add saline? You added saline, you said you added saline in the study?
No, ma'am.
I think I heard.
No, ma'am, I have.
What was the intrathecal combination did you use?
Ma'am, I have taken 2 groups. One group is received intrathecal 1.6 nalbuphine with 0.5% bupivacaine, and second group is received clonidine 30 microgram with hyperbaric bupivacaine 0.5%.
Okay, you did not add saline at all.
Yes, ma'am.
Okay, so that the little confusion was there. And have you randomized or blinded the study design?
It is randomized study, ma'am.
How did you randomize? I don't think you did.
Ma'am, table I have chosen.
How did you randomize the groups, the patients into groups? You forgot? It's okay, it's fine. And your size was how many patients in each group?
Ma'am, I have taken a total 60 patients. In each group, 30 patients, ma'am.
30 patients. So I just want to ask you, if we want a smaller margin of error, should the sample size be large or small?
Ma'am, if the sample size is small, it may error in our result, ma'am.
It may?
Error.
Sorry?
It may error, ma'am, in our result.
Because errors?
Yes, ma'am.
Okay.
It will cause error.
So, okay, and JB, your turn, please.
Yeah, Tanya.
Yes, sir. Good afternoon.
Yeah, in one group you used clonidine intrathecally, and in another group you used non-bupivacaine intrathecally. So, what is the most common side effect you encountered?
Sir, when we used intrathecally clonidine, most common side effect we found is bradycardia and hypotension, sir.
And what about the other group?
Sir, most common side effect is pruritus, sir.
And how you manage the side effects in both the groups?
Sir, if pruritus is occurring, sir, we give promethazine, sir.
Do you have assess for promethazine?
Yes, sir.
Do you have assess for promethazine?
Sorry, sir, I did not.
From where you are getting promethazine?
Sir, it is available, sir, in our institute.
Okay. Okay. Nice presentation.
Thanks.
So our next participant is Dr. Hemlata Patel. Dr. Hemlata Patel, you can unmute yourself now and share your screen. Dr. Hemlata, make sure to keep up with good speed from the start.
Hello. Yes, sir. Yes, sir.
Yes, sir. You can start with your presentation. Make it full screen and start.
Sir, full screen. How to done full screen, sir?
Press F5.
Sir, F5 in not my laptop, sir. Start.
Yes, listen, at the bottom of your screen, you can see that 62%. Right? Just left to that 62%, there is a button.
Yes, sir.
Click on that.
Yes, sir. Yes.
Left to that 62%.
Yes, sir.
Oh, press OK. Yeah. Go to the first slide and start.
Yes, sir. Good evening to all. My today paper presentation topic is a prospective comparative study to evaluate the hemodynamics, arterial blood gases, smoker and non-smokers during general anesthesia in abdominal surgeries. My guide is Dr. Rasmi Palman, co-guide is Dr. Neetu Gupta ma'am and KK Arora sir at the head of the department. Introduction: smoking is the leading cause of the mortality, cause of the high mortality and morbidity in its serious challenging in healthcare systems. Serious challenges in a healthcare system worldwide. Nicotine is the principal ingredient responsible for the tobacco addictive character in smokers. The plasma concentration of nicotine may be 50 to 50 milligrams secret adrenaline, so increasing the sympathetic activity results in an increase in oxygen consumption in cardiac muscle, thus the increase oxygen leading to decrease in the myocardial oxygen supply and demand ratio. It has been found that the frequency of the severity of different specific respiratory event higher in smokers compared to non-smoker. These specific respiratory events like laryngospasm, bronchospasm, aspiration, hypoventilation, hyposmia are observed in smokers groups. The association between the smoking and the operative complication is well documented in various studies. It has been also reported the cessation of the smoking or before the surgery helped to improve the outcomes. Aims and objective. My aim is of the study to evaluate the effective smoking in smoking on the cardiorespiratory system in perioperative period. Primary objective to assess the effect of smoking on hemodynamics, arterial oxygen and carbon dioxide concentration in the subject, and secondary objective to assess the adverse effect like laryngospasm, bronchospasm, desaturation and CO2 retention and respiratory repression in the groups. Material required: anesthesia machine with oxygen supply, suction apparatus, laryngoscope blades, endotracheal tubes, multi-para monitor, drugs for general anesthesia, sterile syringe, intravenous fluid, emergency drugs, epidural kit, and facility to get EBG done. Methodology: study design, a prospective comparative study. Study duration: the study was conducted for a period of 1 year. Study center: Department of Anesthesiology, MGM Medical College and MY Hospital. Sample size: the study was compared 74 patients divided into 2 groups, 37 each. Present selection criteria: inclusion criteria, ASA status 1 and 2, and age from 20 to 70 years. Abdominal surgeries: minimal duration of smoking is 10 years. And exclusion criteria: patient belonging to ASA grade 3 and 4, patient refusal, any drug allergy, patient with pre-existing disease like heart disease and pulmonary diseases and endocrine disease, psychiatric patient and central nervous system disorders, and patient requiring post-op ventilation, recent upper and respiratory tract infection, and patient with receiving medication affecting the heart and pulmonary system. Procedure: a careful perioperative checkup for the all patient was done before the surgery was explained, and consent was explained and concealed about this general anesthesia, and written informed consent was taken to all patients. Upon arrival, the patient operation theater connected with multi-para monitoring. Intravenous 18-gauge IV cannula was established. At 22-gauge arterial cannula was placed in the radial artery and on the either hand of the patient, and ABC sample was taken and sent to analysis, and 18 to 16 gauge epidural catheter was placed desired level according to the surgery, and pre-medication done with glycopyrrolate 0.2 milligram IV and injection metazolam 0.5 milligram or 1 milligram IV. Patients were medicated with injection fentanyl 2 microgram per kg, followed by the peroxidine 100% oxygen up to 3 minutes, and reduction of the general anesthesia was done with endotracheal intubation, maintained with oxygen and nitrous and inhalation anesthetic and muscle relaxation throughout the procedure. Value for mean arterial blood pressure, systolic, diastolic, and SpO2 were recorded just before intubation and after intubation. Value for mean arterial blood pressure, systolic blood pressure, diastolic blood pressure, SpO2, and ETCO2 were recorded just after intubation, 1 minute, 5 minutes, and 10, 15, and 30, and 1 to 2 hours after intubation. And after reversal, after completion of this reversal was done with injection neostigmine and glycopyrrolate. After the extubation, value for mean arterial blood pressure SpO2 and recorded at 5, 10, 15, and then 6 and 12 and 48 hours after the 24 and 48 hours after the extubation. After the all the patient will administer oxygen by the face mask at 4 liters per minute in recovery period. Post-operative EVG analysis was done after 2 hours of the after extubation of the surgery, and peak expiratory flow rate will be recorded on day 0, 1, 2, and day after the surgery every day. Best of these value will be noted. Comparison of the my statistical analysis was t-test and mean Whitney test were applied, or p value less than 0.05 it was the statistically significant. Okay. Comparison of the arterial mean arterial blood pressure difference in smoker and non-smoker group. Smoker is high. Smoker groups is relatively higher mean value found. These are the relatively p-value for the smoker and non-smoker groups. In comparison with systolic and systolic blood pressure, also higher side found the in smoker in the smoker group except after 24-hour extubation. And also diastolic blood pressure also found a higher side in smokers. Comparison of the oxygen saturation, there is no significant difference between the pulse oximetry after saturation. Okay. And comparison of ETCO2 value, and ETCO2 values are a higher side in the smokers group, and P value was significant. Comparison of the arterial blood gases, these are the in this graph smokers have the higher PCO2 and lower pH, and lower pH and PO2 in the smokers group, and higher and normal in the smokers group. There is no difference in the bicarbonate levels, and no significant value found in the bicarbonate and ABG. And comparison of the expiratory flow rate, there is in non-smoker group, in a smoker group, peak expiratory flow rate is lower as compared to non-smokers group. Discussion: all the patients were comparable with regard to their demographic profile and ASC grading. According to the result, we have found that the research can summarize result of the study. The comparison of the mean arterial blood pressure, systolic blood pressure, and diastolic blood pressure are significant difference found in the smoker group, and blood pressure or proportionally higher in comparison to non-smoker group all the time during the intubation or extubation. P-value was significantly less than 0.05 in all the in smokers group, in comparison group, and smoker group and non-smoker group are no significant result in obtained, and data were comparable regarding the oxygen saturation was observed. ETCO2 value proportionally higher in smoker group in comparison to non-smoker groups. Good significant relation were obtained because at all the measurement p-value is below the 0.005. Comparison of the arterial blood gases, different measurement between these group in smoker in smokers. And
Hemlata, you have to wrap it up. Your time is already up.
Yes, sir. Comparison of the oxygen saturation at different time of measurement in between the group and a smoker and non-smoker. No significant result were obtained in comparable groups. This result is, in this study also agree with the result of obtained by the Malhotra SK et al. Hemodynamic parameter in the lower abdominal surgery in post. This result in this study agree with the obtained by P. Patwani study control of the hemodynamic response to tracheal intubation in cigarette smoker compared to non-smokers. Comparison of the oxygen saturation at different time of measurement between two groups. Smoker not significant. In our study found that the exaggeration sympathetic activity is significant in hemodynamic changes and cardiorespiratory changes in blood gases changes in smoker patients. These are the references. Thank you, sir.
Okay, that was a good presentation, Namrata. Just one quick question.
Yes, ma'am.
Why do you think smokers in the study, why do you think the smokers have had these increased blood pressure that you have shown, systolic, diastolic, and mean arterial blood pressure? What is the cause?
Ma'am, because of the in smokers nicotine level is high, that is the stimulate the adrenal medulla in the kidney, so that the sympathetic activity is increased. So,
is that the only reason? Can there be any other reason? Only this sympathetic activity?
Ma'am, this is also increase the myocardial oxygen demands, and so that's ma'am. Ma'am, smoker is in hypertensive state.
Why? Okay, fine, forget it. And your sample size was, you have taken 37 patients, isn't it? In each
yes,
group?
ma'am, each group.
37 patients. Why specifically 37? Why 37? It's a very odd number.
Ma'am,
Focus. Very easily you will find a lot of patients who are smoking. Day in and day out, you will find patients who are smoking.
Ma'am, specific abdominal surgery is considered karni thi, ma'am. Not all smoker and non-smokers.
Okay, only abdominal surgery.
Yes, sir.
Okay, fine. Thank you. Good presentation.
Thank you.
Yeah, Hemlata, it's a nice presentation.
Yes, sir. Yes, sir.
Yeah. Again, my question is, you are restricted to 1 year and you are incorporating the patient who gone through the laparotomy surgeries, abdominal surgeries in smokers. Am I right?
Yes, sir.
Or is there any particular inclusion or exclusion criteria? Because the study group number is very unusual.
Sir, specific abdominal surgery इसीलिए नहीं सर स्मोकर एंड नॉन स्मोकर्स ग्रुप में सर और अदर सर्जरी इंक्लूड नहीं कर रहे थे सर तो स्टैटिस्टिशियन ने मतलब यही डाटा निकाल दिया.
Okay, so in the duration of your study, it's that was 1 year duration. You had 74 abdominal surgeries. Okay, fine.
Yes, sir.
Okay, next speaker, please.
Okay, that was good. Thank you, Hemlata.
Thank you, sir. Thank you.
Our next presenter is Dr. Hema Chauhan. She is a second year MG Medical College. Sorry, third year MG Medical College. Hema, now you can unmute yourself and share your screen.
Good afternoon, sir.
Good afternoon. You can share your screen now.
Good afternoon, sir.
Yeah,
hello,
good
sir.
afternoon.
Is it
please continue? Yeah. Kindly share your screens.
Yes, sir. Sir, I think the previous presenter has not switched off the. It's still showing some presentation on screen, sir.
Yeah, there is one photo which is visible over here.
Hima, the previous presenter has already stopped sharing her screen. You can try again. Please try again.
Yes, sir.
Hima?
Yes, sir, I'm trying, sir.
Okay, are you using your laptop?
Yes, sir.
So on the bottom of that screen, there is an option for share screen. Are you clicking on that?
Sir, that's what I'm doing, sir. Actually, I'm using an Apple laptop.
Okay, so it is same in both of these things because the app runs devices. You're able to see that option, na? Share your screen.
Yes, sir. So I'm able to see that. I'm going to the next screen. I'm sharing the entire screen. I'm going to the next screen, which is my presentation, but it is not getting shared. So just 1 second. Sir, should I come next in order to save time?
Ma'am?
Yeah.
Sir, let's move on with the next candidate and we will...
Yes, Himanshu, give the
Oh,
permission
no
to the
problem.
next candidate.
Yes, let's not waste time.
Thank you, ma'am. Next will be Dr. Kapil Prajapati. Dr. Kapil, unmute yourself and share your screen.
That's what.
Good afternoon to everyone. Myself, Dr. Kapil Prajapati. The study for my the topic for my presentation is comparative study of USG guided versus PNS guided tab block for post-operative analgesia laparoscopic cholecystectomy. Pain is an unpleasant sensory and emotional experience associated with actual and potential tissue damage. Concurring pain is one of the greatest achievement of science, without which surgery would never have been achieved the status it is enjoying today. Inadequate control of post-operative pain leads to several untoward adverse effects, such as the patient discomfort, prolonged immobilization, extended hospital stay, thromboembolism, and pulmonary complications. Pain after laparoscopic cholecystectomy arises from procuring pneumoperitoneum-induced abdominal stretch and hepatic blood destruction due to cholecystectomies. Various modalities has been used to alleviate the pain after laparoscopic cholecystectomies, which includes the NSAIDs, opioids, thoracic epidural block, and multimodal analgesias. Tab block is a peripheral nerve block designed to anesthetize the nerve supplying the anterior abdominal wall from T6 to L1. The block was described by Raffi in 2001. With increasing utilization of ultrasound guidance for more accurate needle localization, the tab block is now a safe and effective technique for alleviating post-operative pain following abdominal surgeries. This is an image showing the cutaneous nerve distribution and the dermatome of the abdominal wall. And this is the surface and anatomical landmark it is used to identify the triangle of Petit, which is our area of interest. Duration of tab block is limited to the effect of administered local anesthesia. Recently, adjuvant medications were added to local anesthesia to prolong the effect of tab block. In pursuit of multimodal analgesia for laparoscopic procedures, our studies were designed to compare the efficacy of USG guided versus PNS guided tab block for laparoscopic cholecystectomy for post-operative analgesia 24 hours post-operatively. Aims and objectives are to assess the analgesia efficacy of USG guided and PNS guided tab block as compared to control group with the following objectives: to assess the analgesia efficacy of USG versus PNS guided tab block, to study and compare the time of administration of rescue analgesia and its total dose requirement during the first 24 hours to assess the patient satisfaction for post-operative analgesia, to determine the safety of USG guided and PNS guided by assessing the incidence of any adverse effect. The study design is prospective, randomized, and controlled study. The study center is Department of Anesthesiology, SSMC, and associated GMH and SGMH, Riva, Madhya Pradesh. The study period is from January to 2022 from December 2020. Inclusion criteria includes adult patients with ASA grade 1 and grade 2, elective for lab coli. Exclusion criteria is patients refusal, significant systemic diseases, psychological disorder, pregnant women, patient allergic to local anesthesia and coagulopathies. After getting the clearance from IC, 90 other patients were randomized in 3 groups. Control group received a standard post-operative analgesia regimen consisting of injection paracetamol and injection diclofenac. The group US tab received the bilateral USG guided tab block with 0.375% ropivacaine along with the standard post-operative analgesia regimen. Group PNS tab received the bilateral PNS guided tab block with 0.375% ropivacaine along with the standard post-operative analgesia regimen. Detailed history of all the patients were taken. Patients were explained about the entire procedure and informed consent taken. Patients were educated about the VAS score and the patient satisfaction scale. Patients were kept nil by mouth at 6 hours prior to the surgery. After shifting them to the operating theater, monitor were attached and the baseline parameters were recorded. Intravenous access secured with 18 gauze IV cannula. In the operating room, the patient received IV fentanyl. Anesthesia was induced with IV propofol. Scoline was used to facilitate the tracheal intubation. Anesthesia was maintained with nitrous and isoflurane and oxygen. At the end of the surgery, bilateral USG guided tap block was performed using a mid-axillary approach with a high-frequency ultrasound probe. In reaching this plane, the local anesthetic solution was injected, which leads to expansion of the tap that appears as a hypoechoic space. Careful aspiration was performed before injection to exclude the vascular puncture. After confirming the negative aspiration of the blood, 20 ml of 0.375% ropivacaine was administered on each side in all group USG tap patient. This is an ultrasound image showing the external oblique, internal oblique, and transverse abdominis muscle. And this is the plane where the local anesthesia is injected. That is a hypoechoic area. And this is a USG. In this image, it is showing the needle placement and the USG transducer present for in-plane. A bilateral PNS guided trap block was confirmed by using the insulated 20 gauge 17-degree bevel locopus needle of length 50 mm. By stimulating the subcostal nerve, contraction of the transversalis and rectus muscles can be elicited. Direct stimulation of the muscle can be ruled out by using a low intensity current less than 0.5 milliampere. After confirming the negative aspiration, 20 ml of 0.375% ropivacaine was administered on each side in all the group patients. After completion of the surgery procedure and block, patient was transferred to ESU. Pain severity was assessed using a visual analog scale, which was recorded at 0, 8, 12, 18, and 24 hours after the surgery. At any point was more than 4, IV tramadol was used as a rescue analgesia. The duration of analgesia and the total tramadol consumption in first 24 hours was duly noted. Likert scale of patient satisfaction score was assessed using a 5-point, which are classified as highly satisfied, satisfied, dissatisfied, not dissatisfied, dissatisfied. The study ended 24 hours after the surgery. Statistical analysis, all the measurement data were presented as mean plus minus standard deviation, and statistical processing was performed using SPSS 20.0. The categorical data analysis by using a chi-square test, while quantitative data by a student t-test. The data with p-value less than 0.05 was considered statistically significant. This is a graphical representation of the VAS score. In the y-axis, there is a mean VAS score, and in the x-axis, there is a time interval for our studies. And in this study, it is showing that there is a significant difference between the control group, VAS group, control group, and PNS guided and USG guided tab block for the VAS score. The total mean duration of analgesia for US tab is 12 hours in US tab, as compared to PNS tab, it is 10 hours, and for control group, it is 4 hours. The total amount of tramadol required for control group is more as compared to PNS and US tab. In US tab, highly satisfied patient percentage is about 48%, whereas 36% patients are satisfied with PNS tab and 0% patients are highly satisfied with control group. Discussion. Both US tab and PNS tab produce significantly low VAS score than control group after first post-operative hour. Carne et al. Have the same study in support of our study. Injection tramadol IV significantly more frequently added in control group than in US tab and PNS tab group. Beverly D all did the same study in support of our studies. Maximum duration of analgesia was 12 hours in US tab, 10 hours in PNS tab, and 4 hours in control group. McDonald's JC et al. Did the study in support of our study. As compared to PNS tab, US tab reduces the post-operative pain intensity at a significant p-value less than 0.001 at 8 hours and 0.05 at 12 hours. And there is a significant difference in rescue analgesia and total analgesia dose between both groups with p-value less than 0.001. 48% in US tab group and 36% PNS tab and 0% in control group are highly satisfied. Summary: the most post USG and PNS tab block enables better pain control, less rescue analgesia consumption, and less adverse event than control group who underwent laparoscopic cholecystectomy. US guided tab block was better in reducing the post-operative VAS score and rescue analgesia consumption than PNS guided tab block in patient who underwent laparoscopic cholecystectomy. No episodes of any adverse event noted in USG and PNS guided tab block. These are the references. Thank you.
Nice presentation. Over to our judges.
Thank you, sir.
It is Kapil Prajapati. So Kapil, it's a very good, very excellent study. Good afternoon. I really liked it. It's very good, very excellently presented also. And your delivery was also very good. What was the study design? What was the study design of your
prospective study.
Did you randomize? This is the duration was from January 20 to December 2020.
Yeah? My randomization is done by using envelope method.
Envelope method. Okay. Randomization also has been done. Very good. The only thing is we were busy with COVID. We were not doing so. January
I'm actually
2020.
Yes, ma'am. In our centers. In our centers there are more cases are happening lab poly patient. Approximately 3 to 4 cases are happening in regular basis. That's why I'm able to get all these patients.
Okay. You had plenty of patients to conduct the study on. Very good. Excellent. Jaideep, your turn.
Yeah, ma'am. Kapil, definitely your presentation is very good. Good afternoon. Your presentation is very good. You are very confident in presenting the thing. I have few query. Do you compare two techniques of TEP block, or you are comparing TEP block with the subcostal nerve block?
Sir, in this we are comparing the post-op analgesia for that. Sir, technique was not compared, sir.
No, but the topic of your presentation is comparison of TEP block with USG technique and PNS technique.
Sir, for post-operative analgesia, sir. Which one is better in controlling?
That's for post-operative analgesia but TEP block is not possible with PNS. You are getting my point?
Hello. Sorry, sir.
You are getting my point or not?
Yes,
you are getting my point or not?
Sir, can you please repeat the question, sir?
Yeah, the topic of your presentation is comparison of TEP block with USG technique and PNS technique.
Yes, sir.
Am I right?
Yes. Yes, sir. Yes.
How you perform TEP block with PNS? What is the meaning of TEP? What is the meaning of TEP?
TEP is a transverse abdominal plane, sir.
Yeah, great. So how you achieve a plane with the help of PNS needle?
Transverse abdominal plane, sir. In this plane, the thoracolumbar nerve.
Hello.
Running in this plane only, sir.
Hello.
Sir.
Yeah, Kapil. Kapil. How you achieve a plane with the help of PNS? You are getting my point?
Sir, by using insulated. Yes, sir. Yes, sir. Yes, sir.
Yeah, what you stimulated in the plane?
So subcostal nerves are going through this plane only, sir. Thoracolumbar.
No. Subcutaneous plane is not available at that level. If you do, it's a serratus anterior plane basically. TEP is a different.
Quadratus lumbar.
TEP is a different plane. It's not practically possible to achieve TEP block with the help of PNS. You go through with the literatures. You your presentation is excellent. I am very happy with your confidence as you presented your thing. But you go through with literatures, there's slight difference between the tab block and serratus anterior block and quadratus lumborum block. They are 3 different blocks. And comparing 2 different blocks for same modality is, I don't think it's presentable.
Another thing I would like to say is, if you don't mind, Jaideep, what I have gathered is ultimately you have to confirm that the needle is in the plane only by USD, even if you're using a PNS.
Exactly. Exactly. This is my point, that to achieving a tab block, the standard modulation is USG.
Yes.
Okay. And if you are stimulating, as you told, if you are stimulating subcostal nerve, that itself becomes subcostal nerve block, not the tab block. Okay, Kapil, you are getting my point?
Yes, sir. Yes, sir.
Okay. Thank you. Nice presentation.
Thank you.
Thank you, judges. Our next presenter is Dr. Richa Pandey, 3rd year, Gandhi Medical College, Bhopal. Dr. Richa.
Good afternoon, teachers. Hello.
Yes, sir. Dr. Richa, you're audible. Start sharing your screen. Dr. Richa?
Ji, sir.
Are you having any problem? Dr. Richa?
Sir.
Your screen was visible for a few seconds, then it's gone again.
So my screen is visible. Hello.
No, Richa, your screen is not visible yet.
Not visible.
Yes, go to the first slide and start. Go to the first slide and start.
Good afternoon, respected teachers. My paper presentation title is Efficacy of Dexmedetomidine in Quality of Surgical Field and Hemodynamic Stability for Functional Endoscopic Sinus Surgery. Introduction. Sinus surgery is one of the most prevalent surgeries on ear, nose, and throat, which is mainly carried out through endoscopy. Even a slight bleeding could cause abnormal endoscope vision and increase complications, including damage to the surrounding structures, surgeons' impaired vision, frequent use of suction, and increased operative time. Anesthesiologist has a great role in creating this surgical field and an appropriate condition for better visibility of the surgeon. Dexmedetomidine is a highly specific and potent agonist of alpha-2 receptors. The beneficial dose-dependent effects of dexmedetomidine are sedation, analgesia, sympatholysis, and reduce anxiety without respiratory depression. It helped in providing an ideal allogeneic surgical field during FIS. My primary aim is to evaluate the efficacy of dexmedetomidine in intraoperative bleeding and quality of surgical field in FIS. The secondary aim is to evaluate the effect on hemodynamic control during FIS. Material and method. Study design is double-blinded, randomized, observational hospital-based study. Size is 50 adult patients of both sex, age 18 to 45 years, of 45 to 65 kg, scheduled for elective FIS under general anesthesia. Inclusion criteria: age 18 to 45 years, both male and female, ASA grade 1 and 2, patient posted for FIS. Exclusion criteria: pregnancy, altered conscious state, significant comorbid disease, hemoglobin less than 10 gram per dl, allergy to anesthetic drugs. Procedure is: study was done in Gandhi Medical College and Associated Hamidia Hospital. Written and informed consent were taken. Study consists of 2 groups. 50 patients were randomly divided into 2 groups, 25 each. The D group received 1 microgram per kg in 10 minutes at induction, followed by 0.4 to 0.8 microgram per kg per hour during maintenance, while the control group were administered an identical amount of saline solution. In both groups, infusion was stopped before 10 minutes of the surgery. FIS was performed by the same surgical team to ensure consistency in the estimation of the surgical field, who were unaware of the study drug. Both the surgeon and the anesthesiologist administering the drug were blinded to the study. On arrival to the operation theater, the baseline parameters of blood pressure, heart rate, oxygen saturation, temperature, and ECG were recorded, and study drug infusion was started. Patients were pre-medicated, and after pre-oxygenation, anesthesia was induced with propofol 1.5 to 2 mg per kg. Direct laryngoscopy and tracheal intubation with an adequate size curved endotracheal tube was done. Heart rate, systolic blood pressure, diastolic blood pressure, mean arterial pressure, and opioid requirement were evaluated in 15th, 30th, and 60th minute of the induction. Intraoperative bleeding was estimated by the surgeon based on Fromme-Bozard scale for the evaluation of operative field visibility during the surgery. Reversal of neuromuscular blockage was done after patient was fully awake and following commands. Statistical analysis: the recorded data are presented in a table format and expressed as mean plus minus standard deviation. The analysis was carried out using Microsoft Excel. Statistical significance was analyzed using student t-test. A p-value of less than 0.05 was considered significant. Analysis and result. Intraoperatively, there was a statistically significant reduction in the mean heart rate compared with the baseline value in group D. After extubation, the heart rate was found to be higher in patients of control group. The baseline mean systolic blood pressure was comparable between the group, but it was lower during surgery in patient of group D, but no statistically significant difference. No episode of hypotension was observed in any patient during the study period. After discontinuation of the study, drug infusion at the end of the surgery and after extubation, blood pressure was significantly lower in group D. The mean intraoperative fentanyl consumption in group D was significantly less compared with the control group. The average intraoperative isoflurane requirement was low in group D compared to group C. This was statistically significant. During FIS, surgeons experienced an ideal surgical site of grade 1 and 2, minimum bleeding with sporadic suction in 21 patients of group D, whereas no patient of control group showed much reduction of bleeding at the surgical site despite a low systemic blood pressure. The difference in bleeding at the surgical site was statistically significant between the two groups. Discussion. Dexmedetomidine during surgery has significantly decreased the heart rate, blood pressure, and bleeding at the surgical site, which is attributed to the known sympatholytic effects of alpha-2 adrenergic agonists. Dexmedetomidine is nowadays used as a hypotensive agent in endoscopic surgeries. It also has an added advantage of analgesic property, thus reducing perioperative analgesic requirement. Many studies have investigated the effect of dexmedetomidine and reported a significant reduction in heart rate and blood pressure. Guven et al. And Boxu et al. Reported better hemodynamic stability, visual analog scale for pain, clear surgical field, and few side effects when dexmedetomidine was administered for FIS. In the present study, the efficacy of dexmedetomidine in reducing the bleeding of the surgical site was examined. There was a significant improvement in the quality of the surgical field and provide an ideal allogeneic field for surgeons. It was better in maintaining hemodynamic stability and drier surgical field and did not cause reflex tachycardia or rebound hypertension. Dexmedetomidine provided analgesia through binding in the spinal cord. In the present study, intraoperative fentanyl consumption was significantly less in group D compared with the control group. Regarding the intraoperative adverse effect, 2 patients in the group D and 3 patients in group C developed bradycardia. It was easily reversed by atropine 0.3 mg IV single dose in both the groups. This was not statistically significant. Other intraoperative problems like hypertension, arrhythmias, tachycardia, ischemia were not encountered in either of the groups. Conclusion: Dexmedetomidine has effectively provided the ideologically surgical field during FIST with a high score of surgeon satisfaction and little need for additional hypotensive agents. It was observed that dexmedetomidine improved the quality of surgical field and hemodynamic stability. In addition, it might be safely and effectively used in surgeries in which deliberate hypotension is desirable, offer the inherent advantages of analgesia, sedation, anesthetic, sparing effects. Thank you.
Nice presentation, Dr. Richa. Over to our judges.
Yeah, yes, it was a good presentation. The study design was also good. Richa, what was the scale that was used? Your main primary aim was to study the field, isn't it? Surgical field, and that was the primary aim. So what scale was used to assess
It was a Fromme-Bozard
surgeon satisfaction?
Ma'am, it was a Fromme-Bozard scale. It is divided into 0 to 5 groups points. In 0, there is no bleeding. In 1, it is a minimal bleeding. In this, suctioning is not required. In 2nd grade, there is a minimal bleeding, but occasionally suctioning was required. In 3rd, it is also minimal bleeding, but repeated suctioning required. In 4th, moderate bleeding, in which the bleeding obscures the surgical field. And in 5th grade, there is a severe bleeding in which the surgery is not possible as the bleeding is completely obscures the surgical field.
Okay, and the surgeon was also blinded to the study?
Ji, ma'am.
The surgeon was blinded to the study?
Ji, ma'am, surgeon was blinded to the study.
So it was a double blind study?
Ji, ma'am, double blinded study.
Okay, very good. Jadid, please carry on.
Yeah, overall, it's a very good bridge study and nice presentation by Dr. Richa. The only single question about the satisfaction of patient. Do you involve this the surgeon in your study, Dr. Richa?
Sir, the surgical team was same for all the patients, but they were blinded to the study drugs.
Okay, so they are not knowing what drug you are using and
Yes,
why
sir.
they are having the difference in the bleeding pattern of the patient.
Yes, sir. They were blinded. They were not knowing about it.
So in FAS, when they are doing the surgery with the help of their scope, microscope, how you assess the blood?
Sir, as the bleeding during the phase, it is complicated as it is a very microstructures bleeding occurs. But the bleeding, we assess bleeding by first by the sponges which are soaked in by the blood, the suctioning which is filled, the volume of the suction which is filled by the blood, and the wash used. And by the microscopic screen which is present, the bleeding which is visible in the screen, and they are doing the suctioning over there. By that we can observe the bleeding, and by the surgeon satisfaction.
Actually, surgeon satisfaction is it's not a criteria. It's overall a very subjective criteria. Okay, it was a nice presentation. Thank you so much.
Thank you.
Next, please.
Yes, Shikha, you can unmute yourself and start with your presentation. Dr. Hima, can you hear us?
Hello. Yes, sir.
Yes. You start with your presentation.
Okay, sir.
This is what is the name of the candidate?
I'm Shikha Jain, Dr. Shikha Jain.
Shikha Jain. Okay.
Yes. Dr. Shikha. Dr. Shikha. Dr. Shikha, can you hear us? You're not audible to any of us. Dr. Shikha. Unmute. Dr. Shikha, unmute yourself. Dr. Shikha, we cannot hear you. Ma'am?
Yeah, Dr. Himanshu, you can take another candidate.
Sir, can I present?
If you're okay, if you're prepared, please do. Let's not.
Who's this?
Dr. Hima, sir. Dr. Hima.
Ma, are you ready with your
Yes, sir.
presentation?
Yes, sir.
Share your screen.
Yes, sir.
Yeah, candidate, please identify
No,
first.
is it possible?
So she's Dr. Hima Chauhan, and she's a third-year resident MGM.
Good afternoon, sir.
Okay.
Good afternoon, sir. The
afternoon.
title of my presentation is an interventional study to assess the outcome of thoracic segmental spinal anesthesia in upper abdominal surgeries. My guides are Dr. Manish Banjare, sir, professor, Dr. K.K. Arora, sir, professor and HOD, and Dr. Dipali Valecha, ma'am, assistant professor. So, introduction. Abdominal surgeries are some of the most commonly done surgeries, can be done electively or as emergency, can be taken under general anesthesia or regional anesthesia. Regional anesthesia in the form of neuraxial, epidural, or spinal. Regional anesthesia is preferred in high-risk cases, that is in elderly and those with renal and liver disorders, which eliminates the drawbacks of GA. Most anesthesiologists do not give lumbar puncture above the termination of spinal cord, fearing injury. Although MRI scans have confirmed that the gap between dura mater and spinal cord is more in mid to lower thoracic spinal cord versus that in lumbar region. Hence, there is safety and lower chances of spinal needle injury. There are a few advantages of segmental spinal anesthesia at mid to lower thoracic levels in abdominal surgeries, such as since there's no blockade of lower extremities, there is little caudal spread. That portion of body has no venodilatation and it buffers adverse BP fluctuations. A low dose of an anesthetic is required due to the high spinal specificity. Superior muscle relaxation is observed as compared to GA without any respiratory depression. There is better patient compliance, the less anxious patient with some motor control over the legs. There is lower opioid requirement due to neuraxial anesthesia, which inhibits neuroendocrine stress response as well. There is early mobilization, which negates the chances of DVT and pulmonary embolism post-operatively. My aims and objectives were, primary objective was to see intraoperative hemodynamic stability. Secondary objectives were post-operative recovery room discharge time, post-operative analgesia, side effects and patient satisfaction. Materials required were injection bupivacaine, isobaric 0.5% ampule, the spinal anesthesia tray, anesthesia workstation with oxygen supply, multi-parameter monitor, and emergency trolley. Methodology. My study design was interventional. Study duration time was, it was conducted over a period of 2 months. Study center was the Department of Anesthesia, MGM Medical College and MY Hospital Indore. And my sample comprised of 20 patients who presented to the surgery department electively. Selection criteria. Inclusion criteria included ASA physical status 1, 2, and 3, age from 18 to 65 years of either gender, patients posted for elective upper abdominal surgeries. Exclusion criteria were patient refusal, ASA status 4 to 6, patients with hypersensitivity reaction to study drug, infection at the site of block, uncorrectable bleeding disorders, patient having neurological psychiatric illness, patient with polytrauma or head injury. Statistical analysis, appropriate statistical software was used for both qualitative and quantitative variables. P-value less than 0.05 was considered as statistically significant. Procedure. On the day of surgery, written informed consent was obtained from every patient. Patients were counseled about the procedure. Patients were examined clinically for ASA grade, weight, height, and physical status. IV line was secured with number 18 gauge cannula in all patients and were connected to the multiparameter monitor for monitoring of heart rate, ECG, SpO2, and non-invasive BP. After adequately preloading with 500 ml crystalloid solution, patients received segmental spinal anesthesia at T10 to T11 intervertebral space using 2 ml of isobaric bupivacaine 0.5% mixed with 0.5 ml of fentanyl using a 25 gauge Winky spinal needle under all aseptic precautions according to the institutional protocol to obtain a sensory block up to T6 being the upper level. All patients were given oxygen at 2 liters per minute via nasal cannula. Level of sensory anesthesia was assessed by pinprick method at 3-minute interval until the establishment of desired block and then at the end of surgery. Motor block was confirmed using modified bromide scale, recorded just before the start and at the end of surgery. Hemodynamic parameters were recorded every 2 minutes for 10 minutes and then every 15 minutes till the end of surgery. The mean duration of surgery being 70 minutes. Post-operatively, patients were shifted to recovery room. Discharge time from recovery room was noted. Analgesia was assessed on the basis of VAS score and patients' demand for additional systemic analgesics. Side effects like nausea and vomiting and residual neurological deficits were noted. Patients were interviewed after the procedure and their responses were graded according to the patient satisfaction scale. My observation and results were as follows. The ratio of male to female was 12:8 and the mean age was 42 years. Hemodynamic parameters intraoperatively were assessed, heart rate and mean arterial pressure, which was seen to be very stable throughout the surgery. Oxygen saturation was maintained throughout the surgery and no patient complained of breathing difficulty. This graph shows the achievement of sensory upper level, which was achieved within 15 minutes in all the patients. And this is the progression every 3 minutes for the first 15 minutes and at the end of surgery. The sensory lower level, this graph shows the achievement of sensory lower level, which was the lower level that was obtained was up to L3. Motor block was obtained according to the modified bromide scale in the form of this graph. As we can see in the beginning, at the start of surgery, most patients were on the scale of 1, and at the end of surgery, there were 0 patients with the bromide blockade of 4. The mean postoperative recovery room discharge time was 60 minutes. The mean VAS score of 20 patients postoperatively was 2.33 when followed for 6 hours. 2 patients out of 20, that is 10%, required IV systemic analgesics within 6 hours. 2 patients, 10%, had hypertension intraoperatively, which was managed with IV ephedrine. 3 patients, 15%, had pruritus intraoperatively, which was managed with IV chlorpheniramine maleate. 10% patients had nausea vomiting postoperatively, which were managed with IV ranitidine and IV metoclopramide. No patient had any residual neurological deficits. Discussion. Our results are in consonation with earlier studies done in terms of conditions which ensure a calm, relaxed patient with good muscle relaxation, which assisted the surgeons during operative procedure. No hemodynamic fluctuations were noted, which would entail use of vasopressors, inotropic supports, or positioning of table for managing BP. Postoperatively, there was limited use of antiemetics and minimal use of analgesics up to 6 hours. There were no pulmonary complications noted as the patients were free of pain in the immediate postoperative period. Promising results mandate the study to be duplicated in future, and randomized multicentric prospective studies need to be advocated to highlight the excellent results for the benefit of patients undergoing upper abdominal surgeries. Conclusion. Our study shows that segmental thoracic spinal anesthesia can be used effectively and safely for elective upper abdominal surgeries. It has more intraoperative hemodynamic stability, reduced oral and parenteral requirement of analgesics and their side effects, and it was overall cost effective for the patient. Thank you.
That was a very nice presentation. Over to our judges.
Yeah, okay, Hiva, that was a good presentation. What
Thank you,
I
ma'am.
could not actually relate to was in the immediate post-operative period, you said you watched the patient immediate post-operative period and there was no additional requirement for analgesics. So what advantage are you getting if you are watching the patient immediately post-operatively and you are sending the patient out? Did you not watch the patient for a longer period because it's ultimately you're giving a thoracic segmental spinal?
Yes, ma'am.
What
Since
has
it was
made you deduce that it's a safe method? You could have injured the spinal cord.
Ma'am, that's what I've told, that in previous studies it has been shown that through MRI scans it has been shown that the
That is all
gap
right.
between.
That is all fine. But we know that this is not an easy procedure. There are chances of injury.
Ma'am,
Isn't it?
there was no.
So why immediate procedure?
Actually, I went through the previous studies and the chances of injury were very less seen in the previous studies. That is why we attempted it. And we saw that there was actually no injury in any patient.
But you have not studied the patient for a longer period post-operatively.
Ma'am, for 6 hours post-operatively, the duration of
24 hours.
analgesia, with isobaric bupivacaine through most of the studies comes out to be around 6 to 7 hours. And in that period, we assessed the patient for any additional systemic analgesics.
Okay, I'm not little. And what about Romage scale? Why are you doing Romage scale in segmental thoracic spinal? How are you going to do
Ma'am, to assess the lower level of anesthesia achieved, to see whether it was actually maintained in a segmental manner.
Okay. Thank you. Jaideep, please carry on.
Overall, it's a nice presentation, Dr. Hima.
Yes, sir. Thank you, sir.
I just want to know what additional advantage you get as compared to general anesthesia if you are using segmental block.
So the pulmonary complications can be avoided, sir, in patients. And other than that, there is more, because GA as such, we have to use more drugs to achieve analgesia, sir. In this case, and those drugs can lead to post-operative nausea and vomiting. In this case, we are giving analgesia in the form of neuraxial blockade, and there is lower chance of post-operative nausea and vomiting, sir. And patient was also less anxious.
And as you told that you are using this technique for the upper abdominal surgeries, will you please name them, what you included in your study?
Yes. Sir, the surgeries that were conducted in my college were mostly open cholecystectomy, incisional hernia repair, and mostly these two, sir.
Okay. So in the patient who had open chole, what is your experience during the study? Patient is more comfortable when you are giving general anesthesia with proper analgesia or when you are doing segmental block?
Sir, in the cases that we saw, patient was actually more comfortable with the segmental spinal anesthesia, sir. It was not a comparative study, but the study the results that we saw were good in terms of less patient anxiety.
Okay.
And patient was more comfortable, sir.
Okay. Overall, it's a nice presentation. Good.
Good.
Thank you.
Thank you. Dr. Ruchi ma'am will be joining in Hall A for her session. And for the remaining part of this session, we will have Dr. Yogesh sir. He is Associate Professor from Ratlam. Dr. Yogesh sir.
Thank you, Himanshu. Thank you so much. Thank you, Jaideep.
Thank you so much, ma'am, for your kind presence.
Yogesh sir. Dr. Yogesh, sir, kindly join us.
Hello.
Yeah, Dr. Yogesh, welcome.
Hello.
Sir, are you able to hear us?
Yeah, I am hearing you, but I'm not able to start the video.
Okay, sir, we will do that for you. The video for you. Yes, sir. Sir, welcome.
Thank you.
So for this free paper session, we are left with 3 candidates, and they are allotted 6 minutes for their presentation and 2 minutes for the question answer session, sir.
Okay.
Yes, sir. So the next candidate is Dr. Shikha Jain. So sorry, we have 4 candidates left. Next is Dr. Shikha Jain. She's a 3rd year MGM Indore.
Okay. So,
good afternoon, everyone. Sir, am I audible now?
Yes, you're audible.
Yeah, good afternoon,
Sir,
Shikha.
should we start?
Yeah, please.
You can.
Thank you, sir. Thank you. Dr. Shikha, your time starts now.
Yes, sir. Good afternoon, respected seniors and my dear colleagues. I'm Dr. Shikha Jain from MGM Medical College, Indore. I'm here to present a paper before you on the title that dexmedetomidine with nalbuphine provides better sedation and analgesia than propofol and nalbuphine in patients undergoing tympanoplasty under monitored anesthesia care, that is MEC. Tympanoplasty is a microscopic surgery, as we all know, which requires a calm and quiet patient and a comparatively bloodless field as compared to other surgeries. Tympanoplasties are usually performed under MAC, that is local anesthesia, along with adequate sedation and analgesia, with preservation of spontaneous breathing and airway reflexes. MAC results in less physiologic disturbance and a more rapid recovery than general anesthesia. Here, combination of commonly used and commonly available drugs are being compared, that is dexmedetomidine, nalbuphine, and propofol. Primary objectives of my study were to assess the level of sedation intraoperatively by Ramsey sedation score and assessment of pain intraoperatively by visual analog scale. Secondary objectives were hemodynamic monitoring at various time intervals, assessment of a surgical bloodless field by Bozard grading scale, and requirement of intraoperative rescue sedation and rescue analgesia, and patient satisfaction by 5-point Likert verbal rating scale. Any adverse events like bradycardia, hypotension, nausea, vomiting were also recorded. Material required: apart from emergency drugs and backup general anesthesia preparation, injection dexmedetomidine 50 mics in 0.5 ml, injection propofol 200 mg in 20 ml, and injection nalbuphine, which comes in 1 ml ampule containing 10 mg. My study is a prospective randomized comparative study conducted on 60 patients with 30 patients in each group. Inclusion criteria: patient aged between 18 to 60 years with ASA class 1 and 2 with BMI ranging from 18 to 25 kg per meter square were included. Excluded were the pregnant lactating females, any patient who were allergic or had hypersensitivity to the study drugs, and the patient who required more than 2 doses of injection midazolam as a rescue sedative were also excluded. Coming to the method, all patients, after prior taking their written informed consent, were pre-medicated with injection glycopyrrolate 0.2 mg IM about 30 minutes prior to the start of the surgery. Then all patients received injection nalbuphine 50 mg per kg IV when they came in the operation theater. The patients who were allotted group D were given the bolus dose of injection dexmedetomidine at the dose of 1 mg per kg over 10 minutes, which were followed by an infusion of 0.3 mg per kg per hour. Patients who were in group B received the bolus dose of propofol at the dose of 750 mg per kg, and then an infusion was started at the 25 mg per kg per minute. Rescue injection midazolam at the dose of 10 mg per kg and rescue analgesic paracetamol 1 gram were kept ready if RSS was less than 3 and VAS was more than 3 respectively. 3 tests were used for statistical analysis, that is unpaired t-test, Mann-Whitney U-test, and Friedman test. Now, Coming to the results, all patients were comparable in regards to their demographic profile, their baseline vitals, and the duration of surgery in both the groups. What we found that the sedation score, that is RSS, was slightly higher in the group B, with the mean 4.24 plus minus 1.5, and it was less in group P, that is mean was 2.5 plus minus 0.95. So the requirement of injection midazolam as a rescue sedative was less in group D. It accounted only for 6% of the patient, but injection midazolam was required in higher number in group P, that accounted for 24%. Pain score, if we talk about pain score, then it was less in group D. Mean was 3.5 and in group B it was 5.4. That is, the pain experienced by the patients in the group D was less. Hence, the requirement of rescue paracetamol was only 8% in group D, which was 26% in the group T. Now, the two parameters which concerned us were the bradycardia and hypotension. Bradycardia and hypotension occurred in higher number in group D. That is, around 24% of the patient in group D had bradycardia episodes as compared to group B, which was only 11%. Coming to hypotension, 26% in the group D patient had hypotensive episodes and only 14% had hypotension in group T. And close monitoring was mandatory. These are the graphs which I have spoken. They are showing that values only. Now coming to post-operative period. In the post-operative period, sedation and VAS score were followed till 5 hours, every hour till 5 hours. Sedation score was 3.2 in group D, while it was nearly comparable, that is 3 in group T. But coming to pain score, then pain score was 3.2 in group D and it was 3.8 in group T. That is, it was statistically significant also. Then mean patient satisfaction score and mean bleeding score were also checked and noted, and it was 2 and 4 in group D and group P respectively. Now, I have been talking about sedation score, and which we noted at the time interval at 0, 10, 30 minutes, and then after every 30 minutes till 120 minutes. And it was consistently higher at every point in group D than compared to group T. Pain score was noted at 2 points, that is just after the induction and just at the end of the surgery, which was less in group D. That is, patient experienced less pain in group D. Then for bleeding score, surgeons were asked post-operatively about how was the surgical field in terms of bleeding, and then it was noted, and the mean calculated was 2 and 4 in group D and T. About the satisfaction score from the patient's point of view, we asked the emergence from sedation, whether it was smooth, whether the surgery was painful, or patient had an episode of nausea, dry mouth, etc. And hence it was calculated about calculating the parameters from all these values, which came out to be 2 and 4 in group D and group P. So overall, what we concluded was that dexmedetomidine and nalbuphine combination is superior to propofol and nalbuphine combination in producing sedation and decreasing VAS in patients undergoing tympanoplasties under MEC. Better surgeon and patient satisfaction were observed with dexmedetomidine nalbuphine combination, but hemodynamics need to be closely monitored. These are my references. The third reference, that is Dr. Nellam, Chiruvella and Reddy, had the same results, and this is the Cochrane study itself. Thank you, sir.
Thank you, Dr. Shikha. That was a very nice presentation. Over to our judges.
Yeah, it's a nice presentation by Dr. Shikha.
Thank you.
Shikha, I want to ask only one question to you. Is any patient had respiratory distress during your surgery?
Sir, respiratory distress was not seen, but for respiratory distress, the parameter which we recorded was saturation at SpO2. So, sir, we considered that if the saturation falls below 94%, that patient is in respiratory distress, and we used to increase the oxygen from 2 to 6 liters. This was in our theory.
As a protocol, you are insufflating 2 liters to each and every patient?
Yes, sir. Yes, sir.
Okay, good. To Dr. Yogesh.
Yeah, it was a nice presentation. Dr. Only one question from my side, that you used dexmedetomidine. Have you
Yes.
observed excessive sedation?
Sir, over sedated was no, sir. None of the patient was over sedated, sir. But we were ready that if the RSS goes beyond 4 or 5, then we have to convert that procedure into general anesthesia. But sir, none of the patient was over sedated in our study.
Okay. It was a nice presentation.
Thank you, sir.
Thank you, sir. Our next presenter is Dr. Manju Lata Shakya. She is from NSCB Medical College, Jabalpur. Dr. Manju.
Hello.
Hello.
Hello. Am I audible?
Yes, you're Dr. Manju Lata.
Is my screen is visible?
Your screen is not visible currently.
Now it is visible?
No, it is not visible, ma'am. Hello, Dr. Manju.
Yes.
Ma'am, your screen is not visible. You should press that share screen option on your screen.
I have pressed it.
Ma'am, are you using a laptop?
Yes, I am using laptop.
Okay.
Actually, it is visible to me, but it,
Ma'am, do one thing. Stop sharing your screen and try it again.
okay. Actually, my presentation is on desktop. So how should I drag here?
Your presentation is on desktop and you're using your laptop.
Yes.
That is not going to happen, ma'am. You have to keep your presentation in your laptop only.
Yes, it is in laptop.
Okay, ma'am. Ma'am, so just do one thing. Just stop your screen sharing option and start it again.
Now
Yes,
it is
ma'am.
visible.
Yes, ma'am. Now we are able to see it, ma'am. Please full screen it, and you can start with the presentation.
Now
Yes,
it is visible to everyone.
yes, ma'am.
Okay. Good afternoon, respected judges. My study topic is comparison of analgesic efficacy of ropivacaine versus bupivacaine, installation through surgical drain, modified radical mastectomy, a randomized clinical study. Introduction. Brace surgeries are the lumpectomy or modified radical mastectomy with the axillary node dissection remains the treatment of choice for breast cancers. Traditionally, post-operative pain could be reduced by taking narcotics or NSAID drug, but they also cause nausea, vomiting, and dyspepsia. Various local and regional anesthetic techniques like intercostal block, brachial plexus block, thoracic block, also evaluated in the past to reduce early post-operative pain after breast surgery, but they were more time-consuming, discomfort to patient due to fear of needle pain, failure of procedure, need more advanced techniques. Due to fear of needle tract seedling and cutaneous spread of malignancy, infiltration along the line of surgical incision is not recommended in malignant lesion. The technique of infiltration or irrigation of local anesthetics is less invasive, cause prompt pain relief, more patient satisfaction, early mobilization, plastic reconstructive brace surgeries without adverse effect. This is the diagram how surgeon insert the drain and we instill the through this. Bupivacaine is an ideal choice for local anesthesia in brace surgery through installation in the dissection space because of long-acting efficiency in the similar applications. Moreover, ropivacaine is also structurally related to the bupivacaine and has less central nervous system and cardiovascular side effects, but effect was not so prolonged as by the bupivacaine. Aims and objectives. Aims was to compare efficacy of ropivacaine 0.2% versus bupivacaine 0.25% for post-operative analgesia after MRM. Duration of analgesia was the primary objective, and secondary objective was total analgesia requirement and side effects. Material and method. It was an randomized prospective double-blind control study. Informed consent was taken from each and every patient. Study was proceeded after ethical committee approval. Inclusion criteria was 90 female patients of age group 40 to 60 years, ASA grade 1 and 2, posted for MRM under general anesthesia. Exclusion criteria was history of chronic analgesic drug usage, allergy to local anesthetic drug, history of clinical significant CVS, pulmonary, hepatic, renal, neurologic, psychiatric, and metabolic diseases. Breastfeeding and pregnant patient also excluded. Expected major blood loss and bleeding episodes also excluded from the study. Study group patients were randomly divided into 3 groups of 30 patients in each group. Group B received ropivacaine 0.25% through axillary and chest drain. Group R received ropivacaine 0.25%, and Group S received normal saline 0.9% through axillary and chest drain. All patients were kept nil orally for at least 8 hours prior to surgery. After shifting patient to OT, monitors were attached and baseline parameters like NIVP, pulse oximeter, saturation, ECG were recorded. Operatively, all patients were educated about the VAS score for pain. All patients were uniformly pre-medicated with injection glycopyrrolate, ondansetron, and fentanyl. Then, after pre-oxygenation for 3 minutes, patients were induced injection propofol 2 mg per kg IV. Muscle relaxation was facilitated with injection suction alcohol. Patient was intubated and maintained an oxygen is to nitrous oxide 30:70 ratio, sevoflurane, and injection atracurium 0.1 mg per kg intermittently. After the completion of surgical procedure, 2 drains were placed by surgeons, one in axilla near the axillary vessels and second in the chest wall below the skin flap over the pectoral muscle. A study drug was given to patient through each drain in divided doses after closure of incision, and then drain was clamped for 10 minutes. After that, release the clamp and allow the test solution into the negative pressure suction drain. All patients were allowed to receive intravenous paracetamol infusion 1 gram in 100 ml normal saline as background analgesic immediately after extubation, then 8 early. Rescue analgesia given in form of injection tramadol 2 mg per kg intravenously. Pain score at 0 hours and 4 hours up to 24 hours noted. Pain was assessed using VAS score. If the VAS exceeded any time more than 4, then rescue analgesia were given in form of tramadol. All the patient received prophylactic ondansetron, so adverse effects like nausea and vomiting were not noted. This is the diagram showing VAS score. 0 means no pain, 10 means worst possible pain. Observation result of the study. Observation by decoded and tabulated statistical analysis were done by ANOVA test, chi-square test, and post-hoc Turkey test. Statistical analysis carried out using SPSS version 20 for comparison p-value less than 0.5% was significant. This is the demographic characteristic and duration of surgery between the group are statistically insignificant. This is the table showing duration and rescue analgesia. Duration of analgesia was highest in group B, ropivacaine group, and duration of analgesia was lowest in group S, normal saline. Rescue analgesia requirement was highest in group S, normal saline, and was lowest in. It was comparable in group bupivacaine and ropivacaine. This is the VAS score. Group B and group R comparable in VAS score. The mean duration of analgesia in bupivacaine group was 14.8 hours. It was 12.9 hours in ropivacaine group and 5.7 hours in normal saline group. There was a significant difference between group S and group B and between group S and group R. So p-value less than 0.001. The analgesia with senile was variable, and there was no difference in the duration of analgesia when compared to group B and group R. There was statistically significant difference between group B and group S and between group R and group S in terms of total tramadol consumption. There was no local anesthetic toxicity, wound hematoma, infection, or delayed wound healing in any of the patients. Discuss the infiltration and installation of local anesthetic at operative site can improve post-operative analgesia, reduce OP requirement. Local anesthetic drugs like bupivacaine and ropivacaine have been increasingly popular for treating surgical pain because of their long-lasting analgesic property and lack of opioid-induced adverse effects. So, finding of our study are 0.25 of bupivacaine and 0.2% ropivacaine was equally effective for post-operative analgesia through surgical drain. It caused better reduction of VAS score, reduction of total amount of rescue analgesic, duration of analgesia was longer, lack of opioid-induced adverse effects as compared to control group. The study similar to our study was Talbot et al. Also done a study determined the effect of local anesthetic indication of axillary drain following modified fatty mastectomy. Culliford and Casimir et al. In their study irrigation of local anesthetic local anesthetic was reported with high level of satisfaction regarding post-operative pain, and author has have recommended this technique of analgesia for all the cosmetic based surgeries. Raman et al. Conducted comparative study between analgesia effect of bupivacaine and opivacaine infiltration in the bilaterally symmetric based surgery model and found that overall analgesia achieved with bupivacaine and opivacaine infiltration was not statistically different except for the risk of cardiotoxicity with the bupivacaine. Our study shows that VAS score rises early in group R than group B, but not very significant. When VAS score reached more than 4, rescue analgesia in form of tramadol was given. In our study, we observed that 0.25% bupivacaine caused post-operative analgesia up to 14.8 hours, and 0.2% opivacaine caused post-operative analgesia up to 12.9 hours, as shown by the study of Patel et al. In our study, there was no case of local anesthetic toxicity, infection, hematoma, and wound lesions observed, which was in concordance with the study of Jona Vitula and Talbot et al. The administration of local anesthetic by instillation for surgical drain is one component of multimodal approach that allow for minimal invasive exposure and also result is immediate pain relief, which have been proven to increase patient satisfaction and early mobilization. So conclusion, post-operative analgesia with bupivacaine was 14.8 hours and with bupivacaine was 12.9 hours. Due to less cardiovascular toxicity and central nervous system effect, bupivacaine is still better to bupivacaine. Limitation of our study was single center study, sample size was low, only VAS score rest was measured, and future recommendation with multi-center study, last sample study to confirm the finding. These are some differences. Thank you.
Thank you, ma'am. That was a very nice presentation. Now over to our judges.
Yeah, overall, it's a very nice presentation. Dr. Manju ma'am.
Thank you, sir.
You are making things simplified by replacing regional anesthesia or rescue block with local infiltration with the help of drain. So there is only one query. If you are putting local anesthetics, how you or the surgeon is assessing the drain which is coming from the surgical side?
Drain was.
Hello, ma'am, you are not audible.
Hello.
Yeah.
Hello.
Yeah. Now you are audible.
Drain was inserted by the surgeon. And sorry, I'm not.
No, my question: the drain is putting to assist the blood or the collection of blood at the surgical plane, and if you are putting local anesthetic at the same plane, how you assess the blood loss or the drain which is coming from the surgical side?
Actually, after installation of the drug, we had clamped the we had clamped this drain for up to 10 minutes. After that, we release it.
Okay. Dr. Yogesh, over to you.
Yes. Manju madam, that
Yes,
was a nice presentation.
Thank you.
I have to you have used bupivacaine and opivacaine. So, but the results were insignificant. So, how can we compare both? Which is better? What criteria you chosen? What criteria chosen? What criteria?
Actually, both are comparable. For bupivacaine cause cardiotoxicity, one of my colleagues has done the study with bupivacaine. So, I had in mind that there should be one study with bupivacaine.
Okay.
So, I have done this study.
Okay, that is enough.
Okay. Thank you.
Okay, come to the next speaker.
Thank you, sir. Thank you, ma'am. Our next speaker is Dr. Saurabh Srivastav. Dr. Saurabh Srivastav, sir.
Hello.
Hello.
Am I audible?
Yes, sir. You are audible, sir.
अभी पापा काम कर रहे हैं ना उधर बैठ
Please share your screen.
Hello.
Share your screen.
Yes, sir. Sir, you are audible, sir. Please share your screen. Dr. Saurabh, sir.
Screen is sharing.
Sir, your screen is not visible, sir. Sir, have you clicked on that share screening option?
Yes.
Please, sir, stop sharing and please try it again, sir.
Okay. I am trying to share screen.
Yes, sir. Please go on with it.
Share.
इसको 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 वो कर दो, बंद मत करना।
डेस्कटॉप पे था ना। Is my screen visible?
Yes, sir. Your screen is visible. Yes, sir. Your screen is visible. You are just make it full screen and you can start with your presentation.
Myself, Dr. Saurabh Srivastava, presenting a study that our title is Comparison of two different doses of intrathecal desmoid-ditomidine on the characteristics of spinal anesthesia. Introduction. Subarachnoid block is a well-established technique. It is technically easy, fast in onset, and provide effective sensory and motor blockade. Bupivacaine is a commonly used local anesthetic drug in spinal anesthesia. However, duration of spinal anesthesia by bupivacaine is limited up to 75 to 150 minutes. Therefore, for prolongation and improving quality of anesthesia, various adjuvants like desmoid-ditomidine, clonidine, opioids, neostigmine, ketamine, and epinephrine were used along with
Sir, we are not able to hear. Dr. Saurabh, sir, you're not audible. Hello, Dr. Saurabh, sir, am I audible to you? Dr. Saurabh, sir, am I audible to you? Sir, Dr. Saurabh, sir, has logged out from this session. Give us the permission to call on the next participant, sir.
Okay, how many participants is left?
Sir, after Saurabh, sir, only one participant is left.
Okay, let's start with them.
Okay, sir. Next participant is Dr. Shikha Goyal. Dr. Shikha Goyal, if you can hear us, unmute yourself.
Call the next contestant.
Yes, sir, we are calling the next contestant.
Yes,
Dr. Shikha Goyal?
Yes, I am audible.
Okay, share your screen.
Okay.
Am I audible?
Good afternoon. My topic is effect of venous magnesium sulfate on cardiovascular response during tracheal extubation in patients undergoing craniotomy. Tracheal extubation causes a modest and transient increase in heart rate and blood pressure. These changes has a major concern for patients with coronary artery disease, cerebrovascular disease, and in hypertensive patients. These changes and particular arterial hypertension may increase the risk of post-operative intracranial edema and hemorrhage in craniotomies. In literature, a variety of drugs and techniques have been used for control of these changes, including esmolol, fentanyl, diltiazem, verapamil, and lignocaine, but none has been completely successful. So we use the magnesium sulfate, which is a naturally occurring calcium antagonist, non-competitive antagonist at NMDA receptor. It inhibits the release of catecholamine from both adrenal glands and adrenal terminals. It involved in several processes like control of vasomotor tone, cardiac excitability, neurotransmitter release, and modulation of pain. It also attenuates the adverse hemodynamic response associated with the intubation. So my aims are assess the effect of study drug on cardiovascular stress response during extubation and any untoward side effect of the study drugs. We include the patients of ASA grade 1 and 2 with the age group of 18 to 50 years of either sex, and we exclude the patient with known history of allergy to study drugs, patients with cardiopulmonary disease, patients on antihypertensive, antiarrhythmic, adrenoreceptor agonist, and antagonist, patients with patient who require the post-operative ventilation. Patients of 60 patients of ASA grade 1 and 2 scheduled for non-vascular intracranial space occupying lesion under general anesthesia but divided into two groups randomly using sealed envelope technique. In group C, we have given the 100 ml normal saline over 10 minutes, and in group M, we have given the 30 mg per kg injection magnesium sulfate prepared in 100 ml saline over a period of 10 minutes. After pre-medication and pre-oxygenation, general anesthesia was induced with injection of thiopental sodium 5 mg per kg body weight, and endocranial intubation was facilitated with injection with uranium 0.12 mg per kg body weight. General anesthesia maintained on nitrous oxide, oxygen, and maintenance dose of injection with uranium, and intermittent isoflurane was given using vein anesthetic circuit. At the time of skin closure, study drug was given in 100 ml saline over a period of 10 minutes. Residual neuromuscular blockage was reversed by injection myocardial. Once patient met the sign of adequate reversal, extubation was performed, and all patients were given oxygen by face mask during recovery period. Heart rate, systolic blood pressure, diastolic blood pressure were recorded just before and 3 and 5 minutes after study drug administration, during extubation, and 3, 5, 10, and 15 minutes after extubation. Respiratory rate and SpO2 were recorded at 3, 5, 10, and 15 minutes after extubation. With the power of study being 80%, confidence level 95%, sample size required to detect 30% reduction in hemodynamic parameters was 24, and we conduct study with 30 patients in each group. Statistical tests used were chi-square test and paired and unpaired student t-test by software SPSS 17. A p-value less than 0.05 was taken as statistically significant. We found this table has shown it shows the demographic profile are comparable in both the groups. In this graph, we have shown that heart rate was higher in control group during extubation at 3, 5, and 10 minutes after the extubation as compared to group M. In this graph, we have shown that the systolic blood pressure less in group M during extubation at 3 and 5 minutes after study drug administration, 3, 5, and 10 minutes after the extubation. Diastolic blood pressure was lower during extubation 3, 5, and 10 minutes after the extubation. This graph has shown that side effects are comparable in both the groups. In our study, heart rate was increased at 2 minutes after mentioned infusion. This may be due to the fact that inhibit the release of acetylcholine from the vagus and produce tachycardia initially. It was higher in control group as magnesium sulfate group due to after. This was probably due to epinephrine level in magnesium sulfate group did not increase as significant as in control group. Our study supported by the RRC et al. And Montazeri K and Polar. These studies support the use of safe dose of IV magnesium sulfate 30 mg per kg, which was similar to our study with no incidence of adverse effects. And also IV magnesium sulfate for stabilization of heart rate during intubation and similar result. From our study, it was observed that systolic blood pressure was lower in group M compared to control group at all time, from 3 minutes of study drug infusion to 10 minutes after extubation, and blood pressure was lower during extubation till 10 minutes after the extubation. Our results are in accordance with RRC and et al. And et al. Shivering and nausea were observed in control group. Besides these, no untoward side effect was found in any group. Difference was statistically insignificant between two groups. Ripley G et al. Also found a similar result with the magnesium sulfate. So we conclude that mentioned sulfate administration before the extubation significantly decreased the cardiovascular response to tracheal extubation.
Very nice presentation, Dr. Shikha Goyal. Over to our judges.
Yeah, it's a nice presentation by Dr. Shikha. Dr. Shikha, how you assess magnesium sulfate toxicity?
We assess by the deep tendon reflex, by urine and by respiratory rate.
What you are getting in respiratory rate?
There is a respiratory rate is decreased.
Okay. Okay, to the next candidate, or to Dr. Yogesh.
No further question. You can call the next candidate.
बंदरिया आहा बंदरिया आहा दो बोल दो बंदरिया मेरी बंदरिया है ना
Is there any other candidate?
Sir, no other candidate is left.
Yes,
We will resume with Dr. Saurabh, sir. His presentation was left in between. Sir, with your permission, can we allow him to present his rest of the presentation?
Yeah, please go ahead.
Okay, thank you, sir.
Yeah, you can call.
Am I audible?
Thank you, sir. Yes, sir, you're audible, sir. Please share your screen.
Okay.
Shikha, please turn off your Shikha, hello.
My screen is sharing.
Yes, sir, your screen is visible to us. Please go to that slide that you have left with.
Okay. Material and method. It is a prospective hospital-based randomized double-blind study. The study was carried out in the Department of Anesthesiology, GTB Hospital, New Delhi. Selected 90 patients scheduled for elective below umbilical surgery were randomly allocated to one of three groups. Group 1, having 30 patient, control group received 3 ml hyperbaric bupivacaine plus 1 ml normal saline. Group 2, having 30 patients, received 3 ml hyperbaric bupivacaine plus 5 microgram desmedetomidine 0.5 ml plus 0.5 ml normal saline. Group 3 received 3 ml hyperbaric bupivacaine plus 10 microgram tomidine 1 ml intrathecally. Desmedetomidine was diluted in normal saline to make constant volume. Exclusion criteria for patient: non-history of sensitivity to bupivacaine, body weight greater than 100 kg and less than 45 kg, and height less than 145 centimeter. Patients on any drug treatment, patients having systemic disease, coagulopathy, bleeding disorder, history of spinal cord surgery, vertebral deformities, and infection at the site of block. All the patients technique. All the patients were to be kept nil orally for at least 6 hours before procedure. Intradermal sensitivity test of bupivacaine was performed. Preloading of 1 liter RL was started with 18 gauge cannula half hour before start of anesthesia. A midline subarachnoid block was performed at L3, L4 or L4, L5 intervertebral space with the patient in lateral decubitus position using a 25 gauge Quincke spinal needle. Thereafter, the patients were placed in the supine position for surgery. During surgery, crystalloids, colloid, and blood were administered according to requirement to maintain hemodynamic stability. Monitoring: pulse rate, ECG, non-invasive systolic and diastolic BP, respiratory rate, and peripheral arterial hemoglobin oxygen saturation, SpO2 were monitored preoperatively and intraoperatively. For study purpose, data were recorded at 0, 10, 20, 40, 60 minutes after intrathecal injection and thereafter every hour up to 8 hours. Criteria for bradycardia is having a patient pulse rate less than 60 per minute, hypotension, is patient having a fall in systolic BP greater than 30% from the baseline value. Respiratory depression is defined as a patient having a respiratory rate of less than 10 breaths per minute or SpO2 less than 90%. Anesthesia parameters to be monitored are onset time of sensory blockade, defined as time taken from intrathecal drug injection to loss of sensation up to T10 level by pinprick. Duration of sensory blockade is time taken from onset of sensory block to regression below T10. Duration of analgesia, that is pain relief, is defined as time taken from onset of sensory block to the first patient request for supplemental analgesia. Onset time of motor blockade is time from intrathecal drug injection to development of grade 3 motor blockade of Bromage score, that is inability to move legs and feet. Duration of motor blockade is defined as time taken from onset of complete blockade, motor blockade, to the time when the patient was just able to flex knee with free movement of feet, that is grade 1 motor blockade. Intensity of pain and VAS score at the time of first analgesia request was recorded. Assessment of pain was done by visual analog scale. When patient complained of pain post-operatively, VAS score at time of first analgesia request recorded. Then IV infusion of diclofenac sodium 75 mg over 30 minutes in 100 ml saline was given, and the study of that patient was taken as complete. All patients were followed for 24 hours. Statistical analysis. Significance of differences in outcome variable between groups was tested by chi-square test for proportions. ANOVA was used for comparing the significant difference between the three groups. P-value less than 0.05 was considered statistically significant. These are the observations. This table shows that there were no statistically significant difference among demographic variables, and all the groups were similar. Parameters of spinal anesthesia were monitored. This table shows parameters of spinal anesthesia like onset time of sensory blockade, duration of sensory blockade, duration of motor blockade, and duration of analgesia. On statistical comparison, we found highly significant differences among duration of analgesia, sensory and motor blockade. There is also significant difference among sensory and motor onset. That is, desmethadone prolonged the duration of spinal anesthesia in a dose-dependent manner. This table shows side effects and complications. On statistical comparison, we found that the addition of intrathecal desmethadone up to 10 microgram does not significantly increase any major side effect except mild sedation. Results. Intrathecal desmethadone 5 microgram and 10 microgram does not affect VAS score at the time of first analgesia request. The duration of sensory blockade was prolonged by about 20 minutes in group second and by about 27 minutes in group third. Duration of motor blockade was prolonged by about 18 minutes in group second and by about 26 minutes in group third. The duration was analgesia was prolonged by about 48 minutes in group second and about 86 minutes in group third. Onset of sensory and motor blockade was earlier in group second and group third than group first. Discussion and conclusion. Our study shows that intrathecal desmethadone as an adjuvant up to 10 microgram prolong the duration of spinal anesthesia in a dose-dependent manner with early onset of blockade without increase in significant side effect. Desmethadone is a specific and selective alpha-2 adrenoceptor agonist. Activation of receptors in the brain and spinal cord inhibits neuronal firing and lead to symptomatic effects causing hypotension, bradycardia, sedation, and analgesia. The reason for prolongation of duration of analgesia, sensory and motor blockade may involve both vasoconstrictions and anti-nociception from alpha-2 receptor stimulation in substantia gelatinosa of spinal cord produced by intrathecal desmethadone. Our findings were consistent with the results of Mohammed A. et al., Eid H. et al., Al Mustafa M. et al., Hogan S.F. et al., and Shukla D. et al. These are the supporting studies. Thank you.
Thank you, sir. That was a very nice presentation. Now over to our judges.
Yeah, it was a nice presentation. Was there a bradycardia observed with both the doses, 5 microgram and 10 microgram?
Sir, no significant bradycardia, sir, was not observed. In our definition, bradycardia is defined less than 60 per minute.
Okay. Excessive sedation?
Sir, only in group third, in which a patient received 10 microgram, observed that Ramsey sedation 4. The patient respond to glandular tap and no significant sedation in other groups.
Okay. Yeah, Dr. Jaydeep. Any question?
Dr. Jaydeep, sir. Dr. Jaydeep.
No questions from my side. Hello.
Hello.
Hello. This will hello. Thank you, sir. Thank you so much. This will conclude our section D for the free paper presentation. I would like to give a big thanks to our judges, Dr. Yogesh Tilkar sir and Dr. Jaydeep sir, for being there with us. And that was a very fruitful session. Lots of new ideas we have heard, and with the expert guidance from our judges, it had become more knowledgeable to us. Dr. Yogesh sir, you are with us for the next session also.
Yes, yes.
So sir, should we start with the next session too?
Yeah, you can start new
Participants
session.
are already here. So okay, so the next
You
session
can call
is
the first contestant.
yes, sir. So this is a group A for the poster presentation, and with our two judges, Dr. Pooja Singh ma'am. She's associate professor, Department of Anesthesia, AIMS Bhopal. She's MBBS, MD Anesthesiology and PDCC in Cardiothoracic Vascular Surgery. And we have Dr. Yogesh Tilkar, associate professor, Department of Anesthesia, GMC Ratlam. He has done his MD Anesthesiology from GMC Bhopal. And ma'am, are you with us?
Yes, I am with you. Yeah.
Okay, ma'am. Ma'am, should we start with the presentations?
Yeah, sure.
Yes.
Go ahead.
So, sir and ma'am, we in this poster category, we have allotted total 7 minutes to the candidate. That will be 5 minutes for the presentation and 2 minutes for the question answer session. And all the participants are requested to complete their presentation within 5 minutes. 3-4 minutes are enough for the poster presentation. We have given you 5 minutes, so I will assume that all of you will be able to finish it in 5 minutes. So with that, I will call the first candidate, that is Aditi Kaushal. Aditi Kaushal, please unmute yourself and share your screen.
Hello, good afternoon.
Good afternoon, Aditi. Please share your screen.
Yes.
You have 5 minutes. Okay. You can start now.
Hello, good afternoon, respected faculty members and all the delegates present. I am Dr. Aditi Kaushal from Mahatma Gandhi Medical College, Indore, and today I'll be presenting my poster on low flow anesthesia. My guide is Dr. Manish Manjare sir, and the HOD of my department is Dr. K.K. Arora sir. Introduction. Low flow anesthesia is a technique that employs fresh gas flow less than the alveolar ventilation. Low flow anesthesia is defined to be an inhalational anesthetic technique in which the rebreathing fraction at least amounts to 50%, where 50% of the exhaled gas mixture is returned to the patient after CO2 removal in the next inspiration. Using modern anesthetic machines, this can be achieved when fresh gas flow is reduced to at least 1 liter per minute or less. This is a table showing the amount of fresh gas flow that is to be supplied to the patient. In low flow anesthesia, we supply 500 to 1000 ml of fresh gas flow to the patient. Now, there are different types of anesthesia techniques. We can use medium flow technique, in which the patient is supplied with 1 to 2 liters of fresh gas flow. Minimal flow anesthesia technique, in which we supply 250 to 500 ml. In metabolic flow anesthesia technique, we supply about 250 ml and less. Now, what are the benefits of the low flow anesthesia technique? Physiological benefits is that it preserves heat and humidity of the inspired gas. It conserves body temperature. It reduces water loss from the patient and maintains humidity. It increases mucociliary clearance. It improves airway epithelial health. It reduces accumulation of dried airway secretions by maintaining the humidity. There are ecological benefits as well. Economical benefits are reduced anesthetic gas consumption and significant cost savings. Ecological benefits are reduced overflow of the fluorocarbons and nitrous oxide, reduced greenhouse effect. Environmental benefits as well. There's reduced OT pollution. Now, what are the requirements for this low flow anesthesia technique? We need anesthesia machines that are capable of delivering lowest gas flow. Low flow meters calibrated to 50 ml per minute. We need a leak-proof circle breathing system. We need accurate gas monitoring system. We need vaporizers capable of delivering high concentrations and calibrated to be accurate at low fresh gas flow. We need breathing system with minimal internal volume. This is a typical anesthesia workstation that that we can use for a low flow anesthesia technique. The Gothenburg technique of induction of anesthesia says that for 6 minutes we have to supply oxygen at 1.5 liters per minute and nitrous oxide at 3.5 liters per minute. And in the maintenance phase, we can reduce the oxygen to 4 liters per kg per minute, and we can adjust the nitrous to maintain a constant oxygen concentration in the circuit using oxygen analyzers. Now, conclusion: safety features of anesthetic machines today and accurate gas monitoring offer strong footing to low flow anesthesia practices. Availability of reliable guidelines simplified the clinical application of quantitative anesthesia. It is a resource efficient, economical, and safe procedure for patients. These are my references. Thank you.
Thank you, Dr. Aditi. Over to our judges.
Okay, Aditi, am I audible to you?
Yes, ma'am.
So what are the drawbacks of low flow anesthesia? Like you have shown, what are the advantages, but what are the drawbacks?
Yes, ma'am. Ma'am, the drawbacks are when we have to wash out certain toxic gases from the patient. If the patient has inhaled smoke or there's cyanide intoxication, ma'am, we can't apply the fresh gas anesthesia techniques in those conditions. Ma'am, also we can't use these techniques for in malignant hypothermia patients and in patients in diabetic ketoacidosis or metabolic acidosis. Where we have to provide adequate oxygen and wash out CO2 from the system.
Okay. So, Dr. Yogesh, you carry on with your questions.
Good afternoon.
Yeah. Good afternoon. What are more advantages of this low flow anesthesia? You can.
So, there are many advantages of this this anesthesia technique. It is basically a quantitative anesthesia technique where we are supplying the patient with the amount of gas that he needs. We are not supplying him with more with more than what he requires. In today's scenario, in the COVID era, so we have to supply adequate oxygen that is needed for the patient, sir.
Okay. Okay. Thank you.
Thanks.
Okay.
Thank you. Our next participant is Dr. Akhilesh Chaudhary. Dr. Akhilesh Chaudhary, unmute yourself and share your screen. Dr. Aditi, can you stop your screen sharing option? Dr. Akhilesh Chaudhary, please unmute yourself and share your screen.
Yes. Am I audible, sir?
Yes, you're audible. Start with your presentation.
Good afternoon, respected judges and the moderating team. Myself, Dr. Akhilesh Chaudhary from Gandhi Medical College, Bhopal. I am presenting a poster on a huge meningioma and anesthetic implications, a case series. Introduction. Meningiomas are the most common benign intracranial tumor. They become huge and debilitating and known to bleed. Aim and goal of this study is to provide the adequate surgical condition with the sleek brain and the low intracranial pressure. There are total 5 cases studied. Case 1 is of the temporal lobe meningioma. A 50-year male patient came with the complaint of the unable to walk or to stand by himself. Case 2 is the parietal meningioma. A 35-year female patient with complaint of the numbness in the right side of her body with multiple episodes of the focal seizures. Case 3 is of the frontal lobe meningioma. A 35-year male patient came with the complaint of the diminution of the vision, antisocial behavior, and episodes of seizures. The case 4 is of occipital meningioma, 41-year female patient with complaint of the right-sided weakness and inability to speak. The 5th and final case studied was of the temporal parietal meningioma, a 45-year female patient came with the complaint of the headache, giddiness, and episodes of the seizure. Now, the anesthetic implications include the preoperative and the intraoperative management of this kind of the patient with meningioma. What are the challenges preoperative and how they are managed? Raised ICP is the foremost concern, and it is managed preoperatively by giving the steroid and the osmotherapy, osmotic diuretics like mannitol. Sedation is avoided because it can hypoventilate or increase the hypercapnia, which can lead to the increased ICP. If the patient having the associated comorbidities like the hypertension, we should continue the antihypertensive drugs till the morning of the surgery. If patient is diabetic, we have to shift the patient on the insulin if the patient is on the oral hypoglycemic agents. Drugs we can provide to patient are the anticonvulsant like the phenytoin, but phenytoin is an enzyme inducer which can prolong the prolonged use of phenytoin will result in the more requirement of the anesthetic drugs. Steroids should be started 40 hours before the surgery to reduce the brain edema. Now, the challenges we face intraoperatively and how they are managed. We have to monitor all the standard monitoring, and the direct intra-arterial blood pressure should be considered along with the AVG and the blood catheterization as we are giving the osmotic diuretics to the patient. Induction should be smooth to reduce the ICP and the blunt the noxious effect of the laryngoscopy and the intubation. Positioning. Ensure the optimal venous drainage to avoid the venous air embolism. Before and after positioning, tracheal tube should be secured and checked for the equibilateral entry. Flexometallic tube is preferred over the normal endotracheal tube because of the positioning of the head. Patient is mostly positioned and cradled on the Mayfield horse head rest with the left or the right tilt. More tilt leads to the high airway pressure. Raised intracranial pressure. High airway mean pressure avoided. Maintain the normocarbia with 35 to 45 mm of the Hg. Diuretics should be given. Avoid hypoxia. Mean arterial pressure reduction is required if the cerebral autoregulation is affected. IV fluid management. The neurosurgical patients are more prone to the hyperglycemia, so we should avoid the fluid containing the glucose, limited to the glucose-free isotonic crystalloids. Maintain the normovolemia. Avoid use of the ringal lactate as it is hypotonic to the plasma. Plasmolytes are preferred over the RL. Administer the colloids, blood and the blood products to overcome the surgical loss and the shock. Emergency. Straining or the bucking should be avoided. It can lead to the increased intracranial pressure and increase bleed. Consider the prophylactic use of the labetalol to attenuate the hypertension during emergency. Rapid awakening facilitate the immediate neurological examination, which is far most important in prognostic. Conclusion: the management of the huge meningioma are challenging not only for the surgeon but also for the anesthesiologist. Bleeding is the most common complication. Numerous other factors also govern the post-operative outcomes. Below are my references. Thank you.
Okay, Dr. Akhilesh.
Yes, ma'am.
You have told me that the one of the measures to reduce ICP is to maintain hypocapnia, isn't it? No.
Avoid hypercapnia.
Avoid hypercapnia. So you want to maintain the normocapnia in these patients. But still, if the ICP is raised despite all the other measures, like you have mentioned, steroid, osmotherapy, and all, and diuretics, can you further reduce your CO2 level at till what level you can take the EtCO2 level, acceptable CO2 level? Is it possible to reduce it further?
Yes, up to 30 mmHg.
Okay. Yes. Despite all the measures, if the ICP is still raised, you can reduce up to almost 25 to 30 mmHg. Yeah. And like you said, your patient was hypertensive. Huh?
Yes.
So if the patient is having labile BP, like at one point of time, like if you are taking up the case of meningioma, you will obviously put the arterial line, isn't it?
Yes,
and if you see that the patient's BP is very labile, at one point it is 60 by 30, and another, after a few minutes, it becomes 180 by, suppose, 100, 120. So how you are going to manage these patients? What measures you can take, and what are the things you are going to check for to avoid such labile BP in this patient? Because definitely when the pressure will go high, there will be high risk of bleeding, isn't it? So surgeon is definitely going to complain about that. So how are you going to manage that?
Ma'am, for the hypertensive patient, if they are bleeding, we can use the beta blocker like labetalol.
Yes. Yes. So if suppose if the at one point of time, it may fall down to 60 by 30. So the first thing which you have to look for is you have to maintain a very adequate, very deep anesthesia level. Okay. Second thing is you can definitely use labetalol, but you have to look for the heart rate and pressures also. And the third and the most important thing, especially if it is a meningioma in the occipital lobe, you have to go and check for the positioning of the patient. Okay. Sometimes what happens if the meningioma is very large, it may cause compression over the brainstem, which can cause a baroreceptor reflex, and which can definitely make this a very labile BP. So you have to also ask the surgeon to readjust the positioning of the patient. So this is one of the way you have to manage these patients. Dr. Yogesh, you want to ask something?
Yeah. What can we do for the post-operative management for this patient?
So for the pain, we cannot give opioid or the sedative because they can precipitate hypercapnia or the hypercarbia, which can also lead to increase in the ICP and
post-operative management.
So we have to take them for the CT or the MRI if facility are provided.
Okay. And ICU management, for what can we do further?
What do we look for in CT and MRI in the post-operative period?
When intracranial bleeding, if there is.
So there has to be some evidence, no? Okay, if it is there, okay, Only then you have to take the patient for CT and MRI.
Yes, on cognitive dysfunction we can check for the focal neurological deficits are there. Then we can take them for the CT or MRI.
Our next candidate is Dr. Anjali Bansal. Dr. Anjali Bansal, please unmute yourself and please share your screen. Dr. Anjali, can you hear us?
Yeah, I can hear you. Yeah. It's my screen. I've shared my screen. Am I audible?
Yes, you are audible. Please double click.
Should I start?
Yes, sure, Anjali, you can start.
Good afternoon, everyone. Myself, Dr. Anjali Bansal, third year PG student.
Dr. Anjali, we are not able to see your screen.
Hello. Hello.
Dr. Anjali, please double click on the keypad. Now it's visible. Please start your presentation.
Okay. Myself, Dr. Anjali Bansal, third year PG student. I'm going to present a poster on scalp block for chronic STH in patients with RHD. It's a case report. Guided by Dr. Namrata, assistant professor, and Dr. Dilip Kothari, head of department. Introduction. Local anesthesia of the nerves of the scalp is referred to the scalp block, and it's a well-established technique for craniotomy and may be given pre-operatively to reduce the pain response to pin holder application and post-operatively before emergencies to decrease pain. RHD forms the bulk of etiology of valve lesions, and mitral and aortic valve lesions remains the most common. To avoid change in hemodynamic and situations that can cause major reduction of cardiac output and fluid shift, regional anesthesia is preferred over general anesthesia. My patient was a 56-year-old male weighing 74 kg. Presented to us in the emergency department with a history of altered sensorium and since one day and fever since last 3 days, along with the left-sided weakness, which was gradually in onset and progressive in nature, diagnosed with chronic STH. There was a history of RHD and CVA since last 5 years, but the patient was not on medication at present. On examining, patient was conscious but irritable. CVS step on examining CVS, tapping apex feet on palpation and murmur was heard. Respiratory system had the bilateral V's and basal clefts were present. GIT was normal. Chest X-ray shows bilateral basal infiltrate, and ECG shows the sinus tachycardia with left ventricular hypertrophy. In echo, there was dilated LA, RA, and right ventricle with domain of AML and fixed PML. Mitral area was 1.2 centimeters square with PR, moderate pulmonary arterial hypertension, and left ventricular ejection fraction was 40%. Patient hemogram was normal, prothrombin time was 14 seconds, and INR was 1.03, and RBS was 142 milligram percentage. Other RFT was RFT and serum electrolytes were within normal limits. NCCT had reveals mixed density of STH with left frontoparietal and right parieto-temporal occipital region, which was needed to be corrected surgically as early as possible. Anesthetic management. In operation theater, standard monitoring was done with NIBP, pulse oximetry, and ECG and temperature. Baseline heart rate was 150 per minute with blood pressure of 156 by 104 mm of Hg. Patient had 94% saturation on room air, and normal saline was used as a maintenance fluid. All the cardiac medicines and defibrillators were kept ready. Factors such as thorough pre-op examination, echo, treatment of chest infection, cardiologist consultation, documentation of pre-op cardiac and neurological status, and correction of any coagulopathy were necessary and taken care of in our patient. We avoided general anesthesia and went for a scalp block. Scalp block was given with 20 ml of 0.5% ropivacaine without adrenaline, 2 to 3 ml of for each nerve to block supratrochlear, supraorbital, zygomaticotemporal, auriculotemporal, greater and lesser occipital nerve. The block was supplemented with the injection midazolam 1 milligram, the injection dexmedetomidine 1 microgram per kg as loading dose, and which was followed by 0.5 microgram per kg per hour as maintenance. Patient was kept on spontaneous respiration throughout the procedure on 3 to 4 liter oxygen by nasal prong. The procedure lasted for 1 hour and the intra-op course was uneventful with maintenance of hemodynamic parameters within normal limit. MS, coming to discussion, mitral stenosis is most common valvular defect in rheumatic heart disease. Actually, coming to discuss it, mitral stenosis is most common valvular defect in rheumatic heart disease. For anesthetic management of these patients, we should be careful about the drugs and the events that may increase heart rate, systemic vascular resistance, and MS may complicate as atrial fibrillation, LA thrombus, pulmonary hypertension, and pulmonary edema. So whenever possible, regional techniques such as peripheral nerve blocks are preferred. General anesthesia with controlled ventilation has advantages of better oxygenation, but can be associated with risk of hemodynamic instability along with compression of pulmonary vessels, impaired gas exchange, and most of induction and maintenance agents are may lead to myocardial depression and decreased systemic vascular resistance. The goal should be to maintain hemodynamic stability by maintaining sinus rhythm, prevent rapid decreasing systemic vascular resistance and prevent increase in pulmonary pressure.
Dr. Anjali, your time is up already. You have to wrap it up quickly.
Optimization of the patient, we decided to proceed with. Okay, and coming to conclusion, patients with MS are more prone for hemodynamic instability, cardiac output, and heart. So to prevent intubation and other adverse effects, GI was avoided, and this may be considered as an alternative technique in selective patients who are not my references. Thank you so much.
So Anjali, was it an acute SDH or a chronic SDH?
Ma'am, it was a chronic SDH case.
So why there was no time for optimization of the patient? At least you could have controlled the heart rate.
Ma'am, because the patient came as an emergency case and the GCS was deteriorating.
Okay.
So this wanted to operate as soon as possible.
Okay. So you have found that scalp block along with sedation is a safer technique than general anesthesia in cardiac patients.
Yes, ma'am, because it prevents that intubation response, which is that may cause like increase in heart rate and BP, and to make the drugs which are we use for induction are may cause a decrease in cardiac output and the decreased systemic vascular resistance. So it's better to use scalp block.
Since the patient is a case of MS, and the heart rate is 150, cardiac output would definitely be on the lower side. At the rate of 150 in a patient with MS, cardiac output to kam hoga na beta. So suppose if you have to do this case under general anesthesia, how you'll go about it?
Ma'am, then we can we'll avoid the drugs that will reduce the cardiac output, and we can when we use the more amount of opioids to sedate the patient instead of large amount of induction agents like propofol. Because propofol
So
is
what
also
induction agent you're going to use in this?
like etomidate is the cardioprotective and indicated, but in our institute etomidate is not available. So
okay,
we
so
had
etomidate is the agent of choice, induction agent of choice for such kind of a patient. But before that, what other measures you are going to take?
But the patient is having like tachycardia also.
So how are you going to control this fast ventricular rate?
We can use as beta blockers like esmolol, metoprolol, or like if beta blockers.
Yes, you can use esmolol, but since the yes, you can definitely use esmolol in a titrated doses. Along with that, other option is like since the patient's EF is already on the lower side, it's almost 40%. You can use amiodarone also.
Yes, ma'am, amiodarone.
To control the ventricular rate. So, okay, I think it is a technique which might work, but I think for a cardiac patient with MS and along with severe MR, I think general anesthesia would have been more safer technique in such patients, because if the patient starts suddenly bleeding, then how are you going to manage such a patient? You'll not be able to secure the airway at that point of time. Would you be able to secure the airway in the midway? Suppose when the brain is open, it's very difficult to secure the airway. In a cardiac patient who is already so much compromised, and if some mishap happens in the intraoperative period, so there is no way you can manage the airway or you can start. Have you put the central line in these patients?
No, ma'am. No, ma'am. In this patient, I didn't put that central line.
See, if the patient would not have been a cardiac patient, then definitely this technique can work. But from the cardiac point of view, I don't think you were well prepared for the patient for any mishap which could have happened during the intraoperative period. Okay.
Okay.
So I think in this case, particularly when the patient is cardiac, having some cardiac issue, in those patients, you have to go for general anesthesia. This is my opinion. Okay, Dr. Yogesh, you can ask your question.
No more question. You can call the next.
Thank you, sir.
Next will be Dr. Ankit Raipuria. Dr. Ankit Raipuria, unmute yourself.
Yeah, am I audible?
Yes, you're audible. Please share your screen.
Yes, sir.
Okay, Dr. Ankit, please be fast with your presentation.
Yes, sir. Okay, my topic is therapeutic hypothermia after cardiac arrest. Presenter, I am Dr. Ankit Raipuria. Moderator, Dr. Lal Praveen. Introduction. Hypothermia is the body temperature below 36 degrees Celsius. Therapeutic hypothermia is induced hypothermia and can be mild, 35 to 9 to 34 degrees Celsius, moderate from 33.9 to 32 degrees Celsius, and moderate deep from 31.9 to 30.1 degrees Celsius, and deep less than 30 degrees Celsius. The importance of therapeutic hypothermia in selected category of the patient has been widely demonstrated. Laboratory, animal, and the human studies permitted to understand the molecular mechanism underlying cooling and its importance in preventing the ischemia. Perfusion injury of the brain, the development of the new technology and offered the possibility of reach the desired temperature effectively and rapidly and reduce the related side effects. Therapeutic hypothermia, lower brain damage and following cardiac arrest. Here we can see in patient have a cardiac arrest and then cardiac CPR we have to done, and therapeutic hypothermia if we do, and hold the lower damage to the brain and following cardiac arrest. Discussion. Despite advances in the ICU care, cardiac arrest remains a significant cause of the death in the many countries. Mortality report vary from 65 to 95% out of hospital cardiac arrest. It is recommended now that after return of the spontaneous circulation out of hospital, ventricular fibrillation, cardiac arrest, and patient that remains comatose should be subjected to hypothermia at 32 degrees Celsius to 34 degrees Celsius from 12 to 24 hours. This may also be applied to the comatose adult patient with a spontaneous circulation after out hospital cardiac arrest from a non-ventricular fibrillation rhythm or in hospital cardiac arrest. Several unanswered questions, however, remain due to the lack of randomized studies. These in part related to time from initiate of therapy to achieve a target temperature and whether it is a significant predictor of outcome. The optimal rate of the cooling is also an unanswered question. So it is optimal duration of the therapeutic hypothermia in some settings. Albeit in the setting of the cardiac arrest, improved outcome have been demonstrated within 12 to 24 hours of therapeutic hypothermia, 32 to 34 degrees Celsius. Hypothermia for neonatal abstinence is also common, performed for 72 hours, while hypothermia of the cerebral edema associated with the liver failure has been reported for as long as for 5 days. Here we can see in the diagram also using a cooling cap or a blanket or a newborn body temperature is lowered from 30.5 degrees Celsius. The newborn body temperature is lowered for 72 hours. Decrease body temperature and slow the body temperature metabolic rate, and cells are able to recover and prevent the spread and severity and permanent damage of the brain damage. Mechanism of action. There are several possible mechanisms of which mild hypothermia might be improved. Neurological outcome where when use of the after reperfusion in normal brain, hypothermia reduce the cerebral metabolic rate for oxygen by 6% by every 1 degree Celsius reduction in the brain temperature, more than 38 degrees Celsius. Some of this effect is due to the reduced normal activity. Mild hypothermia is through to suppress many of the chemical reactions associated with the reperfusion in the. These reactions include the free radical production, excitatory amino acid release, and calcium shift, which can be turned lead to the mitochondrial damage and apoptosis, a programmed cell death. Therapeutic hypothermia indication: cardiopulmonary resuscitation, traumatic brain injury, traumatic brain injury in outcome, stroke, fever in the patient with a neurological injury, subarachnoid hemorrhage, vasospasm prevention, intraoperative hypertension for the intracerebral aneurysm surgery, intraoperative hypothermia for the thoracoabdominal aortic aneurysm. Adverse effect. Adverse effect are shivering would be there, and muscle activity, increased oxygen consumption, increased rate and metabolism. Drug metabolism, altered clearance of the various medications, cardiovascular manifestation, prolonged PR, QT interval, and widening of the QRS. Arrhythmia, tachycardia, and then bradycardia, and then atrial fibrillation can be infection inhibit the release of the various pro-inflammatory cytokine, inhibit neuropathy and neutrophils and the macrophage function. Coagulopathy, increased bleeding time, increased APT and thrombocytopenia. Electrolyte disturbance, hypokalemia, hypomagnesemia during cooling, and hyperkalemia during dewarming. Insulin resistant hyperglycemia. Cooling techniques, non-invasive. These techniques include the use of the cooling blankets, application of the ice package to the groin, axilla, and neck, use of the wet towels and fanning, and use of the cooling helmets. Arctics, and we can use here, we can see here in that diagram, invasive. Intravenous infusion of the 30 ml per kg of the crystalloid of 4 degrees Celsius over 30 minutes reduce the core body temperature significantly and did not cause pulmonary edema. Conclusion. Therapeutic hypothermia is now increasingly used across many intensive care units, and application could be expand well beyond the current indication. It is important to use safe, effectively cooling method, recognize, prevent, and treat various adverse events that could occur, so we can improve the survival of these patients. ILCR recommendation: unconscious adult patient with a spontaneous circulation after out of hospital cardiac arrest should be cooled by 32 to 34 degrees Celsius for 12 to 24 hours when the initial rhythm was ventricular fibrillation. Such cooling may also be beneficial for other rhythm or in hospital cardiac arrest. Thank you.
Okay, and Dr. Ankit, yes. Is it still recommended in the recent ACLS guidelines 2020 post cardiac arrest care? What is the take on targeted temperature management? What are the
Target?
recommendation?
Ma'am, recommendation is less than 36 degrees Celsius. Up till 30, we can use for deep hypothermia.
So what is the target temperature range which is recommended in recent guidelines?
Recent guideline, ma'am.
In 2020 guidelines, ACLS guidelines, okay, in the post cardiac arrest care, what is the temperature range they have recommended for targeted temperature management in these patients?
Ma'am, 36 to 33 used.
Yes. So in the recent guidelines, it is said that there is no need for deep hypothermia because the results of normothermia and mild hypothermia is almost the same. Okay, so there is no added advantage of very steep hypothermia in the patient. All right. So, okay, Dr. Yogesh, you want to ask something? There's one new article in NAGM in the targeted on this topic only, targeted temperature management. You can refer to that.
Yes, ma'am.
No, have you mentioned about this cardiac arrest, post cardiac arrest care?
Sir, here in if we therapeutic hypothermia, if we give therapeutic hypothermia to the patient, that time we have to intubate that patient, and our patient should be on muscle relaxant. We have to care for 24 to 12 to 24 hours that patient. We have to take care about shivering also to that patient, because of that we have to be on muscle relaxant.
Okay. Okay, you can call the
next participant. Okay.
Thank you.
Next is Dr. Aradhna Chaurasia. Aradhna, if you can hear me, please unmute and share your screen. Dr. Aradhna, if you can hear me, please unmute and share your screen.
Hello.
Hello.
Hello. Hello.
Yes, Dr. Aradhna, we are able to hear you. Please.
Am I?
Yes, you're audible. Please start.
Hello. Hello.
Yes, start with your presentation.
Myself, Dr. Aradhna from MGM Medical College, Indore. My topic for presentation is venous ear embolus in neurosurgery. And my guides are Dr. KK Arora sir, professor and HOD, and Dr. Rashmi Pal, ma'am, professor. Introduction. Venous ear embolus is a potential serious neurosurgical complication associated with all surgery in steep head-up position, including posterior fossa surgery in sitting position. This diagram shows the standard sitting position used for the posterior fossa surgery, and in this position, venous ear embolism, risk of venous ear embolism is high. Then pathophysiology. Ear embolism occurred due to pressure difference between the right atrium and central venous sinuses. So venous ear embolism means the ear entry to the venous system, and then it reaches to pulmonary circulation, and after pulmonary, when it reaches to pulmonary circulation, there is right ventricular strain, which increases the pulmonary artery pressure. And because of the pulmonary artery pressure, there is obstruction in the outflow of the right ventricle. So there is decreased venous return and decrease in cardiac output. So there is cardiovascular collapse. Then the clinical manifestation, first is coughing. Second, because of the right ventricular obstruction and decreased cardiac output, there is hypotension, and there is also chances of the dyspnea, and fourth is chest pain. In diagnosis, first is we can see in the monitor, we can able to see there is fall in arterial oxygen saturation. Then there is sudden drop in amplitude of the capnography, and the most sensitive investigation is precordial Doppler, and the most recent investigation is transesophageal echocardiography. For management, first be to prevent the further entry of air, first be notify the surgeon and flood the surgical field with the saline soaked soap. Then we lower the head below the level of the heart. Then if already air embolism had occurred, we aspirate the air with the central venous catheter at right atrium. And then the jugular, by the jugular venous compression, we increase the pressure at the central venous sinuses, so further air entry is decreased. Then there is Durand maneuver. In this, we tilt the patient in left lateral position and slide Trendelenburg position. So the embolism is accumulated in the apex of the right atrium. And then we aspirate through the catheter at right atrium. And if there is massive venous air embolism, then the CPR is started. Thank you.
Very nice presentation. Over to our judges.
Okay, Dr. Aradhana, like you have
Yes, ma'am.
said, to diagnose air embolism,
Yes, ma'am.
you can use transesophageal echocardiography. So how you are going to, what exactly you are going to see on the monitor by which you can diagnose that there is air in the pulmonary circulation?
I mean, monitor, we are able to see that there is sudden fall in saturation.
No, not on the monitor. With the help of transesophageal echocardiography, how you are going to diagnose that patient is having VAE? Like you have said in your this part, diagnosis part, what you are going to see in transesophageal echo?
Ma'am, in transesophageal echocardiography, there is a murmur, mild murmur can be identified.
You're going to, how you're going to listen to a murmur through a transesophageal echo, beta? Have you ever used transesophageal echo?
No, ma'am.
Okay. So you will see the very striking white marks in the heart, in the chambers of the heart. Okay. And what is the minimal amount of air which can be diagnosed with the help of transesophageal echo?
Ma'am, 0.15 ml.
No, up to 0.02 ml per kg of air. Per kg of air you can diagnose with the help of transesophageal echo. All right. So, okay, Dr. Yogesh, over to you.
You have used capnography for diagnosis. What is its significance in diagnosing this venous air embolism?
Hello.
Hello.
Yes, sir. Hello. Sir, can you please repeat the question?
Dr. Yogesh, you're not audible, I think, to all.
Dr. Yogesh, sir, you're not audible, sir. Hello, sir. Yes.
Hello.
Yes. Yes, sir. We can hear you.
Now audible?
Yes, sir. You're
Yes.
audible.
Yeah. So you have shown capnography for diagnosis. So what is the significance in its diagnosis of this venous area embolism?
Sir, in venous air embolism, there is ventilation perfusion mismatch has occurred. If there is massive amount of emboli is present in the pulmonary artery, so ventilation may decrease. So there is and because of the decrease ventilation and perfusion, CO2 washout is increased.
So how capnography help in its diagnosis?
Sir, amplitude of capnograph is suddenly decreases in venous air embolism.
Okay. So no more
Let's
questions.
move on to
Yes.
let's move on to
Next-
other participants.
Yes, ma'am. Yes, sir. Next participant is Dr. Arsha P. Santosh, Shamsha Medical College, Rewa. Dr. Arsha P. Santosh, please unmute yourself and share your screen.
Good afternoon. Am I audible?
Yes, Arsha, you are audible. Please share your screen.
Yes. Is my screen visible?
No, your screen is not visible.
One second. Is it visible now? Hello?
Yes, it's visible now. Yes.
Please start with your presentation and try to finish it within 5 minutes.
Okay. Good afternoon, respected judges, faculty, seniors, and my colleagues. Today, my topic for presentation is airway management of a patient with postburn contracture neck. Myself, Dr. Arsha P. Santosh, second year PG resident, Shamsha Medical College, Rewa. And my moderator is Dr. Abhiraj Yadav, sir, Assistant Professor, Shamsha Medical College, Rewa. Introduction. Restricted mouth opening, decreased oropharyngeal space, reduced submandibular space complaints, fibrous neck contractures, and limited atlanto-occipital extension make airway management difficult in patients with postburn mentosternal contractures. My case is a 30-year-old female weighing 52 kg, ASA grade 2. She was admitted with postburn contracture of the anterior neck and was scheduled for contracture release and skin grafting. She had accidental chimney burns 3 months back, presented with complaints of tightening of neck, inability to look upwards for the past 3 months. Our plan was tumescent anesthesia followed by oral intubation. 2 IV access was secured with 20 gauge cannula. Monitoring included ECG, NIBP, pulse oximetry, and capnography. Difficult airway cart was kept ready. Anti-sialogogue injection glycopyrrolate 0.2 mg IV and anti-anxiety drug injection midazolam 1 mg IV was given, and injection ketamine 0.5 mg per kg was given. After that, a mixture of 30 ml of 2% lignocaine, 1 ampule epinephrine, and 2 ampules of soda bicarb with sodium lactate is infiltrated into the subcutaneous tissue. After waiting for 20 minutes, an incision was made over the scar tissue, and after that, release of adhesions, patient was induced. Patient was induced with injection propofol 100 mg and injection fentanyl 50 microgram IV. Following which oral endotracheal intubation was done. It was maintained with oxygen, nitrous, and sevoflurane. Injection atracurium 25 mg IV was given for muscle relaxation. Injection dexamethasone 8 mg IV was given to prevent airway edema. Intraoperative period was uneventful. Patient was extubated when fully awake with regular and adequate respiration and reversal of neuromuscular blockade. Coming into the discussion, postburn contracture of neck with fixed flexion deformity poses a significant challenge to the anesthesiologist. It causes distortion of larynx and
Arsha is not audible, I think.
Yes, ma'am. Dr. Arsha? She has logged out. Hello, Arsha?
Hello, am I audible?
Yes, you're audible. Please share your
Shall
screen
I
again.
shall I continue?
Yes, please continue and be quick.
Yes. Sir, is the screen visible, sir?
Yes, the screen is visible. Continue.
Yes, sir. Coming into the discussion, postponed contracture of neck with fixed flexion deformity poses a significant challenge to the anesthesiologist. Distortion of larynx and mandible due to dense fibrous bands and inability to align the oral, laryngeal, and pharyngeal axis make intubation difficult. Mask ventilation can also be difficult because of the anteriorly placed larynx. Sniffing position is unobtainable in severe postponed contracture neck. So, on the conclusion, cases have been found to be managed with ketamine and tumescent local anesthesia. Some nerve blocks are also found to be used, and fiber optic endoscopy is another frequently used technique for the same. And here are my references. Thank you.
Thank you. That was a nice presentation. Over to our judges.
Okay, Dr. Arsha, what is the maximum safe dosage of lidocaine in tumescent anesthesia?
Ma'am, 35 mg per kg.
Okay, there has to be some range, isn't it?
Ma'am,
35 to?
35 to 50.
Okay, fine. And are you sure that we use 2% lidocaine in these patients? What is the concentration which we use for, because we use large volume of, the volume required is quite large. Okay, so what is the concentration which we use in tumescent anesthesia?
Ma'am, we need to make a concentration of 0.4% lidocaine, ma'am. So we
0.4?
0.4.
Are you sure about it?
Yes, ma'am, 0.4% lidocaine.
Okay, and what is the disadvantage of, and what is the side effect or what is the disadvantage of tumescent anesthesia?
Ma'am, it can tumescent anesthesia if lidocaine is not used or any other local anesthetic can be used. It can lead to intravenous
No,
injection.
if we are using lidocaine,
if
we are using lidocaine, what is the main side effect or what is the complication, post-operative complication of tumescent anesthesia?
Ma'am, cardiovascular complications.
See, since we are using large volume of lidocaine and we are using epinephrine also, the rate of systemic absorption will be decreased. So the chances of lidocaine toxicity, the effect of lidocaine toxicity, they may come up to about 12 to 14 hours after the surgery is over. Okay.
Yes,
so in the post-operative period, you have to be very careful because the signs of lidocaine toxicity may appear well after 12 to 14 hours after the surgery.
Yes, ma'am.
All right. So this is one of the main disadvantages because of the large volume and slow absorption, so slow systemic absorption. This might be a complication of tumescent anesthesia. Okay,
Yes.
Dr. Yukesh, you can go ahead with your question.
No more question.
Good afternoon, sir.
You can call the next participant.
Thank you, sir.
Please call the next participant.
Dr. Avi Sharma. Next will be Dr. Avi Sharma. Dr. Avi Sharma, please unmute yourself.
Afternoon, sir. Am I audible?
Yes, you're audible. Please share your screen.
Shall I proceed?
Please, the time starts now.
Okay. A very good afternoon to all the respected seniors. Myself, Dr. Avi Sharma. Under the guidance of Dr. Jatinder Katotkar, I am about to present the topic of the subtle art of pre-oxygenation. We will be discussing about the physiological basis, clinical benefits, and potential concerns about the use of pre-oxygenation. The pre-oxygenation before anesthetic induction and tracheal intubation is a widely accepted maneuver designed to increase the body oxygen store and therapy delay, and thereby delay the onset of arterial hemoglobin desaturation during apnea. For patients, risk of aspiration during rapid sequence induction or intubation, where manual ventilation is undesirable, pre-oxygenation has become an integral component. So what is pre-oxygenation? It is the administration of oxygen to the patient prior to intubation to extend the safe apnea time. This is the key concept here, safe apnea time. It is the duration time for cessation of breathing or ventilation until a critical arterial desaturation occurs, which is typically considered to be 88 to 90% in clinical settings. So why do we do pre-oxygenation? In a healthy anesthetized patient, there is continuous consumption of oxygen at the rate of about 250 ml per minute. Hence, with each passing minute, there will be a fall in partial pressure of alveolar oxygen, and consequently, the partial pressure of arterial oxygen will lead to further apnea, which leads to SO2 falling below 70%. This can be detrimental and it can cause brain damage, arrhythmias, and death. The fall of oxygen saturation will be faster in patients with high metabolism, critically ill patients, children, pregnant patients, and obese. The most important method to delay the desaturation during apneic period is to make sure that there is enough oxygen reserves in the body by giving oxygen to the patient before the induction of anesthesia. During the process of pre-oxygenation, nitrogen in the lungs is replaced by oxygen. By breathing 100% of oxygen, we will increase the fraction of oxygen in the alveoli to 90%. We would have 1,800 ml of oxygen in the FRC. This should last for about 7 to 8 minutes of oxygen consumption. Pre-oxygenation increases the body oxygen stores, the main increase occurring in the FRC. The effectiveness of pre-oxygenation is assessed by its efficacy and efficiency. Indices of efficacy include increase in the fraction of alveolar oxygen, decrease in fraction of alveolar nitrogen, and increase in the arterial oxygen tension. Here we have a table which is showing the factors upon which the efficacy and efficiency of pre-oxygenation depends on. The key in achieving maximal pre-oxygenation is the washout of alveolar nitrogen. There are various techniques of pre-oxygenation which includes tidal volume breathing, 1 vital capacity breath followed by tidal volume breathing, single tidal capacity breath, 4 inspiratory capacity breaths, 8 inspiratory capacity breaths, and 12 to 16 inspiratory capacity breaths, which is known as extended deep breathing. There are also some potential risks associated with pre-oxygenations like hyperoxia and associated with harms with certain settings. Minor hemodynamic changes can also occur by giving 100% oxygen. Mild increase in systemic vascular resistance, mild decrease in cardiac output and heart rate. Hyperventilation and hypocapnia and its disadvantages related to that. A very important disadvantage can be atelectasis due to oxygen resorption. Like what type of delivery device, oxygen delivery device you're using. Like if you're using a CPAP mask, then patient might vomit and aspirate because of the mask. So aspiration risk is also well known. Here we can see some images of oxygen delivery devices. In this image, we can see the famous C and E method by which we grab the mask in order to pre-oxygenate. An adequate mask is shown over here, which extends from chin to glabella. So in conclusion, I would like to say that pre-oxygenation should be performed in all the patients given general anesthesia. Pre-oxygenation should also be performed whenever there is an anticipated interruption of oxygen delivery, such as during open and tracheobronchial suctioning or before or during a fiber optic intubation, especially in high-risk patient where you anticipate an difficult intubation. Also in super morbidly obese patient. These are my references. Thank you.
Okay, Dr. Avi, which among the various technique, which is the best technique you think is there for pre-oxygenation?
Ma'am, hello?
Yes.
Best technique would be bag and mask ventilation, ma'am, using anatomical face mask.
For pre-oxygenation?
Yes, ma'am. Anatomical face mask by delivering 100% oxygen.
Okay. So among all the techniques, you think the bag and mask ventilation. So during the pre-oxygenation, patient would be awake. So how you're going to bag and mask ventilate that patient? Patient would be on spontaneous ventilation. Achha, you want to put a face mask with a seal.
Yes, ma'am. Face mask with a seal. I'm sorry, I said mask. Bag. I was also only talking about the tight seal mask.
Okay.
Okay.
Okay, Dr. Yogesh.
How you can achieve pre-oxygenation, best pre-oxygenation in pediatric patient?
I'm sorry, sir. Can you repeat the question?
What is the best method for pre-oxygenation in pediatric age group patient?
In pediatric age group patients, ambu bag with tight fitting face mask.
Yeah, because you have to use GRC circuit with best tight fitting mask.
Type E Mapleson circuit, sir.
Jackson Ray circuit.
Jackson Ray circuit, yes. Sir.
Okay, no more question.
The next participant is Dr. Harish Kumar. Dr. Harish Kumar.
Am I audible, sir?
Yes, you are audible. Please share your screen.
Able to see, sir?
Start. Yes, start with your presentation.
Good afternoon, everyone. Today my post is about post-pandemic COVID-19 lung sequelae. My guide is Dr. Hariprasad Reddy, HOD and Professor, SVS Medical College, and co-author is Dr. Ayatullah. Introduction. COVID-19 pandemic has led to unprecedented surge in hospitalized patients with viral pneumonia associated with increased risk of hypercoagulability and venous thromboembolism. Various mechanisms of lung injury in COVID-19 has been described, but among them, lung fibrosis is the main pathological outcome due to disordered wound healing and post-infection and inflammation. Aims were to analyze lung sequelae clinically and radiologically following resolution of COVID-19 infection, its prevention strategies, if any, available. Materials of taking primary authors clearance, combination of 5 original articles were considered. Risk factors were age, more than 65 years, duration of ICU stay, more than a week, chronic smoker and alcoholic, comorbidities like diabetes, hypertension, and coronary artery disease. Results. Symptoms like mainly presented with fever, cough, and ABG shows like ARDS and acute lung injury, mild hypoxemia, and they are treated with hydrochloroquine, macrolides, remdesivir, low molecular weight heparin, dexamethasone, tocilizumab. Patients receive NIV support. On admissions, they have. On admission, we have seen ground glass opacities in both lower lobes. On follow-up, 1 minute, sir. And last follow-up, we have seen ground glass opacities in 55% patients and fibrous stripes in 39% patients, bronchovascular bundle distortion in 4.7% patients, pleural thickening in 18%, and mild pleural effusion. And second follow-up, 8% reached complete radiological resolution with ground glass opacities in only 46%, 33% having fibrous stripes. And third follow-up, ground glass opacities faded with fibrosis of lung in 33% patients, 30.6%. Discussion in an article states that pulmonary lesions were found to be completely absorbed in 53% patients during third week after discharge, implying pulmonary damage can be repaired without any sequelae. Other reported that older age and male sex are high risk factors for worst outcomes. Treatment options including steroids like dexamethasone, 4 to 6 mg in acute stages for no more than 10 days, antifibrotics like pirfenidone and nintedanib. These taken at least 1 to 3 months to demonstrate an effect and also cause hepatotoxicity. Both COVID and idiopathic pulmonary fibrosis share many common demographic factors, and antimalarials like hydrochloroquine has no role in some studies. Combination therapy like antifibrotics and anti-inflammatory, antiviral, oxygen support, and anticoagulation are at high risk for clotting complications of discharge. Vaccination should receive against influenza and pneumonia for any secondary infections. Lung transplantation is needed in severe COVID patients. Rehabilitation improves respiratory function, exercise endurance, self-care in daily living activities, and psychological support. Conclusion. In our study, pulmonary opacities were completely resolved with minimal fibrotic abnormalities. At follow-up, the lung functions and exercise tolerance resulted to normal. In minimum number of patients, that is 3%, mild to moderate disease progressed to severe form, termed stone lung, requiring total lung transplant. The result of study have to be confirmed on larger population and also in patients with severe COVID-19. Reference. Thank you.
Thank you. That was a very nice presentation. Over to judges.
Okay, Dr. Harish, what were your duration of follow-up?
Ma'am, up to 3 months, ma'am, 3 to 4 months.
Like you have said that there was a first follow-up, then second follow-up. So is it like 1 month follow-up, then the second month follow-up, and the third month follow-up?
Yes, ma'am.
Is it like that? So you mean to say by the end of third month, there was a complete resolution of fibrotic opacities?
Yes, ma'am.
Radiologically. And what was the functional status of that patient, of the patients? Hello.
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 Ma'am, am I audible, ma'am?
Yes, you are audible.
Ma'am, 1 second.
Shall I repeat the question?
Yes, ma'am.
Shall I repeat the question?
Yes, ma'am. Yes,
For
ma'am.
you? So you said there was a complete resolution of the fibrotic opacities radiologically. But what about the functional capacities of this patient? Did you get the PFT done or any other functional test which can assess the functional capacity of the patient?
No.
Spirometric test.
Spirometry and incentive spirometry we have advised, ma'am. There is an increased
No,
respiratory.
I just wanted to know how was the functional capacity after the 3-month follow-up of this patient? Was there any evidence of leftover pulmonary dysfunction in these patients?
Yes, ma'am.
Because radiologically, you said the fibrotic opacities, they have dissolved.
Not among all, ma'am. Among about 30 to 40% people.
Okay. In those patients only, what was the level of their functional capacity? Was it completely resolved?
No, ma'am. They
Okay,
decreased.
Dr. Yogesh, your question, please.
What pulmonary function tests you advise to this patient? Hello.
Sir.
Am I audible?
Yes, sir.
Which PFT, pulmonary function test, you use for this study?
Hello.
Hello.
Am I audible, sir?
Yes.
Spirometry, sir.
All is spirometric.
Yes, sir.
Then next, no more question.
Thank you.
Question.
Next will be Dr. Dilip Singh Pandolia. Dr. Dilip. Dr. Dilip, if you can hear us, please unmute and share your screen. Dr. Dilip, if someone in your room is also logged in, please ask them to turn their audio off.
Yes, sir. Yes, sir.
You can start with your presentation.
Yes, sir. Good afternoon, respected judges, faculties, and my colleagues. I am going to present my e-poster on topic Newton technique for caudal epidural in neonates and infants under the guidance of Dr. Abhishek Gupta and Dr. Dilip Kotari, sir. Introduction. Caudal epidural block is the most common technique for regional anesthesia among pediatric patients. It is commonly used to augment general anesthesia and to manage postoperative pain. Effective postoperative pain relief from caudal anesthesia has numerous benefits, including earlier ambulation, reduced time spent in a catabolic state, lowered circulating state hormone level, and decreased need for postoperative analgesic, including narcotics. There are two types of approach for caudal epidural block in pediatric age are common approach and Newton approach. Anatomy. The incomplete fusion of the posterior arch of the fifth and sometimes the fourth sacral vertebra from the sacral hiatus, which is covered by a ligamentous membrane called the sacrococcygeal membrane. The caudal epidural space can be assessed easily in infants and children through the sacral hiatus. The termination of the dural sac ascend from S3-S4 at birth to S2 by 3 years of age. To identify the sacral hiatus, we can palpate the sacral cornua and the indentation that is a bit caudal and midline to the cornua, or locate the two posterior superior iliac spine and draw a line between them, assuming this is to be the base of an equilateral triangle. The apex of the triangle can be considered an approximation of the sacral hiatus. Technique. There are two well-known techniques for performing a caudal epidural block, the common technique and the Newton technique. In the common technique, the needle is inserted at a 90-degree angle to the cutaneous plane, and after passing the sacrococcygeal membrane is lowered 30 degrees and advanced several millimeters into the sacral canal. In the Newton technique, the needle is inserted at 60-degree angle to the sacral plane instead of 90 degree in the midline at the apex of the sacral hiatus. After crossing the sacrococcygeal ligament, the needle does not have to be advanced because the bevel is at the beginning of the sacral canal and already within the epidural space. In Newton technique, the sacral hiatus is first identified and left index finger is placed over it. These are the images. The needle is then inserted caudally 1 to 1.5 cm from the hiatus, introduced into the subcutaneous tissue and advanced subcutaneously until the needle tip is felt by the left index finger. The needle is then advanced slowly at 60 degree until loss of resistance is felt. Thereafter, the needle is advanced not more than 0.5 cm. An aspiration test is performed. This technique is guaranteed that no subcutaneous injection will be required because the left index finger is placed over the hiatus. And for subcutaneous injection, the needle should not pass completely under the index finger, which will be easily felt because the skin and subcutaneous tissue in the pediatric patient are very thin. This is normal technique which is showing in the figure. The needle is inserted at the 90-degree angle, then after passing the sacrococcygeal membrane and turn to the 30-degree angle and furthermore advanced into the sacral canal. And this is Newton technique, in which after identify the sacral hiatus, left index finger is placed over the hiatus and the needle is then introduced Conclusion. Norton technique is very easy approach with fewer complications and lower failure rate. And these are my references, sir. Thank you, sir.
Presentation. Over to our judges.
Okay, Dr. Dilip, how are you going to make sure that your needle is exactly inside the epidural space? Is there any way of...
Yes, ma'am. Because the left index finger is already in the hiatus, if and because the subcutaneous tissue in the pediatric patient is very thin, so it is very easily felt by index finger. And when the drug is injected, if the drug is injected subcutaneous plane, swelling is felt easily.
You can use ultrasound also, isn't it?
Yes, ma'am.
To identify whether the needle is there in the epidural space or not. Okay, Dr. Yogesh, you can go ahead with your question.
Yes. What are the success rate of this technique?
Yes, sir.
What is the success rate of this technique?
सक्सेस रेट सर मतलब जो कॉमन टेक्निक है उससे सर बेटर ही है सर
के कंपैरिजन में बेटर है फेलियर रेट हेलो
यस सर Hello.
What you found? Success rate more than the normal technique?
Sir, I found sir success rate more in Norton technique, sir, because we have go in single direction and we also guide by index finger.
Okay, no more questions. You can call the next.
Thank you, sir. Thank you. Our next, Dr. Divya Dadoria.
Yes. Okay. Nice. Chalo party.
Hello.
Yes, Dr. Divya.
Hello. Am I audible to you, sir?
Yes, you're audible. Please share your screen. Dr. Divya, can you hear us?
Yes, sir.
Please share your screen.
The last participant is sharing.
Try now.
My screen is visible.
Yes, your screen is visible. No, it's not visible. Dr. Divya?
Yes.
Now it's visible. Please make it full screen and then start with your presentation.
Good afternoon, everyone. The title of my poster topic is bipolar hemiarthroplasty in an elderly patient with ejection fraction 30% with suspected LV. Fracture neck of femur is one of the leading causes of hospital admission in elderly patient. Studies have shown up to 25% mortality following hip fracture within 1 year of surgery. Elderly patients have history of undiagnosed rare disease, often get detected during these surgeries. Major adverse cardiac event and death. The major perioperative goal is management in patient with low ejection fraction is maintaining hemodynamic stability. Goal of perioperative management in these patients includes focused perioperative assessment, close perioperative monitoring, suitable anesthetic, and maintaining hemodynamic stability. Case report. My patient is 68-year-old male patient came with history of fall, presented with fracture neck of femur and inability to walk since the fall. There was no history of any other comorbidities or surgical history. There was no history of chest pain, dyspnea, and any consciousness, nausea, vomiting, and ENT. On examination, blood pressure was 120 by 78 mm of Hg. Pulse rate was 76, regular normal volumic, and ECG showed anterolateral inferior infarct old. 2D echo showed ejection fraction 30% with suspected LV apical clot. Airway examination showed 3-finger mouth opening, Balampati score was 2, upper central incisor absent with limited neck extension and neck flexion. No engorgement of veins was seen. Nodes were not palpable. All other investigations were within normal limit. Cardiac markers was normal, were within normal limits. Case management. The procedure was explained with all due risk to the patient and a well-written informed consent was taken. Patient was nebulized with salbutamol and Budecort preoperatively. Patient was shifted to OT after midnight fasting and standard monitor was attached. Baseline values were noted. NTG infusion 25 mg in 50 ml NS was started at 0.5 ml per hour. General anesthesia was the choice of anesthesia. Our major goal was to avoid tachycardia during perioperative period. Patient was pre-medicated with midazolam 1 milligram fentanyl in titrated dose. Injection lignocaine 3 ml was given. Patient was oxygenated with 100% FiO2. Was induced with etomidate 16 mg and rocuronium 50 mg IV. Patient was intubated with at 8 mm internal diameter ET tube fixed at 21 centimeter and bilateral air entry was checked and confirmed. Patient was maintained on atracurium, isoflurane, and oxygen and nitrous oxide. Injection fentanyl, bipolar hemiarthroplasty was performed and patient was hemodynamically stable throughout the surgery. Patient was extubated and ensuring criteria were met. Pain management was done with epidural analgesia with bupivacaine in titrated dose for perioperative and post-operative pain. 2 large bore cannulas were taken and IV fluid was given in calculated doses. Discussion. Elderly patient with cardiac abnormalities pose challenge for the anesthetist. In our case, we minimize the associated complications by preoperative optimization, careful assessment, and vigorous intra-op and post-op monitoring. There's scarcity of data on the use of certain anesthetic technique with patient. With reduced ejection fraction in any surgical procedure involving low EF, maintaining hemodynamic stability and intra-op survival become challenging issues. Our emphasis was to avoid tachycardia, prevent hypertension, and maintain deep plane of anesthesia. We achieved post-op analgesia by epidural technique. Conclusion. Elderly patients with the cardiac issues often go undiagnosed and are detected at the time of surgery. In our case, we achieved our goal by through pre-op assessment and optimization throughout the surgery. In our case, both intubation and extubation were uneventful and patient was hemodynamically stable the surgery and was shifted to SICU for post-operative care. These are the references and ECG. Thank you. Okay, Dr. Divya, why did you start NTG in this patient? What's the rationale behind? And to prevent tachycardia and hemodynamic stability.
To prevent tachycardia, you started NTG.
So, ma'am, to prevent Hypertension.
So there was no hypertension. BP was 120/78. Patient was having EF of 30%. So I could not understand why did you start NTG in this patient? What was the rationale of starting NTG? And moreover, you are going for, you have also used epidural technique for post-operative analgesia. This will again cause fall in BP. So patient is not showing very high blood pressure. EF is already low. There was no rationale of starting NTG in this patient. The infarct was also old. Okay, he was a case of old MI, isn't it?
Yes, yes, ma'am.
So there was no point in starting NTG in if the patient had a history of MI. If there was a previous history of MI, what is the rationale of starting NTG at this point? Was he having any chest pain? No. There was no chest pain. There were no ischemic agent, no ischemic episode. Blood pressure was fine. EF was low. And still you have started NTG. So there has to be some rationale behind it. What was that rationale? Okay, Dr. Yogesh, you can continue with your question.
Yeah, I also pointed out the same. If the patient's BP is normal, then why you have mentioned the use of nitroglycerin? Why you are using? Hello. Hello. Okay, then call the next.
Yes, sir. We'll call the next participant. Next is Dr. Aditi Dugaya.
This is last or?
Yes, sir. This is last candidate. Dr. Aditi Dugaya, please unmute and share your screen with us.
Hello.
Hello.
Good afternoon, everyone.
Yes, Aditi, please share your screen.
Is it visible?
Yes, it is visible.
Yes, ma'am. You start.
Start with your presentation.
Good afternoon, everyone. My name is Dr. Aditi Dugaya, a second-year resident, Sri Aurobindo Medical College and Postgraduate Institute. My topic for today is anesthesia for robotic surgeries, a case report. Introduction: robotic-assisted surgery is the recent surgical innovation designed to provide greater dexterity and precision. In Indian scenario, robotic surgeries are performed less because of the requirement of huge initial investment, recurring cost of consumables, device malfunction, increased risk of infections. Anesthesiologists should become familiar with the changes while managing a patient undergoing robotic surgery than the conventional or laparoscopic surgery. Here I am presenting two case reports which were performed in our institute. First is robotic total prostatectomy. A 55-year-old 50 kg male posted for total prostatectomy in view of benign prostatic hyperplasia with no past medical or surgical history. Second will be bariatric surgery, a 47-year 98 kg female with BMI of 55 kg per meter square posted for sleeve gastrectomy in view of morbid obesity with history of hypertension since 3 years and no surgical history. Both cases were induced as per institutional protocol and remained hemodynamically stable throughout the surgery and were extubated uneventfully. The challenges which an anesthetist faces during robotic surgeries are: readily access to the patient is unable due to spatial restrictions. During the bariatric surgeries, bougie manipulation is difficult due to robotic positioning. Physiological response such as pneumoperitoneum results in reduced functional residual capacity and lung compliance. Multimodal pain management is required. Steep Trendelenburg position for prolonged duration can raise intracranial pressure, which can lead to facial and orbital edema, risk of regurgitation and kinking of endotracheal tube. Hemodynamic consequences will be intraoperative hypotension, bradycardia, and cardiac arrest may occur, along with some respiratory consequences. Brachial plexus injury and lateral femoral cutaneous nerve injury may occur due to positioning. Time delay in patient monitoring may result in critical complications. The measures should be to be taken are: large bore venous access should be secured with extensions prior to procedure. Bougie insertion should be done prior to positioning, and an access way should be taken beforehand for manipulation. Application of positive end expiratory pressure prevents atelectasis during steep Trendelenburg position. Surgical local infiltration, transverse abdominis plane block, caudal or epidural analgesia in addition to general anesthesia may be helpful in pain management. Controlled ventilation to avoid hypercapnia or can lower the insufflation pressure. A nasogastric tube is used to reduce the risk of passive regurgitation. Full routine and invasive blood pressure monitoring is required. And if bradycardia, should be treated promptly with antimuscarinic drugs like atropine. Vulnerable areas should be adequately padded, and limbs should not be positioned at extreme angles. Quick response training of both anesthetist and surgical team is required. During the steep Trendelenburg position, there would be increase in ventilation perfusion mismatch, peak airway pressure, hypercarbia, risk of tracheal tube displacement, risk of surgical emphysema, risk of facial or airway edema, systemic vascular resistance, mean arterial pressure, oxygen consumption, risk of venous air emboli, risk of visceral or vascular injury, intracranial or intraocular pressure, cerebral blood flow, risk of neuropraxia, catecholamine release, renin-angiotensin system, or regurgitation. There would be decreased functional residual capacity, vital capacity, compliance, renal splanchnic blood flow, venous return, cardiac output, glomerular filtration rate, and urine output. Here are my references. Thank you, sir.
Okay, no questions from my side. Dr. Yogesh, you can ask if you want to ask something.
Sir, please unmute.
No questions from my side.
Thank you,
sir. Thank you so much. So this will be the end of our session. I would like
Thank you very much.
Thank you, ma'am. Thank you, sir. That was a very interactive and a very knowledgeable session. All the participants were good.
Thank you, ma'am.
Ideas. And with that, we are going to end our session A for the poster. Thank you, sir. Thank you, ma'am.
Oh, thank you very much.
Thank you very much.
Thank you very much. So now we are going to start with our next section. That will be section B for the poster presentation. For this session, we have Dr. Suren Raikwar, sir. Hello. For this session, we have as jury members Dr. Suren Raikwar, sir, and Dr. Subhash Agrawal, sir. Sir, can you hear me?
Yes, I am here. I'm here.
Yes. So welcome back. So welcome on this session, sir. So we have 12 participants here for the poster presentation.
Okay.
Yes, sir. Sir, in our jury, all the contestants, in our jury, we have Dr. S.K. Raikwar, sir. He's a professor at Gandhi Medical College, Bhopal. He have done his MBBS from GMC Bhopal, and his MD is also from GMC Bhopal. He has a teaching experience of 20 years. He's past president, ISA MP, 2017 to 18, past only secretary, 2016 to 17, past secretary ISA MP 2014 to 2017. He's a past secretary ISA Bhopal City Branch 2011 to 14. He's an executive member, Central Zone 2012 to 2015. He's an ordinary treasurer, National Conference of Neuroanesthesia, ISNACC 2012. He was organizing secretary, 4th and 7th Central Zone, Mpisacon 2012 and 2015. And organizing secretary, 30th Mpisacon MP 2015. He have more than 15 national and international index journal publications to his name. He participated and presented paper, delivered lectures, chairing scientific sessions in so many national, zonal, and state conferences. And we are very lucky to have him here. He was one of the driving force behind our 35th annual conference of Sagar. And we have a lot of input and lot of guidance from him.
Thank you very much.
Thank you, sir. Our next judge, Dr. Subhash Agarwal, sir. He is professor at Department of Neuro and Anesthesiology, SS Medical College, Rewa. He had done his MD Anesthesiology from GSVM Medical College, Nagpur. He has done undergraduation from SS Medical College, Rewa, and he have more than 20 papers recognition on his name on various national and international platforms. Has specialty in field of neuroanesthesia, pediatric anesthesia, and critical care. Welcome, sir.
Thank you. Thank you.
Sir, with your permission, can we start this session?
Yes, please proceed.
Yes, sir. The first candidate is Dr. Akshay Kumar Kherwar, Gandhi Medical College, 3rd year. Dr. Akshay, please unmute and share your screen.
Good afternoon, respected judges, moderators, and my dear friends. Today I am presenting a poster. Topic is the pharmacogenomic variability in anesthesia. Introduction. Genetic variant underlying genetic disorders are rare and solely determine the abnormal drug response phenotype, where the genetic variant involved in the pharmacogenomic variability are relatively common, but make only a partial contribution to the drug response phenotype. Pharmacogenomics deals with the genetics of the drug response phenotypes and that have the complex genetic basis. It is an understanding of this pharmacogenomic variability and underpins the concept of personalized medicine. Aim and objectives of pharmacogenomics is genomic variability of the response of the general anesthesia is like to play an important role in the incidence of awareness under anesthesia. Basic genetic principle is each protein produced in cells is input a specific DNA sequence found at the specific chromosomal locus. With the DNA sequence is known as genes. The sequence within a gene is ultimately translated into the protein sequence. This graphical representation shows that there are the percentage of responding of the drug and the doses in the genetic versus the pharmacogenomic variabilities. Which is described as in first figure, describe the idiosyncratic reactions in which the usually rare in genetic variant has a major effect on the response to a drug, such as carriers of the variant from the distinct population, which is shown in the red color, in the contrast to those without the variant in blue colors. The pharmacogenomics variability related to the combination of genetic factors that each has a small contribution to population variability. Carriers of the such a variant, green color, which shows in the green color, from the subpopulation that has a response to the drug that tends towards one or other tail to the whole population, which relative size of the contribution curves are not to scale. The DNA sequence In the upstream enhances the promoters where the gene structure and transcription. The DNA of the coding regions is composed to exons, which are the coding DNA. Exons are the coding DNA, interpreted with the introns, which are the non-coding DNA, and flanked by the untranslated regions, UTRs. Upstream of the coding regions within the genes of our DNA sequences, the cortisol, control the promoters. In the third figures, there are some in the process of the transcriptions where the triplet codon has changed the genes, which shows that the there are some changes in the protein sequence and protein formation, which is formed after the transcription and translation. And the drugs which attach to the proteins after the absorption, which shows the systemic in the systemic circulation, there are some free drugs which bond, and there are some in the tissue side and in the axon size. Then anesthetic importance of the pharmacogenomics is the pharmacological variability seen in the patient who undergoes for major surgery under general anesthesia, like malignant hyperthermia, nitrous oxide toxicity are the very common. Investigations of the pharmacogenomic variability, knowledge of the large number of single nucleotide peptides spread across the genome of viable host of the genotypes through the ability of single nucleotide protein array chips containing 500 to 1 million single nucleotide peptides has brought to reality of the prospect of genome-wide association study for the several important diseases with the genetic complication. Complex genetic backgrounds such as the coronary artery disease, bipolar disorder, Crohn's disease, rheumatic arthritis, and diabetes. Pharmacogenomic variabilities and adverse response to anesthetics. Malignant hypothermia has a complex genetic, about 200 genetic variant in R1, the genes coding the skeletal muscles in sarcoplasmic reticulum, calcium release channel have been reported in addition to multiple RYR variant. 5 other chromosomal loci shows the possible linkage of the malignant hyperthermia. Nitrous oxide toxicity, prolonged exposure to nitrous oxide is known to be associated with megaloblastic anemia, agranulocytosis, and nephropathy, secondary to acute demyelination. This results from inactivation of vitamin B12 by the nitrous oxide. Vitamin B12 is essential cofactor of the methionine synthesis. Nitrous oxide should not be administered to a patient who is known to methylene tetrahydrofolate reductase deficiency. Conclusion: gene association study has identified variant in the genes of the most likely factor identified so far the possibly influence drug response in the perioperative setting. The lack of definitive and the confirmatory data probably reflect the weakness in the candidate gene approach when many other genetic factors may be operating. The practical difficulty posed by the design requirement for the genome by association study using the clinical opioid response to phenotypes are considerable. Similar study problem by apply the investigation of the genomics of the intravenous and inhalation anesthetic wide association. References.
Thank you. Very nice presentation. Now over.
Hello, can you hear me? Akshay?
Yes, sir. Yes.
You have presented such a nice topic, and definitely it is an excellent presentation.
Yes, sir.
My question is that what is pharmacogenomics and its application in anesthesia?
So pharmacogenomics is the genes which is present on the chromosomal and extra chromosomal DNA, which form the various type of proteins after the process of the transcription and translation. which proteins are finally formed the receptors and ligands for the drug attachment, and various type of the enzymes, which is the responsible for the drugs metabolism and drugs efficacy. And so if we have the pharmacogenomic data of the patient, then we can say that it will be very easy for us to choose the drugs and the choice of anesthesia for the patient.
Good.
In some cases, patient has the opioid receptors mutations, having the low effect of the fentanyl. So we can have the such type of data. If patient is having the genetic mutation in the particular gene, and we should not give the fentanyl for in the future.
What is the future of pharmacogenomics?
So future of pharmacogenomics, we have the lots. We can keep the lots of data of the patient at the molecular data. We can say that we can keep the structural data, structural medicine, structural data in related to patient. We can use in further functional medicine, sir.
Okay. One more question from the history.
Yes.
Who invented pharmacogenomics?
Sir, Mr. Friedrich Wagel in 1956 first reported the pharmacogenomics.
Okay, very good. Over to Subhas. Have you any question, please?
Sir, good evening, sir.
Good evening. कैसे हो?
बढ़िया sir. My question is that what is role of anesthetics here?
Yes, sir.
Anesthetics का role क्या है यहाँ पर?
Sir, as an anesthetist, we have the data, sir. If we have the genomics study, genomic data of the patient, some patient have the very responded to the isoflurane.
Basically, what you want to say that we are just telling the data we are collecting, है ना? We don't have any active intervention. We are not doing any case control study, or we are not doing any experimental study. It's some sort of observational and study जिसमें अपन genomic sequencing करके उसको देख लेंगे बस, यही है ना?
जी सर.
चलो अच्छा, nice presentation. Thank you.
Thank you. Good day, sir.
Thank you. Our next presenter is Dr. Nagma Hassan Siddiqui. She is a third-year resident, Index Medical College, Indore. Dr. Nagma, please unmute and share your screen. Dr. Nagma, can you hear us?
She delivered a talk on what we need to know about nucleotomics as anesthesiology.
Dr. Nagma, please share your screen.
You can start your lecture now.
Dr. Nagma, please start with your presentation. Dr. Nagma, can you hear us? Check your microphones. Dr. Nagma, can you hear us? Dr. Nagma, can you hear us? Please acknowledge. Sir, I think she is not able to hear us, or she is having some problem related to audio. Should we move on to the next participant?
Definitely. We can go for
Please.
next participant.
Okay, thank you, sir. Our next participant is Dr. Pranjali Verma, RD Gardi Medical College, Ujjain. Dr. Pranjali, if you can hear us, please unmute and share your screen. Dr. Pranjali Verma. Okay. Dr. Sagar Dureja. Dr. Sagar Duseja. Please unmute and share your screen. Dr. Sagar Duseja, can you hear us? Dr. Sagar Duseja, kindly check your microphone. Dr. Sagar. Dr. Sagar Duseja, please check your microphone and connect with the audio. Dr. Sagar, if you're facing any problem, come to the chat section. And let's move with the next participant, and we will give you another chance at the end of the session. Dr. Sapna Sharma. Dr. Sapna Sharma.
Yes.
Please unmute and share your screen with us.
I cannot share my screen as Dr. Sagar is still sharing his screen.
Yes, we have fixed it. Now try again. Okay, start with your presentation. You have 5 minutes.
Let's see. Hello.
Start, please.
Yes, Dr. Sapna, you can
Yes,
start.
good afternoon, my dear professors, respected professors and dear friends. I'm Dr. Sapna Sharma from Sri Aurobindo Medical and PG Institute. My topic for poster presentation is super obese patient and anesthesiologist nightmare. Introduction. Obesity is currently termed as globesity, as obesity is seen as a worldwide social problem. Perioperative management of a super obese patient is a challenging task for anesthesiologist. Here I'm presenting a case report of a 59-year-old male with morbid obesity, OSA, COPD, and was posted for laparoscopic bariatric surgery in my institute. His anthropometries were as follows. Weight was approximately 280 kgs, height 168 centimeter. His BMI came out to be 99.2 kg per meter square. Neck circumference was 20 inches. On assessing his airway, we found out his mouth opening to be 2 fingers, MPC 3, and he had short neck. His vitals were pulse 100 per minute, BP 130 by 80 mmHg. His saturation was 92% on portable BiPAP. His echo was normal. His LFTs and other pre-op profile was normal. This patient was administered general anesthesia. He was induced using IV propofol, IV cisatracurium, and IV multimodal drug regime of dexmedetomidine, magnesium sulfate, and lidocaine. And this was maintained on oxygen, nitrous oxide, and desflurane. Hemodynamics and BIS with MAC monitoring was done. For this patient, pre-op optimization was done. Respiratory medicine opinion was taken, and IV derifylin in PD dose was advised along with nebulization, as he was a known case of COPD. PFTs couldn't be done due to ongoing COVID wave then. IV anticoagulants in the form of subcutaneous Clexane was given to prevent thromboembolic events, as this patient was a bedridden patient for a long period of time. Liquid diet was started and incentive spirometry was done, and he was given BiPAP support at night. The challenges and measures taken, ET intubation using rammed up position and nasopharyngeal airway was used. Logistics, the main problem was shifting this patient to the operation theater. In such patients, transport and positioning is risky for the patient as well as care providers. So this patient was shifted on his bed only and was operated on his bed only. Post-op oxygenation support was done using nasopharyngeal airway, CPAP, and proper positioning. Discussion. Obese patients have high intra-abdominal pressure and decreased functional residual capacity and expiratory lung volume and total lung capacity, making mechanical ventilation difficult. Muscle paralysis with muscle relaxants further reduces lung volumes, therefore are prone to faster desaturation, increased rate of atelectasis, and need for ventilatory support. To reduce it, we must include denitrogenation, continuous positive airway pressure application, and positive end expiratory pressure during the intraoperative period. Pharmacokinetics in obese patients is affected by several factors like changes in the volume of distribution, increased free drug availability, and changes in hepatic and renal clearance. Adequate multimodal opiate-free analgesia therapy must be used. Conclusion, the obese present a great challenge to the anesthesiologist who must deal with obesity-induced comorbidities and unique anesthetic considerations such as airway management and OSA, different drug dosage regimens, difficulties in monitoring and vascular access, respiratory and cardiac complications, and steep head-up patient positioning. Thank you.
Thank you. That was a very nice presentation. Over to our judges.
Thank you, Sapna. You present definitely a good case. My question is this: anesthetic challenges in super obese patient, drug distribution and implication in obese patient.
Sorry, sir, can you repeat?
Anesthetic challenges in super obese patient,
Okay.
including drug distribution and implication in obese patient.
So first issue is with the vascular access with these patients. So with this patient, the central line was taken, and
as you told, your patient is obese, COPD, and weight is 280 kg.
Yes, sir.
So what are the drug distribution and its implication in obese patient, and how special care is of the obese patient after during surgery? You are in which year?
Sir, I am in second year.
Okay. What intraoperative care of the obese patient during surgery?
Sir, his BP was managed using infusion of IV dexmedetomidine because it was a laparoscopic surgery. CO2 was inflated, so there is a sudden increase in BP. So we started with IV infusion of dexmedetomidine, and arterial line was taken for like continuous monitoring of the BP. And this monitoring was done so that we can know how deep the patient is, and accordingly desflurane and other things were managed.
What ventilatory strategy for your post-op patient?
So with this patient, he was extubated in the OT, and nasopharyngeal airway was secured, and so that because he was having OSA also, so that BiPAP support can be started anytime if any event of OSA happens.
Okay, Shabas, you can ask.
What is super obese?
Sir, it is BMI more than 80 kg per meter square.
I think it's 50, 50 or 60. It's
Yeah,
50.
yes, sir. 50 to 60, yes, sir.
50 or 60. Basically, the term was used for the weight for that particular age more than 250%. That is called super age. How you have controlled pain? What was your post-operative pain management?
So we generally give just after the shifting the patient pethidine and phenargan P2 to the patients, and during surgery also tap block was also given, transverse abdominis block.
Tab block.
Yes.
In which plane do you give tab block?
Sir, it is given in mid-axillary line between midpoint, in the mid-axillary line, midpoint between the lower rib cage, lower rib line and anterior superior iliac spine, between two muscles.
Basically, it is between the internal oblique and transversus abdominis.
Transverse abdominis, yes.
Transversus abdominis and internal oblique के बीच जो space होता है,
yes sir,
उसको अपन जगह induce करते हैं ना. चलो, okay, thank you, nice presentation.
Thank you, sir.
Our next presenter is Dr. Sheetal Khandekar. Dr. Sheetal, please unmute and share your screen with us. Sheetal, you can start with your presentation. Sheetal, unmute yourself, and please start with your presentation. Sheetal, start with your presentation now.
I think Sheetal has some problem, I think, audio problem.
Sheetal, can you hear us?
So you,
Good afternoon, all of you.
Sheetal, please start your presentation, please.
I'm presenting a case of intraoperative pulmonary embolism.
Your screen is disappear.
Sorry. A case report of intraoperative pulmonary embolism in a polytrauma patient under guidance of Dr. Saurabh Srivastava, sir. Introduction: acute pulmonary thromboembolism can be life-threatening.
Your screen is not visible on the screen. Your poster is not visible on the screen. Hello.
Yes, sir.
Your poster is not visible on the screen.
1 minute, sir.
I request all the participants to be please ready with your presentation. And if you're not comfortable with Zoom meeting, please have someone around you who can help you with any difficulties. Dr. Sheetal?
Yes.
Any difficulties? Dr. Sheetal, I think there is someone in your room who is also logged in with our session. Please ask them to switch off their audio.
Now you can
start with the presentation. Please start.
Kushal.
शीतल, listen, सुनो शीतल।
Yes, sir.
तुम्हारे रूम में कोई एक और आदमी ने लॉगिन किया हुआ है।
Yes, sir.
उनको लॉग आउट करवा लो या फिर उनका ऑडियो बंद करवा लो या फिर उनको हेडफोन लगवा दो।
सर मैं थोड़ी देर बाद प्रेजेंट कर सकता हूँ।
Next is Dr. Shifa. Dr. Shifa, are you ready with your presentation?
Yes, sir.
Please share your screen and start.
Yes, sir. Very good evening, respected judges.
Good
Sir,
evening.
am I audible?
Yeah, start.
Yes, you're audible.
Yes,
Please
sir.
start.
My topic for today's poster presentation is anesthetic issues and difficult airway management in a case of giant retropharyngeal lipomatosis. My moderators are Dr. Brajesh Kaushal, sir, Dr. Shweta Srivastava, ma'am. Introduction. Lipomas are slow-growing benign tumors of adipose tissue which can occur anywhere in the body. Hence, they are known as universal tumors. 13% of lipomas grow in the head and neck region. Lipomas of retropharyngeal region are rare and slow-growing, but they attain a very large size before producing symptoms. Although the diagnosis is difficult, CT scan and MRI aid in the preoperative diagnosis, though confirmation is by the histopathological examination. Giant retropharyngeal lipoma is a risk factor for difficult airway. Hence, anesthesiologist needs to develop strategy in order to anticipate and manage these patients with difficult airway. Here, we are reporting a case of giant retropharyngeal lipomatosis, which was successfully operated in our hospital following fiber optic intubation. Anesthetic challenges that can be faced in such cases are challenges related to airway management of the patient because such large masses can cause tracheal deviation. Major potential intraoperative problems include surgical hemorrhage, nerve damage. Also, pneumothorax can occur if the procedure is carried out in the base of neck. Post-operatively, airway complications like laryngeal edema and tracheomalacia can occur. This is the X-ray neck of the patient in AP and lateral view, showing the giant retropharyngeal lipoma and the deviation of trachea. The CT neck of the patient showed a homogeneous non-enhancing lesion of size 16 cross 15 cross 17 centimeter. It extended from C1 to D1 vertebra. It also displaced the oropharynx towards left side, with causing abutment of right common and internal carotid artery. The right IJV was not visualized due to compression. All of these were suggestive of a giant retropharyngeal lipomatosis. Case report. It was a 52-year-old female patient who presented with the chief complaints of swelling in right side of the neck since 1 year, which was insidious in onset, which progressed from an initial size of 4 cross 5 centimeter to attain the present size of around 15 cross 15 centimeter. The patient had significant history of giddiness. There was no history of dysphagia, dyspnea, or change of voice. She had no significant past medical or surgical history. On examination, there was a 15 cross 15 centimeter swelling which extended from the mandible up to clavicle, and posteriorly it extended right ear lobule. Airway examination of the patient showed mouth opening of 2 fingers with melumpathy grade 3. The flexion of neck was restricted. Anesthetic management of the patient. Since this was an anticipated case of difficult intubation owing to the large neck mass with 2-finger mouth opening and melumpathy grade 3, we planned for fiber optic intubation. In fiber optic intubation, preparation of the patient is the most important thing. Hence, the patient was nebulized with 4% lignocaine. She was pre-treated with 0.2 mg of IV glycopyrrolate, 1 mg of IV midazolam, and 60 microgram of IV fentanyl, and patient was adequately pre-oxygenated. Awake fiber optic intubation was carried out. This patient was intubated with a 7 millimeter internal diameter cupped flexometallic endotracheal tube. Maintenance of anesthesia was done with a mixture of oxygen with nitrous oxide and sevoflurane. Atracurium was used as muscle relaxant. Intermittently, fentanyl was given for analgesia. The surgery lasted for 2.5 hours. Neuromuscular blockade was reversed. We checked that there was no evidence of tracheomalacia. After this, the patient was extubated and was shifted to ICU. Coming to the discussion. When this index case of large retropharyngeal lipoma presented for surgery, the principal consideration was the effect of mass on local structure, which is either in the cervical or superior mediastinum. In neck, the principal structures that are affected to be trachea, carotid artery, and internal jugular vein. Tracheal involvement makes both intubation as well as the surgical airway access difficult. Airway compromises can occur in such patients. Hence, these patients should be kept spontaneously breathing whenever possible in order to avoid the airway compromise. Any large masses around the neck are a direct risk factor for airway compromise, and hence they pose challenge for the anesthetist. The gold standard for an anticipated difficult airway is awake fiber optic intubation. Hence, it is of paramount importance for anesthesiologists to be trained in fiber optic intubation. Concluding, the hallmark of successful outcome in such cases is operative assessment of airway, maintaining spontaneous ventilation while intubating, and anesthetists being vigilant to identify and manage intraoperative and postoperative complications. Anesthesiologists being well versed in various modalities for managing difficult airway is of prime importance. Thank you, everyone.
Dr. Shifa.
Yes, sir.
What special radiological feature to assess the compression or deviation of the trachea?
Sir, radiologically, sir, we'll go for X-ray neck of the patient in AP and lateral view. Sir, in AP view, we can get to know about the deviation of trachea, whereas in the lateral view, we'll get to know about the compression of trachea.
Okay, good. What preparation for the difficult airway should be keep ready?
Sir, we should keep the difficult airway cart ready in this patient, sir. We should also keep ready for the surgical access of airway. That is, we should keep the surgical team ready for tracheostomy in such patients. And for needle cricothyroidotomy, we should be ready.
Okay. What are the differential diagnoses of retropharyngeal mass?
Sir, since this mass was even presenting exteriorly, initially, the most important differential that was there was a large thyroid swelling, because this has presented exteriorly. Also, there can be retropharyngeal abscess is a differential diagnosis.
Okay. What post-op analgesia should we plan for this case? Hello.
Sir, the wound was infiltrated during the closure of the wound. Even the wound was infiltrated so that with local anesthetic, so that even that could provide analgesia to the patient. Low-dose opioid was used for analgesia, sir.
Okay. Subhas, please.
Thank you, sir.
Suppose this is a midline swelling or suspecting a large thyroid swelling.
Yes, sir.
Then what would be your approach? Anything different you would like to do apart from this?
If it is a midline swelling.
Suppose this is a large thyroid. No? That is
Yes, sir.
okay, it's a giant lipoma. Suppose this is midline large thyroid swelling. What your approach would be there, or what special precaution would you like to do?
So prior to taking the patient for surgery, it is important to do an ideal examination and document for the
Okay.
vocal cord status in the patient. And getting to know about the retrosternal extension of the swelling is important prior to taking the patient for surgery. It's important to keep these patients spontaneously breathing, sir, because the moment the spontaneous breathing of the patient is lost, this large masses can cause an obstruction to the airway.
Okay, right. And also you should see for the any tracheal damage.
Tracheomalacia during X-ray. Yes, sir.
And post-operative laryngeal vocal cord movements. No?
Yes, sir.
Okay, thank you. Nice feeling.
Thank you, sir.
Okay.
Sir, next Dr. Sagar Duseja is ready. Should we allow him to present now?
Yes, yes, definitely.
Yes, sir. Dr. Sagar Duseja, please unmute and share your screen.
Good evening, sir. Am I audible?
Yes, you're audible. Please share your screen.
Sir, 1 second.
Dr. Sagar?
Yes, sir. Sir, I'm sharing my screen, sir.
Dr. Sagar, are you using your laptop or you're using it in your phone?
I'm using my laptop, sir.
So there is an option, na, share screen. You just have to click on it.
Yes, sir. Sir, I am trying. Sir, 1 second, please. Sir, it is starting, sir. 1 second. Sir, it is loading, sir. 1 second.
Dr. Sagar, if you're facing any problems, we can have you at the last time of the session. Let's move on with the next candidate, Dr.
Right, it is
Pranjali.
starting, sir. Only it is just
No, Dr.
loading.
D'Souza, this is not. We are already getting late, and our judges have given us a very precious time of theirs. Yes,
I have started, sir. Sir, it is it visible, sir?
Yeah, start fast.
Yes.
Start fast, otherwise.
Yes, sir. So, good evening, sir. My today's topic for poster presentation is anesthetic management for pediatric bariatric surgery. It's a case report. My guide is Dr. Deepti Saxena and Dr. Atul Dixit. Introduction: the pediatric bariatric patients present with a great challenge to an anesthesiologist till nowadays. There is a congenital leptin deficiency disorder, only which means a few dozen cases have only been reported in medical literature. Deficiency of leptin causes hyperphagia, eating like eating in secret, fighting with friends for foods. There is that is not common disorder which is found in our country or the world. A case report: a 6-year-old female with 80 kg and BMI of 55.5 kg per meter square posted for sleeve gastrectomy. On examination, the patient was conscious and oriented with difficulty in doing her daily activities. On auscultation, chest was clear, heart sounds were normal, airway examinations were Malampatti grading 3, with short neck, pulmonary function test and sleep study were normal. In 2D echo, left ventricular ejection fraction is 65%, trivial TR, RVSP 11 mmHg. Other investigations are within normal limits. Patient was induced as per institutional protocol and remained hemodynamically stable throughout surgery and more extubated unevenly. So the anesthetic challenges you face is the difficult venous access, for which we can consider topical anesthesia or IJV cannulation, internal jugular vein cannulation. The patient should be pre-oxygenated well for proper denitrogenation and to delay desaturation earlier in apnea, safe apnea period. The positive pressure ventilation with the addition of positive and expiratory pressure. Very high risk of laryngospasm and bronchospasm in the children, as it is a pediatric bariatric patient. Hemodynamic monitoring, so that the proper size of NIPP curve should be there. If it is not available, we can use invasive radial arterial monitoring. Saturation probe we prefer to the glove type, upper sensor over clip type, and fluid therapy. Normovolemia should be there, the goal to avoid the hemodynamic instability. The conclusion is that the successful outcome for major bariatric laparoscopic surgery is based on appropriate and considered anesthetic technique. Complications may be reduced by anticipating problems likely to arise on and bypassing them in advance. Close attention during induction and better monitoring intraoperatively and postoperatively. Thank you, sir. These are my references. Thank you.
Dr. Sagar.
Yes, sir.
How is a pediatric obese patient is different from the normal pediatric population?
Sir, in normal, in pediatric bariatric patients, sir, the additional complications were also added,
like
due to obesity, due to which there is an excess of fat, and we have to give a fluid according to the ideal body weight and lean body weight. There was excess deposition of fat around the neck and cervical pad, by which intubation was also difficult.
So what problem you face while conducting a pediatric bariatric surgery, and what are the anesthetic challenges? My next question.
Sir, anesthetic changes first was to transport the patient. As it is morbidly obese patient, it is a BMI of more than 55.5 kg per meter square.
Okay.
Secondly, for positioning for intubation, as it is a case for the laparoscopic surgery, so we have to do general anesthesia. So patient proper positioning during intubation as normally in the patient, like pediatric patient, sniffing position was given, but in this patient, we should prefer the ramped up position for that, so that it can easily be intubated, or there was less difficulty in intubating the patient.
What complication you encountered intraoperatively?
Yes, sir.
What complication you have encountered intraoperatively?
Sir, intraoperatively,
in pediatric patient.
Yes, sir.
What is your ventilatory strategy post-operatively?
Yes, sir. No,
post-operatively ventilatory strategy. What is your post-operative ventilatory planning?
Sir, post-operative ventilative settings, either the patient should be kept on BiPAP or continuous CPAP in a propped up position, and proper anesthesia, proper post-op analgesia should be given so that the chest compliance will be normal, so the patient can breathe easily. So if there will be less difficulty in breathing system.
What post-operative analgesia options are available for this patient?
Sir, post-operative, at last, when patient is going to extubate, just prior to extubation, we are practicing to give a tap block to the patient, transverse abdominis plain block, and in our institution, after that pethidine and Finargan is given to patient.
Finargan for what? For analgesia?
A combination of pethidine and Finargan for post-op pain.
Okay. Over to Subhas.
In this, what your case, leptin deficiency, no?
Yes, sir.
What leptin deficiency is associated with other systemic disorder? What other systems involved with congenital leptin deficiency that you should consider during anesthesia? This child having congenital leptin deficiency syndrome, most probably. Okay.
Sir, other systemic associated with the hypogonadism, hypogonadism is associated with the leptin deficiency, sir.
No, only for anesthesia point of view. Basically, these childs are having some sort of atherosclerotic disorders also. There may be subtle coronary syndrome which you have missed. You should also see for the coronary condition. You should see for the heart condition, maybe having mild or moderate type of unnoticed infarction. So I think you should work out for the cardiac condition also. Other they are prone for hypothermia, hypoglycemia.
Metabolic syndrome also.
Metabolic. Thank you.
That's it. Thank you, sir.
Okay.
Next will be Dr. Sheetal Khandekar. Dr. Sheetal, if you can hear us, please unmute.
Good afternoon, all of you. Good afternoon, all of you. I am presenting the case report of intraoperative pulmonary embolism.
Sheetal, we cannot see your slides. We cannot see your presentation.
Wait. दिख नहीं रहा, नहीं दिख रहा है, इस पर नहीं आ रहा. स्वाति यही Good afternoon, all of you. I am presenting a case report of intraoperative pulmonary embolism in polytrauma patient. Introduction. Acute pulmonary thromboembolism can be life-threatening. Early detection is more difficult for patients who lack of pathognomic sign and symptom of pulmonary embolism. Pulmonary embolism. Case presentation. A 47-year-old male underwent surgery for fracture femur under combined spinal epidural anesthesia. Emergency pre-anesthetic checkup was done. All vitals were stable. Intraoperatively, after 1.5 hours of procedure, patient developed sudden onset of tachycardia up to 46 per minute and fall in the blood pressure up to 76/40 mmHg. And patient become tachypneic and fall in the saturation up to 82% in the absence of any drug reaction in acute MI. Pre-anesthetic management, preoperative patient, all vitals were stable. Blood was arranged to deal with unwanted emergency. Intraoperatively, patient induced under combined spinal epidural anesthesia with all vitals within normal limit. Intraoperatively, after 1.5 hours of a surgery, patient developed tachycardia followed by hypotension and fall in saturation up to 82%, and patient become tachypneic. Then patient kept on the bag mask ventilation and saturation improved up to 97%. Then patient was decided to intubate with ET tube number 8.5, cupped, passed, checked, and fixed. Surgery was halted and atracurium infusion was started 1 milligram per ml at the rate of 20 microdrops per minute, and midazolam infusion was started at the rate of 1.1 mg per kg per minute. Patient was shifted to ICU for further management. In post-operative ICU care unit, patient was connected to ventilator support with following setting: FiO2 100%, tidal volume kept 400 ml, respirator rate 16 per minute, and PEEP 6. Following bedside investigation were done. Bedside D-dimer was 71336.8 nanogram per ml, and this is the X-ray showing Western mark sign in pulmonary embolism, and USG findings and capnography fluid wave of EtCO2. After discussion with consultation team, after discussion with the consultation team and medicine consultant, anticoagulant therapy was started and enoxaparin 0.3 mg per kg subcutaneous BD given. After monitoring overnight vitals of patient within normal limit and stop atracheum infusion and midazolam infusion, patient become conscious oriented and was having his own respiratory efforts. Then patient was put on the TEP trial, saturation was maintained and all vitals were within normal limit. Then patient extubated and was observed for 72 hours and discharged successfully. Discussion. Above mentioned patient developed pulmonary embolism without coagulation profile workup. The only pertinent finding of explain this state multiple long bone fracture. A handful of case report have alluded the risk of pulmonary embolism in the patient with polytrauma. Patient was successfully managed and discharged with medicine to avoid recurrence of pulmonary embolism. Conclusion. To conclude, early diagnosis and aggressive management can save the life of such patient, and all patients scheduled for major surgery should receive thromboembolic prophylaxis in the absence of any sign and symptom of thromboembolism.
Hello, doctor.
Good afternoon, sir.
How do you identify intraoperative pulmonary embolism?
Sir, patient develop tachycardia tachycardia and 148 beats per minute and followed by hypotension, and patient become tachypneic and respiratory rate goes up to 42 beats per minute.
And patient is
patient having history of patient also having a history of polytrauma.
okay. But how will identify intraoperative pulmonary embolism? Patient is tachypneic and desaturated in spite of 100% oxygen. Okay.
Yes.
So what are the causes of the polytrauma embolism in the polytrauma? What are the causes of embolism in polytrauma patient?
Polytrauma patient.
Causes.
Sir, due to fracture, there is a inflammatory activation of inflammatory markers and endothelial.
Okay. Then, what is the management of pulmonary embolism? How you will manage it?
Sir, first we start anticoagulant therapy. Prophylactically, we should give anticoagulant therapy, or patient put on ventilator support because patient having a tachypneic. So we have to put on ventilator support by.
What is D-dimer?
D-dimer is a fibrinolytic which increases the pulmonary embolism.
Dr. Shabas, you can ask, please.
No question, sir. Thank you. Nice presentation. Okay. No question. Go ahead with next student.
Yes, sir. Next is Dr. Sonali Savaran. Dr. Sonali Savaran, please unmute.
Hello.
Yes, you can start with your presentation.
Yes, sir. Good evening, sir. Good evening to all professors. My topic for today is uncomplicated inguinal hernia, a daycare procedure guided under Dr. Sangeeta Bansal, Professor and HOD, Index Medical College Hospital, Research Center, Indore. Introduction. Daycare surgery is defined as planned investigations or procedures on patients who are admitted and discharged home on day of their surgery, but who require some facilities and time for recovery. Local anesthesia has its role. The aims and objectives of the study conducted includes to study whether daycare surgery for inguinal hernia repair is suitable for the patients coming to a hospital, to study the feasibility of using local anesthesia for daycare surgery. This was a prospective study carried out in our hospital for a period of June 2021 to September 2021 at Index Medical College. We studied and attended 20 cases of inguinal hernia. A proper record was maintained for each case. We included patients with uncomplicated unilateral inguinal hernia. Age range was 20 to 60 years, ASA grade 1 and 2, and those who were willing to participate in daycare surgery. Excluding recurrent inguinal hernia, incisional hernia, complicated hernias, patients not having facilities and attendants for adequate monitoring and care, patients who needed supplemental IV anesthetic drugs in addition to block during the procedure, and ASC 3 and above patients were excluded. The perfect choice of anesthesia for all reducible adult inguinal hernia is hernia field block. It is safe, simple, effective, economical, without post-anesthetic side effects. PNS guided hernia block was given. Surface landmarks taken were pubic tubercle and anterior superior iliac spine. Technique which we did was we palpated anterior superior iliac spine and raised a skin wheel 3 centimeter medial to this point. We inserted the needle perpendicular to the skin through the wheel to bone and injected 5 ml of the drug. Then we redirected the needle along the line of incision, but downward and medially, and injected 15 ml of our drug, which composed of mixture of 2% lignocaine, plus 0.5% of bupivacaine in the ratio 1:1. We palpated pubic tubercle and raised a skin wheel 2 centimeter lateral to this point, inserted the needle perpendicularly to the skin until bone is hit, and there we injected 5 ml of our drug. Then redirected the needle laterally and superiorly along the line of incision for 2 inches and injected 15 ml of the drug. Discussion. Daycare hernia surgery is a great step forward performed commonly under local anesthesia. Its advantages included reduced cost, more efficient high volume output of patients, reduced waiting list for elective surgeries, inpatient beds freed for major and emergency surgeries, and there were minimal disruption to patients. The results of our study were comparable to previous studies. In our study, 60% of patients were discharged on the same day, 30% of patients on first post-op day, 10% on second post-operative day. The mean time to return to normal activity in present day was 10 to 15 days, and average expenses for daycare hernia repair was very cost effective. That is rupees 2,500 to 3,000 it costed to patients. Limitations of our block was they can't be used in patients who were sensitive to local anesthetic drugs, obese, and markedly overweight patients. The discharge criteria for same-day discharge included vital signs stable for more than 60 minutes, no or minimum nausea for at least 30 minutes. Patient should be pain-free or minimal pain on oral analgesics, and there should not be any active bleeding. 8 patients from a study could not be discharged on same day due to presence of significant pain and inability to pass urine, hence needed further hospital stay. Conclusions. Hernia repair in daycare surgery units is a trend that is rapidly evolving. With improved quality of surgical care, daycare hernia repair surgery can be successfully provided to selected group of uncomplicated inguinal hernia patients under local anesthesia. Thank you, sir.
Dr. Sonali, what
Yes, sir.
Aldrich score?
So Aldrich score is a discharge criteria for patients who
What is
we
normal?
want.
Normal range.
So score more than 9 we are required for discharge from patients from PACU, post anesthesia care unit.
What
So,
are the
sir,
5 parameters of the Aldrich score?
So that is respiration, consciousness, oxygen saturation, arousable circulation, and activity.
What are the other surgeries carried out on daycare anesthesia?
The other surgeries, common surgeries are herniorrhaphy, hemorrhoidectomy can be done, herniotomy, DNC, hysteroscopy, implant removal surgeries, circumcision.
So next, what is the risk in using LMA if large hernia is present?
LMA in local anesthetic procedure, sir?
The risk of using, if you are using LMA, then?
So large hernia and recurrent hernias were excluded from the study, but if we have to use
Okay,
LMA,
okay, it's okay. It is not included in your studies, and that's okay.
Okay.
Over to Subhash, sir.
Sonali, Dr. Sonali.
Yes, sir.
Patient was comfortable with this block during some compression or bowel touch and there was no discomfort with patient, or you have given some sedation?
No, sir. We have excluded those patients from the study whom we had to sedate during the procedure. Pre-op assessment, we took only those patients who were comfortable with the surrounding and there were no anxiety present in them.
इसकी जगह हम लोग टैब ब्लॉक भी दे सकते थे उसको.
Sir, tab block भी दे सकते हैं. Yes, so that also comes under regional block. Yeah.
No, tab block is more
efficient.
Is more comfortable, more field of anesthesia is there. Huh?
Yes, sir. Surely we can use that, sir.
Thank you.
Thank you, sir.
Next is Dr. Swati Singh. Dr. Swati Singh, if you can hear me, please unmute and share your screen.
Am I audible, sir?
Yes, you are audible. Please share your screen.
Yes, sir. Sir, is my screen visible?
Yes, your screen is visible. You can start with your presentation.
Good afternoon, judges and all the delegates attending. I am Dr. Swati Singh, second year resident of Department of Anesthesiology from MGM Medical College and MY Hospital, Indore. I am presenting poster on ethical aspects of anesthesia care under the guidance of my professor, Dr. Monica Gandhi, and my professor and HOD, respected Dr. KK Arora, sir. Coming to introduction, medicine is a respected noble profession with codes of behavior and definite rules of conduct. A physician has moral obligation towards his patients based on physician-patient's relationship. Ethics help in making decisions that create positive impact, steer us away from unjust outcomes, and to have clear conscience. Medical ethics is based on 4 pillars, and those are: first, autonomy; second, beneficence; third, non-maleficence; and fourth, justice, which hold up the dignity, honesty of our profession. Our ethical guidelines are based on 2 theories: utilitarianism and deontology. Utilitarianism is an action that should be done if it leads to best possible outcome for the most people, while deontology is based on if certain actions are right or wrong, regardless of the outcome. Now, ASA ethical guidelines with respect to patients. Patient's interest and his right of self-determination is foremost, including minors in decision-making as per their developmental capacity and medical issues involved. We should not use medical skills to restrain or coerce patients who have adequate decision-making capacity. Monitor yourselves and your colleagues to protect the physical and psychological safety, comfort, and dignity of your anesthetized patients. You should personally participate in process of informed decision-making, especially regarding choice of anesthesia technique. Describe your level of patient care involvement to patient, patient surrogate, hospital, and community, which is essential for informed consent. We should be able to directly participate in most demanding aspects of anesthesia care and provide appropriate post-operative care for patients. We shouldn't participate in exploitative financial relationships and provide care irrespective of patients' ability to pay for care. Some ethical dilemmas that we may pose as anesthesiologists, and those are defining competence or capacity in mentally impaired and in children, informed consent and Ulysses directives in vulnerable, withdrawal and withholding of medical therapies in end-of-life decision-making, physician-assisted suicide and euthanasia, ethical issues of organ transplantation, donation after brain death or donation after cardiac death, surrogate decision-making, advanced directives, and DNRs in OTs. In last, I would like to conclude, there may be specific circumstances when elements of following guidelines don't apply and wherein individualized decisions may be appropriate. Thus, it becomes important to understand the concepts of these ethics, which are founded in professionally established standards rather than in personal beliefs, and to not underestimate the sensitivity of such issues. Thank you.
Thank you. Over to our judges.
Dr. Swati.
Yes, sir.
What are the top 5 ethical issues in healthcare?
Sir, to treat every patient equally and equitably. And sir, getting informed consent and making the patient understand what the procedure would be and what are the risks and what are the alternatives to the procedures. Because in India, we know that our population is not
No. Doctor and patient confidentiality, malpractice and negligence. These are the ethical issues.
Yes, sir.
Physician assist suicide. So what is autonomy?
Autonomy is, sir, the patient has right to self-determination. That is, patient has every right to make a decision for himself.
Okay. What are the component of the informed consent?
Sir, informed consent, the consent.
Component of the informed consent, 5 components. Do you know the components of informed consent?
So the consent should be. And
do you understand my question? What I want to know?
Yes, sir. So components of informed consent you are asking me.
Yes, definitely. Like disclosure, comprehension. Do you know?
Yes, comprehension.
Yes, and competency.
So confidentiality, benefits, alternatives.
Actual consent. Chalo, over to Subhas, please.
Dr. Swati, you have written that what the basic principle for ethics, justice. What do you mean by justice here?
So that each patient is to be, every patient is to be treated equally, and all the resources should be equitably distributed among the patients.
All the benefit that possible should be given to patients. And third one is beneficence. What is that?
So that is, we have to do good by the patient. We whatever is good for the patient, we have to offer that to the patient.
Basically, take positive step to prevent any harm.
Yes, sir.
A good topic, and we should have an idea all about these things in our practice and treatment. Thank you.
Thank you, sir.
Thank you, sir. Nice presentation. Next will be Dr. Anshul Taran. Dr. Anshul, please turn on. Please unmute yourself and share your screen.
I think Anshul is not there.
Yes, sir. Dr. Anshul is not in the participants. The next is Dr. Santosh Rajput.
Okay.
Good evening, sir.
Good evening, Santosh. Dr. Santosh, yes, you can share your screen now.
Hello. Hello.
Yes. Start with your presentation.
Yes, sir. Good evening, sir. My topic. My name is Dr. Santosh Rajput. My moderator, Dr. Rasmi Pal ma'am, and Dr. K.K. Arora sir, professor and HOD. My topic is benefit of using N-acetylcysteine in anesthesia and ICU. In anesthesia, mainly preoperatively, and in ICU, postoperatively. N-acetylcysteine is a forgotten immune modulating and antioxidant and anti-inflammatory characteristics. This drug is belong to the class antioxidant toxicology emergency. N-acetylcysteine has the half-life of in adult 5.6 hours and neonates is at around 11 hours. Its clearance is around 0.1 liter per hour per kg. The volume of distribution of the drug is 0.47 liter per kg. It's mainly excreted mainly by the urine and feces through the liver ducts. The therapeutic uses of this drug is mainly it is conventionally using during the paracetamol overdose and antiviral agent, and recently in the COVID patient it is used mainly for the expectorant and free radical scavenger. In anesthetic, N-acetylcysteine can be added to the local anesthetic to reduce the scar area and the inflammation. And in the pre-operatively to the patient who have the drained LFT to protect from isoflurane or other inhalational anesthetic in the general anesthesia. N-acetylcysteine is also have the anti-inflammatory action. The main mechanism is to suppress the nuclear factor kappa beta activation and subsequent cytokine production get decreased. Primary role of the NEC is antioxidant, which is the ability to increase the intracellular concentration of glutathione, and that is the reduced glutathione, which is the most crucial biochar responsible for cellular redox balance. And it is also used in many studies that it is whenever it is used preoperative, it improves the cognitive improvement. In ICU, it is safe and effective to prevent and delay the ventilator-associated pneumonia, and it is also used in acute respiratory distress syndrome. And it improve complete recovery rate in selected and even in high-risk ICU patient. In the dose of 600 milligram, which is available into the water-soluble effervescent tablet. And it can be used by the nebulization, mainly for the mucolytic action, which break the disulfide bridge of the high molecular weight glycoprotein which are present in the mucus. In the COVID patient and ICU patient, it mainly improve the T cell immunity and it decrease the inflammation. Conventionally, and N-acetylcysteine is used mainly for paracetamol overdose. It also have the neurogenic and neuroprotective properties, since the NEC has the ability to effectively cross the blood-brain barrier and rising the reduced glutathione level in the brain, which is responsible for its anti-inflammatory action and action on essential neurotransmitter. It also has the antiviral action by inhibiting the nuclear factor of kappa beta, as well as replication of to the human influenza virus and respiratory syncytial virus. It improves the lungs function to reduce mortality rate. And best thing is that NEC can be given by the nebulization, oral, and even IV dose. Mainly in our COVID patients, we found that the virus induced the cytochrome storm, superoxide anion radical, and which cause directly injury to the alveoli and other aspects by mainly producing the hydroxyl radical and hypochlorous acid. So ultimately, N-acetylcysteine mainly can be used preoperatively to suppress this inflammation, and post-operatively in case suppose patient went post-op delay recovery. Thank you, sir.
Nice presentation. Over to our judges.
Dr. Santosh,
Yes,
what
sir.
are the uses of N-acetylcysteine in anesthesia?
Yes. Sir, in anesthesia. Yes, sir.
Uses of NAC in anesthesia.
Yes, sir. In anesthesia, sir, यदि अपन किसी पेशेंट को प्री ऑपरेटिवली यदि किसी का रेंज LFT है, यदि SGOT, SGPT रेंज है, तो अल्टीमेटली सर ये देखा गया है कई स्टडी में भी कि ये एंटी इंफ्लेमेटरी की तरह काम कर रहा है. जो आइसोफ्लोरेन जो इनहेलेशनल एनेस्थेटिक है, उनके कारण पोस्ट ऑपरेटिव पेशेंट का LFT RFT रेंज होता है. तो यदि किसी पेशेंट में N-acetylcysteine पहले से देते हैं तो उनके लीवर फंक्शन रेंज नहीं होता. और इसके अलावा सर जो जिन पेशेंट का क्रिएटिनिन लेवल भी पहले से बढ़ा हुआ या फिर रेंज है, तो एंटीऑक्सीडेंट एज अ एंटीऑक्सीडेंट इट कैन बी यूज्ड.
Okay, what is the maximum recommended dose of acetaminophen?
So paracetamol can be given up to the
You are using this drug for the treatment of the acetaminophen toxicity.
Yes, sir.
What is the maximum recommended dose?
Sir, maximum recommended dose which can mainly the paracetamol which can cause the poisoning, which is depend on the maximum dose is a 30 milligram per kg 30 milligram per kg can be used, but more than 45 milligram per kg of the paracetamol dose can cause the toxicity. And normally we are using the 15 milligram per kg body weight dose of the paracetamol.
What are the other common uses of NMC, NSE?
Other common effect which are mainly using for the mucolytic purpose, it decrease the it break the disulfide bond in the high molecular weight glycoprotein, and यदि किसी patient sir, it's mainly protective functions.
So over to Shwas, please.
Sir, please unmute.
What are the side effects associated with an acetyl system or on long-term use?
Sir, mainly the N-acetyl cysteine, it is found into the naturally antioxidant, that is onion. है ना? तो यदि long term it has the disadvantage that it can cause the hemolysis, and even it can cause the thrombocytopenia and the acute renal failure. In case of suppose we are giving the suddenly in the patient, matlab rapid infusion, but if suppose it's give the slowly infusion, it does not harm even to that weight of 100 grams.
Chances of GI hemorrhage is more on long-term use. No, long-term use is may cause somnolence or may cause sedation, and or when or on more prolonged use, it has certain androgenic activity. So hair losses and such like of this. Okay.
Yes, sir. Even yes, sir. Thank you, sir.
Thank you. Next.
Next candidate is Dr. Nagma Hassan Siddiqui, Index Medical College, Indore. Dr. Nagma, you can unmute and share your screen. Dr. Nagma, can you hear us?
हिमांशु प्रांजलि को बुला लो अगर वो नहीं आ रही है तो टाइम इज ओवर बेसिकली.
Yes, sir. Dr. Pranjali? Dr. Pranjali, if you can hear us, please unmute and acknowledge. I think Dr. Pranjali is also not here.
Dr. Nagma, Dr. Pranjali ने join करने से मना कर दिया.
Sir, I think Dr. Pranjali is also not here. So this will be the end of our session, sir.
Okay. 1, 2, 3, 4, 5, 6, 7, 8.
Yes, sir. Sir, out of 11, I think 3 candidates, Dr. Nagma Hassan Siddiqui, Dr. Pranjali Verma, and Dr. Anshul Taran were absent during this session.
5, 6, 7, 8. Okay. Okay. Thank you very much. Thank you very much.
Thank you, sir. Thank you for your valuable time. It was a very great. Sir, I will request both of our judges to send their marks to Dr. Amit Jain, sir. Or you can also send them to Dr. Satin, sir.
Okay, I will send definitely.
Thank you so much, sir.
Thank you. Good day, sir.
Thank you. Long live ISA.
Long live ISA, sir. Seema. Good evening, everyone. Now we are going to start our Group C poster presentation session. And as a jury members, we have Dr. Tipti Vatsalya ma'am and Dr. Seema ma'am with us. Ma'am, very warm welcome.
Hello, good evening, everyone.
Good evening, ma'am. Dr. Tipti ma'am is MBBS MD 2011 GMC Bhopal. She's an associate professor, Department of Anesthesiology, GMC Bhopal. She's an executive member, ISA Bhopal City Branch. She has various publications in various journals. She's a co-author of chapter Adjuvants in Anesthesia in textbook Comprehensive Clinical Anesthesia. Her field of interest of anesthesia are endoscopic procedures. Welcome, ma'am.
Thank you.
Our second judge for this session, Dr. Seema Maheshwari Gupta ma'am. She is DNB, IDCCM, FCCS. She is presently working as professor in Chirayu Medical College and Hospital, Bhopal. She has various publications on her name. Welcome, ma'am.
Hello, good evening, everyone. Welcome.
Good evening, ma'am.
Thank you.
Thank you, ma'am. Thank you for your time. Ma'am, we have around 14 candidates with us. Yes, ma'am. Few candidates we have to adjust because a final session we have already started in Hall A. So we will be having 13 to 14 candidates here, and we are giving total 7 minutes. In that, we have 5 minutes for the presentation and 2 minutes for the question answer session now. With your permission, can we call our first presenter?
Yeah.
Yes, ma'am. So the first presenter is Dr. Swati Jhania. Dr. Swati Jhania is second year, Gajaraja Medical College, Gwalior. Dr. Swati, you can unmute yourself and share your screen.
Hello.
Hello.
Yeah, am I audible?
Yes,
Yeah.
Swati, you're audible.
Okay.
You can start with your presentation.
Okay, thank you. My name is Dr. Swati Jhania. I'm from Gajaraja Medical College. I'm here to present a case report on spontaneous pneumothorax on BiPAP support in COVID-19 positive patient. I'm doing it under the guidance of Dr. Shakti Singhal sir, Assistant Professor, and HOD and Head, Dr. Dilip Kothari sir. Introduction. Pneumothorax defined by the presence of air in pleural cavity with or without collapse of the lung is often a life-threatening complication and a medical emergency. It can be classified into spontaneous and etiogenic or traumatic pneumothorax based on the etiology. Although spontaneous pneumothorax has been reported with infection, including COVID-19, the possibility of pneumothorax increases from the combination of parenchymal injury from underlying infection and inflammatory response with additional positive pressure ventilation. The incidence of this complication is still not yet exactly known. As per Chen report, he reported 1% pneumothorax among other radiological features. Case presentation. A 35-year-old overweight male with complaint of fever, cough, shortness of breath since 2 days tested positive for COVID-19 by RT-PCR was admitted in a institute. He was a non-smoker and had no known previous past medical or surgical history and denied any recent trauma. The physical examination on arrival relieved a body temperature of 38 degrees centigrade with pulse rate of 105 per minute and respiratory rate 28 per minute. His oxygen saturation was 88 on room temperature and was admitted in HDU. On O2 support, he was given on NRBN mass at 15 liter per minute, maintaining 96% saturation at the time. He was commenced on the treatment as per the COVID-19 guidelines. On third day, patient suddenly became tachypneic and desaturated up to 72% saturation and was shifted to ICU. In ICU, we have taken the patient on BiPAP with FiO to 80%. IPAP was set on 18 and EPAP was 10. Patient was responding to the BiPAP setting. Chest examination revealed bilateral crackles, and on X-ray, bilateral opacity was seen. The patient full blood count demonstrate raised WBC count with neutrophilia. Leukocyte count was also increased. Hemoglobin was 13. Platelet was 90,000. Other biomedical markers were also raised. like C-reactive protein, ferritin, D-dimer, LDH, and interleukin-6. Over the next few days, there was a gradual clinical deterioration and the worsening of oxygen requirement of the patient. On the 7th day, patient complained chest pain in right side with heart rate 150. Pollen saturation was up to 80%. After ruling out all the other possibility, immediately bedside X-ray was requested and it revealed a large right side pneumothorax. Surgery call was done and ICT was placed under all septic precaution. Saturation improved up to 92% and vital improved for the time. On the 14th day, patient desaturated up to 60% and was technic respiratory rate 42 per minute. Immediately intubated and shifted to ventilator. Unfortunately, he died as a result of cardiac arrest due to multiple organ dysfunction syndrome, despite providing all the resuscitation measures. In our institute, out of 600 patients on BiPAP, 2 patients developed pneumothorax showing incidence of 0.33%. An underlying pulmonary disease is the primary risk factor for the development of secondary spontaneous pneumothorax. Patient with COVID-19 infection can develop severe pneumothorax leading to acute respiratory distress syndrome. Disease is characterized by radiographically by ground glass opacity involving into consolidative changes and in later stage of the disease, fibrotic changes. Similar changes including severe lung injuries and diffuse alveolar damage were thought to be contributed to the mechanism of spontaneous pneumothorax, complicating the severe acute respiratory syndrome. These changes, in addition to possible over-distension of the alveoli by using non-invasive and invasive ventilators, may put patients at risk of developing pneumothorax. In COVID-19, BiPAP has a clinical use to improve the work of breathing. Thus, inappropriate setting may allow the patient to take an excessively large tidal volume, causing barotrauma and volutrauma. To achieve an adequate tidal volume, the IPAP can range from 12 to 35 centimeter H2O, and IPAP prevent alveolar collapse on expiration. Pressure support is calculated by minusing IPAP from EPAP, and it is recommended that there should be difference of at least 8 centimeter H2O. However, Wang reported a case of a patient who developed spontaneous pneumothorax, pneumomediastinum, and subcutaneous emphysema in a patient who was not on a mechanical ventilator. Similar, Zhao reported a case of spontaneous pneumomediastinum in a patient with COVID-19 who was on spontaneous breathing. And Gottini found that the incidence of pneumothorax is higher in patients with ARDS who were on mechanical ventilation for a longer duration of time. Conclusion, pneumothorax can be life-threatening complication of the severe lung injury from COVID-19 pneumonia. It is due to multiple plausible mechanisms and the higher ventilator setting required to manage it. An acute deterioration with rapid oxygen desaturation in a COVID-19 patient would indicate a pneumothorax. Clinicians should therefore be aware that the pneumothorax can be observed within the radiological and physiological manifestation of the COVID-19 pneumonia, and it may lead to an increase in mortality and morbidity. References are this. Thank you.
That was a very nice presentation. Over to our judges.
It was a nice presentation. Doctor, can you tell me that what were the other possibilities that you ruled out apart from pneumothorax, as your patient was having sudden tachycardia and dyspnea?
Ma'am, first of all, I saw the oxygen port was connected or not, machine was connected or not. Other than that, patient was given hydrodexa and the derifylin was given so that patient could get some relief. Position was changed, and after doing all this, we called for an X-ray.
Did you rule out pulmonary embolism or any cardiac insult to your patient?
Yes, ma'am. Cardiology
because
call was
viral
already.
myocarditis is also a very common cause which led to decreased ejection fraction of the patient, reduced ventricular functions that may further aggravate the hypoxemia and all.
But ma'am, as a patient said, there was no history from his side, so we
Okay, I am just asking the differential diagnosis that you should rule out apart from thinking about pneumothorax, spontaneous pneumothorax. Also, you would have checked your ventilator pressures, what pressure, at what pressure your ventilator is delivering to the patient, because ventilator associated lung injury and self-inflicted lung injury, because your patient came to emergency department with saturation of around 80%.
80.
So self-inflicted lung injury is a major cause for this rapid deterioration. Okay, that's all from my side.
Thank you.
Can these high airway pressure which you have said, IPAP and EPAP, can that lead to spontaneous pneumothorax?
Yes, ma'am, they can lead to, but we have started from very low pressure level, but patient was not maintaining a saturation on it, so we have to increase it according to requirement. So it can cause a trauma.
Yeah, already I think the setting was on a higher side.
Yes, ma'am.
Okay, that's all.
Thank you, ma'am.
Thank you.
Thank you, ma'am. Our next candidate is Dr. Syed Abdul Qayyum. Dr. Syed, please unmute and share your screen with us.
Yes, sir. Sir, I'm not able to open my file. Can I do the next? Can I come next, sir?
Ma'am, can we have him at the later part of our session and call the next candidate?
Yeah, I think.
Okay.
We can proceed.
Next is Dr. Harsh Soni. Dr. Harsh, if you're ready, please unmute and share your screen.
Okay. Hello.
Yes, Dr. Harsh,
Am
we
I
are able to
audible?
see your screen. Yes,
Yeah.
you are audible. Please start with your presentation.
Good evening, ma'am. My name is Harsh Soni. I'm GF in James Medical College, Indore. My topic is stellate ganglion block for post chemotherapy extravasation pain. It is accidental extravasation of a chemotherapeutic agent from the peripheral intravenous site. It can lead to tissue loss or ulcer, resulting in serious damage to the patient. Reported in the treatment for this include both non-formal, pharmacological and non-formal method. With for this patient, we have introduced stellate ganglion block because patient was not responding on opioids. Introduction. Extravasation is defined as process fluid leaking from vessel into surrounding tissue. Any intravenous agent can potentially cause extravasation injury, particularly with chemotherapeutic agents, likely doxorubicin, daunorubicin, epirubicin. Damage from the extravasation can lead to severe result of ulcer, necrosis, and ischemia. The incidence of the chemotherapy agent estimated in 0.01 to 7%. Anthracyclines can remain in the tissue for a month following extravasation injury. The consequence of delayed detection of extravasation may include pain, physical defect, psychological distress, cost of hospitalization, and more extensive tissue damage as a result of delay in the treatment. We herein present neglected doxorubicin extravasation resulting in the ulcer with severe pain and allodynia. Her pain was successfully managed with stellate ganglion block. Case: a 55-year-old woman with diagnosis of advanced breast cancer presented to the surgery outpatient department 20 days following doxorubicin extravasation injury. She had received 4 cycles of doxorubicin at a dose of 100 milligram. Combination with regime cyclophosphamide through the peripheral cannula on the dorsum of the left hand. Following the infusion, there was mild swelling around the administration site with no sensory changes, except little pain around the cannula site immediately after the infusion, although there was some concern of the extravasation injury at this point. The skin changes were minimal, so it was thought to be minor injury and immediate treatment was not started. Post chemotherapy, she was discharged from the hospital and was asked to review after a week. She reported after a period of 14 days, referred to our center and complained ulcer and severe pain. The patient had an average pain of 9/10 on numerical rating scale and did not allow even touch her hand. She complained of constant burning sensation and would sleep with forearm hanging out of bed. An acute pain severe referral was sought and was started with oral morphine, 10 milligram 4 hourly. Her initial response to oral morphine was poor and thus was planned to ultrasound guided stellate ganglion block. Lignocaine 2% 3 ml with dexamethasone 8 milligram 2 ml was deposited between the carotid and longus coeli muscles at C7 vertebral level. Patient reported immediate complete relief and same procedure was repeated 2 days later. Patient was discharged after split skin grafting at the site of the ulcer and the pain scale was 1 to 2/10, managed by 1 gram paracetamol twice a day. Discussion: in the case extravasation of the chemotherapy drug, as soon as the patient complains of the pain and swelling, the first step should be immediately stop the infusion while keeping the cannula or port needle in place. This followed by the attempt at aspiration of the chemotherapeutic agent and removing the cannula or the port needle. Limbs should be elevated during first 24 to 48 hours and extravasation followed by the thermal application of either cold or hot pack. Catheter can then be removed if there is no antidotes that need to be infused or extravasated site. Dexamethasone was initially used to reduce the incidence of cardiomyopathy associated with the anthracyclines, but now it also used in early management. Anthracycline extravasation as the 1 to 2 hours intravenous infusion for the 3 consecutive days through the large caliber vein and a limb other the affected one as follows. It usually given at the dose of 1000 milligram per meter square within 5 hours extravasation, and then the doses was 1000 milligram per millisecond. Then next day 500 milligram, and the third day followed by the extra. Local injection of corticosteroids has clinical benefit on the wound healing and prevent ulcer formation. Indication for the surgery in the chemotherapy extravasation include full thickness skin necrosis, chronic ulcer, and persistent pain. It is crucial to remove the necrotic tissue until the bleeding occur, and only healthy tissue must be left for the wound coverage. To ensure the complete excision, some surgeons use the intraoperative fluorescent dye injected to detect the doxorubicin hydrocolloid in the tissues. After this, either immediate or delayed surgical reconstruction and skin grafting can be performed. In our case, delayed skin grafting was performed after 2 sittings of debridement. International Association of Study of Pain has proposed the clinical diagnostic criteria for the complex region pain syndrome. In the oversight patient, the criteria were not met, but due to predominant pain complained with the allodynia, a decision was given stellate ganglion was made. There is no literature available about the incidence of complex regional pain syndrome or extravasation of the chemotherapeutic agent. AGP by the virtue the sympathectomy is created the recognized treatment for many cases of upper extremity complex regional pain syndrome. It has also been used to good result to improve distal circulation in the pain with systemic sclerosis. In summary, this case report raises the possibility that patient with severe pain due to extravasation anthracyclines may respond to sympathetic block. Therefore, early stellate ganglion block can be considered in the management of such cases that involve the upper extremity. However, studies are needed to prove efficacy and to promote the widespread use of the such treatment. Hello.
That was nice presentation. Over to our judges.
Okay, Dr. Harsh, what was the onset time for relief of pain in this patient?
Onset time 1 to 2 hours.
1 to 2 hours. And what about the skin changes?
Ma'am, skin changes I've showed in the pictures. Skin changes was not that much difference was not there, but pain relief was there main. But because we have targeted just concept for the pain,
okay.
No pain.
And did you encounter any other symptoms that your patient has reported after this stellate ganglion block?
No, ma'am.
Like drooping of eyelid or
No,
absence of sweating?
No, because we have introduced USG guided. We have used USG ultrasound.
So what
guided.
are the other techniques that you use for this block?
Other technique.
If suppose you are not having USG with you, then what else can you use to administer this stellate ganglion block?
Ma'am, fluoroscopic techniques.
Okay. Over to you, Dr.
No questions from my side.
Thank you.
Thank you, ma'am. Our next candidate is Dr. Krishna Raj. Sorry, ma'am, Dr. Syed is asking to present.
Yes, ma'am.
To the next presenter is Dr. Syed Abdul Kayam. I want to request all the participants to keep their presentation up to 5 minutes only. Thank you. Dr. Syed, you can continue with your presentation now.
Good evening, ma'am. My presentation is clinical comparison of dexmedetomidine and dexamethasone as an adjuvant to ropivacaine in supraclavicular brachial plexus blocks for upper arm surgeries. I am Syed Abdul Khayyum, first year PG resident, and my co-author is Dr. Ayatullah and Dr. Hari Prasad Reddy, sir, SVS Medical College, Mehboob Telangana. Introduction. Adjuvants to the local anesthetics for brachial plexus block enhances the quality and the duration of the analgesia. Ropivacaine 0.5% is less lipophilic than bupivacaine, and that together with its stereoselective properties, it has a higher threshold for the cardiovascular and central nervous system toxicity than bupivacaine. Steroids have powerful anti-inflammatory as well as analgesic property. Perineural injected steroids is reported to influence the post of analgesia. Dexamethasone have been found to prolong the block duration. Dexmedetomidine is a highly selective alpha-2 agonist that prolong the duration of sensory and motor block and provide a very good analgesia when used as an adjunct to the local anesthetics for nerve blocks, as they augment its effect of hyperpolarization of nerve tissues by altering the transmembrane potential and ion conductance at the locus ceruleus in brainstem. Our aim was to carry out the compare the efficacy of dexmedetomidine versus the dexamethasone as an adjuvant to the ropivacaine in the supraclavicular plexus block. Our primary goal was the onset time and the duration of motor and sensory block and the quality of the intraoperative analgesia. Materials and method. After informed consent, 30 ASA 1 and 2 class patients scheduled for the elective upper limb surgeries under the supraclavicular brachial plexus block were divided into 2 equal groups in randomized double-blinded fashion. Block was performed using the peripheral nerve stimulator after response of twitching fingers were elicited at 0.4 milliamperes. Group of dexamethasone received the ropivacaine of 0.5% 30 ml plus dexmed 1 ml 50 mics plus 1 ml distilled water, making it total as 32 ml. And another group of dexamethasone received 30 ml of ropivacaine, that is 0.5%, and 2 ml of dexamethasone, that is 8 ml, making total 32 ml. Motor and sensory block onset times, block duration, quality of intraoperative analgesia, and duration of analgesia were recorded. Sensory block was assessed by the spirit swab, and motor block was assessed using the 2-point Brome scale. Side effects like nausea, vomiting, and dryness of mouth, complications like pneumothorax, hematoma, toxicity, and neuropathy was monitored. Results: we can see the onset time of sensory block in minutes, which was lesser in the dexamethasone group, which is 12.59, where compared to the dexamethasone group, which was 14. And the onset of motor block was earlier in dexmed group, again that is 14 minutes. Duration of sensory block was more for the dexmed group, which is 899 minutes. And the duration of motor block was also more in dexmedetomidine group. Duration of analgesia was also more in dexmedetomidine group than dexamethasone group. Discussion: ropivacaine itself provide an analgesia for 4 to 7 hours, but addition of adjuvants like alpha-2 agonist dexmed or the steroid dexamethasone to ropivacaine for the block further enhances the onset, quality, and duration of the analgesia. Dexmed is an alpha-2 selective agonist, site of the origin of the descending medulla-spinal noradrenergic pathway. Dexmedetomidine inhibits the release of norepinephrine, terminating the propagation of the pain signals. Pre-op administration of dexamethasone has been shown to reduce overall pain scores and analgesia requirement in the post-op period without any adverse effect, and it reduces the post-op nausea and vomiting due to its anti-inflammatory property. Post-op analgesia was markedly prolonged in dexmed group, while it was only 786 minutes in dexamethasone group. Conclusion: our present study of comparison between the two agents suggests that dexmed is better choice for shortening the onset of motor and sensory block, enhancing the quality and duration of supraclavicular brachial plexus block without any adverse effect. Thank you.
Okay. Dr. Sayed, your presentation was nice, but you missed certain points. What were your exclusion criteria?
We have taken the age group of 25 to 40, ma'am, and the weight nearly it was 50 to 60 kg weight.
No, that was your inclusion criteria, but
No.
you also require some exclusion criteria, no?
Exclusion criteria, the morbid obese patient we didn't, ma'am, and patients with like cardiovascular diseases.
Okay, and you should have excluded diabetic patients also, as you are using dexamethasone, and
Yes,
it is
ma'am.
going to be absorbed systemically, which may lead to increase in blood sugar level.
Blood sugar. Yes,
And
ma'am.
have you monitored the blood sugar in dexamethasone group?
Yes, ma'am.
Okay, so was there any difference from the patients of dexmedetomidine group or not?
Not that much significant, ma'am. It was nearly comparable to same dexmed group.
Okay, and any sedation you have encountered in the patients receiving dexmedetomidine?
Yes, ma'am. It has a slight amount of sedation.
But you have not mentioned that you are using any scoring system for assessment of that sedation. So you should have done it. So that was the loophole in your study, that you were not monitoring for the sedation caused by dexmedetomidine. Okay.
Okay, ma'am. Okay, ma'am.
Over to you, Dr. Seema.
Thank you, ma'am.
Was healing also affected, because steroid may cause hampering in the healing also? So I think that should also be monitored at least for few
few days?
Yes. Yes, ma'am.
Because steroids, they may hamper healing.
Yes, ma'am.
That's all.
Thank you, ma'am.
The next participant is Dr. Krishnaraj. Dr. Krishnaraj, please unmute and share your screen with us.
Yes, sir. Hello. Am I audible?
Yes, Krishna, you're audible. Please share your screen.
Yes, sir. Hello, sir.
Yes, Krishna. You can start presenting this.
Sir, is my screen visible, sir? Hello, sir.
Yes,
Yeah,
Krishna.
yeah, it's visible.
It's visible. You can start.
Good evening, ma'am. Good evening, respected teachers. I am Dr. Krishnaraj Pai, third year RMO student, Department of Anesthesiology, GMC Bhopal, presenting a case of open cholecystectomy under thoracic epidural block in a patient with 30 weeks of gestation. This study has been under the guidance of respected Dr. Shikha Mehrotra ma'am, Professor Ankit Chodi, and Dr. Nilesh Nimas. Going to the introduction as such, cholecystectomy presents the second emergency surgery during pregnancy, the first being appendectomy. Both general and regional anesthetic techniques have been successfully used for cholecystectomy in pregnant patients. And this report enumerates the perioperative issues relating to the anesthesia given to a pregnant patient when such a case is encountered. Going to the pre-procedural evaluation and history, the patient was a 26-year-old female, 30 weeks of gestation of weighing 60 kilograms, presented with complaints of fever, vomiting, and acute pain abdomen since 7 days. Examination was done, and on general examination, patient was fine, and per se systemic for per abdominal examination, tenderness in the right hypochondral region was very specific. On general examination, vitals were very stable. Going to the pre-operative examination of cardiovascular system and respiratory system, all the vitals were normal. And on abdominal examination, uterus height corresponding to 30 weeks of gestation. And of course, fetal heart rate was monitored, which was 150 beats per minute. Routine investigations like complete blood count, renal and liver function tests, serum electrolytes, which were within the normal limits. A USG abdomen was done, which revealed a thickened gallbladder with multiple calculi, which suggestive of cholecystectomy. Now, going to the perioperative management, materials and methods, emergency open cholecystectomy was planned under thoracic epidural anesthesia. The obstetrician and neonologist were consulted, and the patient and her relatives were explained about the possibility of adverse fetal outcomes of miscarriage and premature delivery. Aspiration prophylaxis was followed. Monitors for electrocardiograph, heart rate, non-invasive blood pressure, and oxygen saturation were attached, and patient was preloaded with ringer lactate solution and placed in a sitting position, and the epidural space was identified by the loss of resistance technique in the T9 T10 intervertebral space. An 18-gauge epidural catheter of 4 cm was inserted and kept in the epidural space. Test dose of 3 ml of 2% lidocaine with adrenaline was administered later. 10 ml of 1.5% lidocaine with adrenaline was injected. Adequate block was confirmed by prick and bromide scale. Injection ixospurane infusion was started. 0.5% bupivacaine, 5 cc was repeated every 45 minutes. And intraoperative fetal heart rate was continuously monitored by an external ultrasound transducer. Procedure was uneventful, and ultrasonography was repeated to ensure fetal well-being. Now, going to the post-operative management, analgesia was achieved with epidural top-ups of 0.125% of bupivacaine heavy every 6th hourly for 48 hours. And going to the discussion of the study, during maternal surgery, most important aspect of the fetal aspect is of fetal monitoring, and care is to avoid intrauterine fetal asphyxia. The role of an anesthetist here is to maintain normal maternal blood pressure, oxygenation, carbon dioxide levels, uteroplacental blood flow, and uterine tone. Although the ideal time for surgery in pregnancy is 2nd trimester, Any emergency procedures have to be carried out regardless of the gestational age. Going to the conclusion of this case, although both general and regional anesthetic techniques have been successfully used for non-obstetric surgeries in pregnant patients, but of course, regional anesthesia avoids the potential risk of failed intubation and aspiration, in addition to reducing the fetal drug exposure, degree of blood loss, and uteroplacental blood flow when opting for regional anesthesia techniques. And these are my references used for my study. Thank you, sir. Thank you, ma'am.
Very nice presentation, Dr. Krishna. Over to our judges.
Dr. Krishna, you have managed your case very well, but as you have used a large volume of local anesthetic, why you preferred lignocaine for intraoperative use as compared to bupivacaine?
Ma'am, basically, since I'm using epidural, epidural mode of analgesia, the thing is epidural is a volume-dependent analgesia, ma'am, and if we are giving more dose of bupivacaine, the chances of local anesthetic systemic toxicity is more, and bupivacaine can cause cardiovascular problems compared to lignocaine. Hence, lignocaine has been preferred, ma'am. And it is a short technique, hence lignocaine can be much easily preferred over bupivacaine.
And how you managed any hemodynamic instability as your patient is 30 weeks pregnant? So there are chances of supine hypotension syndrome in these patients. So how you manage?
Yes, ma'am. So, ma'am, basically supine hypotension syndrome can be managed if the patient is taken on the right lateral position with 15-degree bend.
I'm not asking how you can manage, how you managed it, that I'm asking.
Sorry, ma'am. Ma'am, basically we can use injection isoflurane because it's basically a beta adrenergic drug. And we can also use, ma'am, phenylephrine can be used, which is also an adrenergic drug for hypotension, ma'am. And other drugs such as ephedrine can be used.
Did your patient had any episode of hypotension during the surgery?
No, ma'am. This patient didn't have any as such complications, ma'am.
So you are lucky enough to have a very comfortable patient and comfortable surgeon too, because it's very difficult for a surgeon to operate in thoracic epidural, that too in a pregnant patient and operating for a gallbladder. Okay. Okay, good. Over to you, Dr. Seema.
Yeah. How will you manage if inadvertent dural puncture occurs in this patient?
Ma'am, basically, if the patient,
what was
we
your
encounter a dural
plan in case of what was your plan in case the dural puncture occurs?
Ma'am, if the patient, if unfortunately a dural puncture occurs, then ma'am, we should first of all abandon the procedure because we have given a high thoracic block, ma'am. Actually, I have introduced at the level of T7, T8, and if you are unfortunately giving the drug, it can cause cardiovascular complications, and hence, yes.
While performing epidural, inadvertently or accidentally you puncture the dura, though, how will you manage that? It is an emergency procedure. It is an emergency surgery, so you have to proceed.
Yes.
So you cannot abandon the procedure. You can abandon the technique of anesthesia.
Yes, ma'am. We can abandon the technique and we can actually go for another space, ma'am. If at all, since it is an emergency procedure and we cannot, as such, discontinue the procedure because it's an open cholecystectomy, we can go for the next space of. We can palpate for the next space and go for the technique. Repeat the procedure.
Space a higher space or lower space?
Ma'am, I will prefer a space higher, ma'am.
Why?
Ma'am, a lower space, again, it can go for like it's like a, ma'am, dural puncture, it will go for a dural puncture technique, and upper space, we can avoid the filling of the CSF, and it is more safer when compared to a lower space.
Okay.
Thank you, ma'am. Next participant is
you,
Dr. Kushal Raj Patidar. Dr. Kushal, unmute yourself and share your screen.
Good evening, sir. Hello.
Share your screen.
Yes, sir. Yes, sir.
Dr. Kushal, are you not able to share your screen? Dr. Kushal, what happened?
Sir, I'm sharing that.
Okay. If you are sharing and it's not showing, cancel the share and try again.
Okay.
Dr. Kushal, if you're not able to share, we can have you at the end, later part of the session. Okay. At that time, you can be ready.
Okay, sir. एक minute.
Dr. Kushal, are you there?
Yes, sir. Ready to share.
Please unmute yourself and please tell us what is the status.
Sir, unable to share, sir.
Dr. Mandakini Sahu, if you can hear us, please unmute yourself and share your screen.
Am I audible, sir? Hello?
Yes, you're audible. Who is this?
Yes, I'm sure. Mandakini, sir.
Mandakini, you can share your screen now.
Yes, sir. Yes, sir. Sir, is screen visible? Hello?
No, it's not visible currently.
1 minute, sir. Sir, is screen visible or?
Yes, your screen is visible.
Okay, sir.
Go to the multi-screen and open your presentation.
Okay, sir. Visible, sir? Screen is visible?
Yes, screen is visible.
Okay, sir. Okay, myself, Dr. Mandakini Sahu. My poster presentation topic is operator block under the guidance of Dr. H.R. Baghel, sir. I am PG second year from Shamcha Medical College, Riva. Introduction. Operator block provide anesthesia to middle thigh and relaxation to adductor muscle of hip. And it is a mixed nerve derived from anterior rami of L2, L3, and L4. It runs within source major muscle during initial force, crosses close to bladder wall on its inferior and lateral portion, and divides into. Ji, sir.
If you can click on the current page, then we will be able to see a bigger picture. Not
Okay,
this one, the presentation part.
Okay, sir.
Just click on it. Yes.
Yes, sir. Okay. Divides into anterior and posterior division to supply adductors of thigh. It has sensory and motor supply. Sensory to medial thigh and hip joint, motor to the adductor muscle of thigh, and articular bars to hip and knee. It's an indication of operator block are adductor release procedure, adductor tenotomy, treatment of spasticity of thigh adductors due to hemiplegia and cerebral palsy, to suppress operator reflex during transurethral resection of bladder tumor as a supplement to femoral and sciatic nerve block, and chronic pain due secondary to knee arthrosis, pelvic tumors, and Patient preparation, NPO status is confirmed, consent taken, venous access secured, IV Midas 0.03 to 0.05 mg per kg can be administered. Standard monitors applied like ECG, blood pressure, pulse ox, position, supine position of the patient, thigh slightly abducted and externally rotated, stand on the side of block. Technique, aseptic precautions are taken, needle inserted perpendicular to skin, 1.5 centimeter lateral and 1.5 centimeter inferior to pubic tubercle. Needle advanced posterior direction towards superior pubic ramus, local anesthetic injected as needle is advanced. On contacting bond needle, redirected in lateral and caudal direction, advanced needle enters operator foramen at 2 to 4 centimeter depth, adductor motor response of thigh elicited, and reduced stimulation to less than 0.5 milliampere, witness fade of motor activity after injection of 1 ml local anesthetic. 15 to 20 ml local anesthetic injected in graded aliquots after negative aspiration of blood. Am I audible? Hello? Hello?
Yes, you're audible. Please continue.
Okay. Advantage of the operator of block are prevent bladder perforation during TURBT, and the disadvantages are technically difficult. It has lack of clear landmark and block complexity. Complication of the block are adductor muscle spasm, hematoma, needle trauma, intraneural injection, intravascular injection, and neuropraxia, neuralaxia. Okay. And these are the references. Thank you.
Dr. Mandakini, how do you assess the success of your block, obturator nerve block?
Ma'am, operator nerve block success rate is assessed by the surgeon satisfaction score. Only surgeon can accurately tell us that it is a complete good block or not. Matlab, if a reflex is present during surgery, then he is not able to perform the surgery in a good way.
No, apart from that, is there any reliable indicator that you can assess whether your patient, whether you have successfully blocked the obturator nerve?
No, ma'am, only surgeon can tell us.
No. Beta, you can check the adductor muscles relaxation.
Operator reflex is there, ma'am. Muscle contraction is there.
So you have to check for the relaxation of the adductor muscles of the thigh.
Yes, ma'am.
So you cannot only rely over the surgeon.
Yes, ma'am. Yes, ma'am.
And which technique do you prefer? Ultrasound guided technique or nerve stimulator guided technique or landmark guided technique?
Ma'am, peripheral nerve stimulator guided technique.
But you can combine both USG as well as nerve stimulator guided.
Yes,
so
ma'am.
You can visualize in the ultrasound and simultaneously you can elicit the motor response with the help of your nerve stimulator.
Yes, ma'am.
So combine the both techniques for successful block.
Yes, ma'am. Yes, ma'am. Thank you.
Over to you, Dr. Seema.
Yeah, usually TURBT is done under spinal anesthesia. So where the tumor is located when we want to abolish this obturator reflex? Where on which?
Ma'am, on the peripheral part of the bladder.
Peripheral part? No, I think it's lateral wall, not peripheral.
Yes, ma'am, lateral wall.
That's all.
Okay, thank you, ma'am.
The next participant is Dr. Mayank Karode. Mayank, Dr. Mayank, if you're hearing us, please unmute and share your screen.
Is it visible? Hello.
Yes, it's visible. You can start your presentation now.
Good evening, judges. I am Dr. Mayank Karode. I am presenting a case report of difficult airway in a patient with congenital facial deformities posted for left upper lobectomy. I did this under guidance of Dr. Nupur Chakravarti, who is a professor in HOD. So difficult airway is a clinical situation in which conventionally trained anesthesiologist experiences difficulty with face mask ventilation of the upper air, or difficulty with the tracheal intubation, or both. Congenital syndrome such with facial and skeletal deformities such as Down syndrome, Beckwith-Widman syndrome, Pereira-Robin syndrome, Golden Heart syndrome, Epworth syndrome, Klippel-Feil syndrome commonly present with difficult airway. Difficult airway is due to limited neck extension, limited mouth opening, restricted temporomandibular joint mobility, macroglossia, retrognathia, macrognathia, palatal malformation, lip mandible, and laryngotracheal passage malformations. Now here we present a case report of a 29-year-old male who was posted for left upper lobectomy. It was a case of left subacute invasive pulmonary aspergillosis. With blood-stained sputum since last 7 days and similar complaints 18 months. For past history, he was full-term normal delivery with short neck, high arch palate, ptosis of the right eye, scoliosis, CTEV, cubitus equinovarus, and patent ductus arteriosus. He lost all denture by the age of 20 years and uses now a detachable denture. Surgery for CTEV was done at the age of 2 years, and PDA, patent ductus arteriosus ligation, was done at 5 years of age. He had a history of pulmonary TB at the age of 21 years, for which he took treatment for 9 months. On general examination, he was conscious oriented, bilateral clubbing was present. He had malformation for bilateral forearm and bilateral feet. And scoliosis was present, and lower rib cage end at level of umbilicus. He had right ptosis. On vitals, he had BP of 110 by 16 mmHg, pulse 80 per minute, and respiratory rate of 90 per minute. Same as his verbal, he was following all the verbal commands, moving all 4 limbs, and had normal mentation. S1 is to present. Respiratory examination, bilateral chest entry were present, and threats were present on left side, and para-abdomen was soft, and vowel sounds were present. On airway examination, he had micropnea, large tongue, relatively larger tongue, high arch palate, 2-finger mouth opening, and thyrometal distance of 5 cm. And myelopathy grade 4 was seen. Detachable artificial denture was seen that he used. So he was edentulous, and he had normal neck mobility. ECG was normal. CCT just suggested subacute pulmonary aspergillosis. And spirometry revealed FEV1 by FVC of 85.55. Now the anesthetic challenges in this patient were macroglossia and micropnea, small mouth opening, and he was edentulous. That will lead to difficult mask ventilation. And we had to choose double human tube for lung isolation. So anesthetic management was done. Difficult airway trolley and resuscitation set was there, and preparation was tracheostomy was done. Monitors were attached, and we measured IBP, heart rate, SpO2, ECG, CVP, and temperature. Pre-medication was done with 0.2 mg glycopyrrolate, midazolam 1 mg. They were given 20 minutes before induction. Nebulization was done with 5 ml of 4% lignocaine for 10 minutes, and fentanyl was given 100 mcg. Now, patient was with 90 mg of propofol. Bag and ventilation was done with artificial denture in situ for 3 minutes. Artificial denture was then removed before laryngoscopy. Now, check laryngoscopy was done that revealed the cornet hemorrhage of 3. Succinyl choline 75 mg was then given. Double lumen tube 32 French was chosen for this, and it was passed through the vocal cords. Then correct placement of the left-sided tube was checked through flexible fibroscope, and it was fixed at 27 cm. Patient was put on ventilator with a tidal volume of 4 ml per kg body weight. Peak was set as 4 cm H2, and high pressure and were observed intraoperatively for high pressures. Maintenance was done through oxygen, air, sevoflurane, and vecuronium was given for muscle relaxation. He was given right lateral position. Adequate padding was done over the dependent pressure points, and no perfusion ventilation mismatch was noted intraoperatively. Surgery was done, and ICD was placed on the left side. Double lumen tube 32 French was changed after the surgery, and a single lumen tube was a conventional single lumen tube was inserted with the help of bougie. Patient was shifted to ICU, and then extubation was done next morning after clinical assessment and EVG analysis. So, discussion: patient who present with facial and skeletal deformities are often challenged for anesthesiologists in the form of difficult airway and ventilation throughout the induction and maintenance of anesthesia. Also, such abnormalities are part of congenital syndromes with abnormalities in other systems of body. So appropriate pre-anesthetic checkup and patient optimization must be done, and they are the key for conducting good case, and difficult airway preparedness must be ready for the surgery. Fiber optic guided intubation serves as a gold standard in such cases for securing airway as well as to check the correct placement of the plug. These are my references. Thank you.
It was a well-managed case, Dr. Mayank, but did you perform intubation with conventional laryngoscope or fiber optic bronchoscope?
Ma'am, we did it with conventional laryngoscopy because the Cormac-Lian grade 4 was seen, but
I think
it was,
grade 4 is a difficult intubation
yes,
for
ma'am.
conventional.
Yes, ma'am. It
So
is
you intubated without any difficulty, or you faced some difficulty in placement of your tube?
difficult. The epiglottis was in place. Epiglottis was not clearly visible, but we were able to guide it.
Guided with the help of what? Did you require any use of stillet or something else, or you required
we
the
used the stillet. We used the stillet.
Okay.
Then we removed the stillet once it passed to the vocal cords.
Okay. But double lumen tube requires rotation once you enter inside the vocal cord. So was it an easy intubation, and your patient, what about the pre-oxygenation you used for your patient? Was there any other, which technique you preferred for pre-oxygenation?
We ventilated him for 3 minutes with tidal volumes, normal tidal volume and 100% oxygen.
Okay, so your patient did not had any episode of desaturation?
Yes, ma'am, we did encounter an episode of desaturation.
Okay. Over to you, Dr. Seema.
Why the double lumen tube was changed to 6 mm of internal diameter of the tube? Because the patient is adult and normal weight.
No, he was not normal weight. He was 30 kg.
Sorry?
Patient. He was 30 kg weight.
30 kg.
Yes.
So I think a tube with a greater lumen can be used, because 6 mm internal diameter tube will have again more resistance in post-op ventilation. 30 kg, I think we can use at least 7.
Ma'am,
it was tried, or it was planned, or it was...
No, ma'am, we just tried and it was...
7 mm was tried and then 6 mm.
Ma'am, we tried for 6 mm and it worked for us, so we left it there.
Okay. Okay.
Thank you.
Thank you, Dr. Mayank. Thank you, ma'am. Next presenter, Dr. Kushal Raj Patida. Dr. Kushal, please unmute and share your screen.
I'm audible, sir. Hello.
Yes, Dr. Kushal, you can start.
Yes, sir. So, good evening to all of you. I'm going to present my case report, anesthetic management of a patient with large thyroid mass posted for total thyroidectomy, presented by me under the guidance of Dr. Suman Gupta ma'am and HOD Dr. Kothari, Dr. Dilip Kothari, sir. Introduction: as an anesthesiologist, airway management is an essential part of daily practice and also have been a challenge for anesthesiologists. A giant neck mass could distort the airway and thus is a cause difficult airway mask ventilation and endotracheal intubation. Matthew et al. Reported that the overall incidence of difficult intubation in thyroid surgery was 11.1%. Use of fiber optic intubation in case of difficult airway management has been reported successfully in patients with enlarged thyroids. We present one such case of successful intubation with help of fiber optic bronchoscope using loco-sedative technique in a male patient with huge goiter, where previously scheduled surgery, total thyroidectomy, were postponed because of inability to intubate the trachea with conventional and other techniques like intubating LMA, IGL, and video laryngoscopy. My case was a 60-year-old male presented with the complaint of gradually increasing swelling in front of neck for past 3 years. Patient had a history of palpitation and anxiety since 2 years before and was diagnosed to be hypertensive and hyperthyroid. He was put on tablet. Uh, Neomercazole 10 mg BD, verapamil 40 mg OD, olmesartan 40 mg OD, which he was continuing. He had no history of change in voice and no respiratory symptom. He was diagnosed a case of multinodular goiter, advised surgery, total thyroidectomy, and he was hospitalized for the same in June 2020. Case was postponed for operating room due to failed intubation, and patient again hospitalized in our institute in July 2021 with additive complaint of difficulty in swallowing. On examination, patient was conscious, cooperative. The swelling did not move with deglutition. On palpation, it was firm, immobile, and skin above was free. Airway examination showed two-finger mouth opening, limited neck extension, and severely restricted neck flexion. Pulse was 90 per minute. Blood pressure was 140 per mmHg. ECG showed normal sinus rhythm. He had no strident, no respiratory difficulty, even in lying down position. The dimension of the neck swelling was 9.3 centimeter into 99.4 centimeter to 10 centimeter in size. Swelling was nodular and on left side of the neck, extending from lower jaw up to sternal notch, and showing in the figure number 1, which showing the lateral view of the neck showing large, huge neck mass. The lower limit of the swelling was neither visualized nor palpable. There were no distended veins on the chest assessed. Radiologically, examination MRI neck revealed that the lesion significantly displacing trachea, esophagus, and right lobe of thyroid towards the right side. Laterally, the lesion displacing neck vessels toward the left side. Left jugular and left internal jugular vein is compressed. Bilateral false vocal cords, true vocal cords, cricoid cartilage are normal. Post-cricoid region appears normal. T3, T4, T6 level within normal limit, and all baseline investigation like CBC, RFT, LFT were within in normal limit. In view of previous history, anticipated difficult mask ventilation due to huge size of the tumor and difficult laryngoscopy and intubation. This time, awake fiber optic intubation was planned for the patient under loco-sedative technique. Difficult airway management cart with rigid bronchoscope and jet ventilation was kept ready. The procedure was explained to the patient and written consent was taken. Patient was kept fasting for 6 hours for solid meals and 2 hours for water before shifting to operating room. Anti-thyroid medication and antihypertensive were continued till morning of surgery. Metoclopramide 10 mg was given with small sip of the water one night before and morning of the surgery. No pre-operative sedation was prescribed. Patient shifted to operating room, standard monitor, ECG pulse oximeter, and NIBP were attached, and baseline vitals were recorded. Injection glycopyrrolate 0.2 milligram IV was administered. The patient's airway was anesthetized with lignocaine viscous 2% gargles, 4 ml of lignocaine, 4% nebulization, and lignocaine spray 10%. As because of the distorted anatomy, the neck block could not be assessed. So oxygen was administered via face mask at 5 liter per minute. Patient was administered 2 milligram midazolam, 60 microgram fentanyl to allay anxiety and for mild sedation. Fiber optic bronchoscope was loaded with 8 millimeter armored endotracheal tube. Fiber optic intubation was attempted. Laryngeal and esophageal opening were visualized side by side with the laryngeal inlet on the right side. Patient was instructed to take deep breath to facilitate identification of the airway. Fiber optic bronchoscope could be negotiated through the vocal cords with difficulty because of the airway distortion. The fibroscope was advanced and positioned above the carina. Lignocaine 2% was administered via the drug port of the fiber optic bronchoscope, as and when required, to facilitate passage of the fiber optic bronchoscope. Endotracheal tube was then red-rodded over fiber optic bronchoscope and the fiber optic bronchoscope was done. 80 milligram propofol was administered prior to railroading of the endotracheal tube through the vocal cords to attenuate the laryngeal and tracheal reflex. The breathing circuit was attached and the tube placement was confirmed by movement of the reservoir beak. Anesthesia maintained with oxygen to nitroxide ratio and sevoflurane inhalation. 150 microgram of fentanyl and 5 milligram vicronium were administered intravenously. The endotracheal tube was first firmly secured and anesthesia was maintained with oxygen nitrous oxide. Total thyroidectomy was performed. The patient remained hemodynamically stable throughout the procedure. A trolley for emergency intubation with rigid bronchoscope was kept ready. Patient was extubated and kept in post-operative area for 24 hours before being discharged to ward. The discussion was difficulty with intubation may be caused by an enlarged thyroid gland producing tracheal deviation, compression, or both. Amity et al. Concluded that classical predictive criteria like mouth opening in this report, we present a case of 60-year-old male with huge toxic multinodular thyroid swelling, gradually increasing in size for last 3 years, where trachea was successfully intubated. He had a history of deferred surgery in June 2020 due to inability to intubate, despite 2 to 3 attempts using different laryngoscopes, Buji and Stiller. Patient was readmitted in July 2021 for the surgery and was successfully intubated, this time with the help of
Dr. Kushal, your time is up. Please wrap it fast.
Yes. Low-cost technique. Eldovetley et al. Reported a case of the obese female with huge goiter presenting with the difficult airway, where trachea successfully intubated with fiber optic bronchoscopy and locosedative technique. Same case was reported. Suhas Casey reported a huge goiter with intubation has been done in awake fiber optic bronchoscope in sitting position. So conclusion, there is so many ways for managing anticipated difficult airway like BG, Stillate, and direct video laryngoscopy, but the use of awake fiber optic intubation are considered as a gold standard in case of difficult airway situation. It also reduces the number of the attempts, morbidity, and complication associated with difficult airway. Thank you.
Dr. Kushal, you performed orotracheal intubation or nasotracheal intubation?
Ma'am, I had performed orotracheal intubation.
Okay. So how did you avoided the biting of the tube as your patient was conscious and you were performing awake intubation?
Previously we explained the oral procedure of to the patient and
so you have not mentioned that you have explained. This is very important point that you need to counsel the patient what procedure you are going to perform. Then only your patient will be cooperative. This is the first and foremost contraindication for awake fiber optic, that if your patient is uncooperative, you cannot go ahead.
Yes,
also, you have not checked the nasal patency, neither you have undergone indirect laryngoscopy for such a big thyroid mass. You should rule out the presence of recurrent laryngeal nerve palsy in the preoperative period, because if you are performing total thyroidectomy, there are chances that recurrent laryngeal nerve might be injured and your patient may land up into postoperative airway complications. So have you encountered any complication postoperatively in your patient?
No.
No, with total thyroidectomy, your patient was absolutely normal. Your extubation was also smooth.
Yes, ma'am. Extubation was smooth.
Was there any plan at the time of extubation?
Yes, ma'am. We had expect for the fall in saturation and other complication like this bronchospasm and laryngospasm. So we will keep the difficult airway trolley.
The patient with a difficult intubation is also a case of difficult extubation. So you should be well prepared at the time of extubation also. Over to you, Dr. Seema.
Yeah. What is the most important complication which can occur during extubation, and which you have not mentioned?
That's what I was also asking.
Tracheomalacia, like it's a
Yes, ma'am.
long-standing large goiter, multinodular goiter. So how will you rule out tracheomalacia? You can ask the operating surgeon to feel the tracheal rings, and leak test can be performed.
Yes, ma'am.
Okay. That's all.
I mean, post-op, we can also done chest X-ray and X-ray neck. So,
In the operating room. I'm talking about in the operating room. When you were extubating, before extubating. Okay, is it clear?
yes, ma'am.
The next participant is Dr. Mithun Mohan. Dr. Mithun Mohan.
Hello.
Yes, Dr. Mithun, please share your screen. Yes, start with your presentation.
Hello. Am I audible?
Yes, Dr. Mithun, you're audible.
Okay. Good evening, everyone. I am Dr. Midun Mohan from NSCB Medical College, Jabalpur. Today, I am presenting an e-poster on the topic anesthetic management of a case of occipital meningoencephalocele. Encephalocele is herniation of cranial contents through a congenital defect in the cranium. Meningoencephalocele is herniation of both neural elements and meninges. Most common location of a meningoencephalocele is occipital region, and incidence is about 1 in 5,000 live births. Management of occipital meningoencephalocele is quite challenging for anesthesiologists. In our hospital, we had a 2-year-old baby who presented with a large cystic swelling at the back of the neck and was posted for surgical excision of the swelling. Baby was active and had a weight around 8 kgs at that time. Size of the swelling was 22
Sorry to
into 8.
interrupt, Dr. Mithun. We have a limited time of 5 minutes. You have to go fast.
Okay, I'm going. Size of the swelling was around 22 into 18 to 12 centimeter. The 3D CT skull showed a defect in the occipital bone through which cranial contents were herniating. During our routine pre-anesthetic checkup, we anticipated a difficult intubation because of the difficulty in positioning of the baby on the operating table and because of the difficulty in extension of the neck due to the big size of the swelling. Other congenital anomalies were ruled out by detailed clinical examination and investigations. As you can see in the operating room, baby was placed supine on a raised platform made with pillows, and swelling was allowed to hang beyond the edge of the pillow. Height of the pillow was adjusted such that meningocele surface just touched the mattress of the table so that compression of the swelling was avoided. Baby was pre-medicated with IV glycopyrrolate, deoxygenated, and induced with sevoflurane 6% using an RBS mask size 1 and ventilated with Jackson-Rees modification of ISTPs. After confirming adequate mask ventilation, muscle relaxation was achieved with succinylcholine 15 mg IV. Baby was intubated with 4 mm uncuffed ET tube after direct laryngoscopy using Miller blade 1 on first attempt itself. After ensuring bilateral equal air entry, we secured the tube and baby was taken into prone position for surgery. Maintenance of anesthesia was achieved with oxygen, sevoflurane, and atracurane. Surgery was completed in 1.5 hours and was uneventful. After surgery, baby was put back to supine position. On return of spontaneous respiratory efforts, baby was reversed with reversal, which consisted of IV neostigmine and IV glycopyrrolate, and baby was extubated after adequate return of muscle power. Baby cried normally, and immediate postoperative period was uneventful. Baby was shifted to postoperative ICU where he was monitored for 2 days and he didn't develop any postoperative complications. Baby was discharged after 1 week. So to conclude, perioperative management of occipital meningoencephalocele is challenging both for an anesthesiologist and a neurosurgeon. Managing such a case includes looking for other congenital anomalies, expertise in handling airway, proper positioning, and blood loss replacement. These are my references. Thank you.
How did you avoided the puncture of this large meningocele?
Ma'am, the baby was positioned in such a way that we made a raised platform where baby was laid down and the head was allowed to hang down from the platform, and it was supported with the soft cushion of the operating table and also by the hands of the anesthesiologist who stood behind.
Okay, that's all.
Thank you.
Intubation and lateral position, was that thought of?
Ma'am, yeah, we could have tried, ma'am, but we opted for this supine position this time because surgeons were also willing to operate in prone position only. If they're operating for lateral position, even we could have thought of lateral.
Okay. At what age the airway of a child and an adult becomes same?
Ma'am,
I mean, you got my question, no?
yeah, 4 years.
Sorry, 4.
Yes, ma'am.
No, it's 8 years.
Okay.
Okay. That's all.
Thank you.
Next will be Dr. Nandita Shivram. Dr. Nandita.
Hello, am I audible?
Yes, you're audible. You can start your presentation.
Is my screen visible?
Yes, your screen is also visible.
Okay. Good evening, respected judges. I'm Dr. Nandita Shivram from NGM Medical College, and I'd like to present my topic, Challenges in Airway Management in Patients of Burns. Burn injuries are one of the most devastating challenges to manage from all surgical, medical, and anesthetic point of view, and are hence a leading cause of death. Management of burn patients need an early, aggressive approach, and from an anesthetist perspective, burn patients present with both anatomical and physiological challenges, and the risk of death increases proportionally with the advancing age, presence of inhalational injury, and the size of burn injury. I'd like to point out the classification of neck contracture. The mild ones are where the extension is affected, and the neck extension is allowed for 95 to 110 degrees, and the moderate ones are where the scar appears in resting position and the neck extension is allowed from 85 to 95 degrees, and the severe cases neck is already in a flex position and the scar limits any kind of neck movement, and the extension is less than 85 degrees. And in case of airway assessment of burn patients, the key features include any kind of pre-existing airway abnormality, current airway injury, and signs of glottis obstruction. The anatomical challenges: airway of patients with major burns, especially oromaxillofacial burns, should be assessed as early as possible because they have both acute and chronic problems. The acute problems are soft tissue changes due to edema, and due to laryngeal edema, tubes of smaller sizes should always be readily available. And in case of chronic burn, there would be scar in the scar face, contractures develop which contribute to anatomic variation. Difficulty is faced in all levels. First is the bag and mask. Here, the facial contracture results in affecting the mouth seal. There's a limited jaw movement, oral or perinasal contracture, which reduce the airway patency, and the dressings also make it difficult to make the seal. Next is our laryngoscopy and intubation. There's inadequate mouth opening, restricted neck movement, anterior larynx, and inability to apply burp, and formation of stenosis and granuloma. If we try for a supraglottic airway device, there is a restricted mouth opening and limited jaw and inadequate head extension and distorted pharyngeal and laryngeal anatomy. the difficult surgical airway, which is our last approach, the anatomical landmarks cannot be located a lot of times, and the extension is not possible, and hence there is inadequate space. And due to thick scar, there is difficulty in identification of structure, and the incision and fibrotic scar sometimes leads to excessive bleeding. I'd like to point out towards the picture of an acute burn patient. Here there is circumoral burn scar, and in such cases mouth opening, and hence the gap between incisors is limited. And the second is the mentosternal contracture, which leads to a limited range of cervical motion and hence hyperextension. Physiological challenges in intubation of burn patients. If muscle relaxants are given, the elasticity of the scar tissue and loss of pulling action by the surrounding tissue further aggravate the scar retraction, making it furthermore difficult to intubate. And in such patients of burn come under difficult airway, and this is the guideline that we have to follow. First, we have to try the laryngoscopy, and if it fails, then we have to go towards supraglottic airway device. And if that fails, we have to have a final attempt at face mask ventilation. And if that fails, we have to further go for cricothyroid. Here are the airway management options. If the gap between incisors is more than 3 centimeters, following methods are to be taken: laryngoscopy or supraglottic airway device. In case of 2 to 3, we would prefer a supraglottic airway device. In case of 1 to 2, it is better to go for a fiber optic intubation. And if it is less than 1 centimeter, nasal fiber optic intubation or a contracture release under local anesthesia has to be preferred. A surgeon at all times should be at standby and be ready to intervene for any kind of possible surgical release or emergent tracheostomy. Thank you.
That was very nice presentation. Over to Jatin.
Yeah, it was a nice and very comprehensive presentation. So what are the challenges you face in a patient when you're performing fiber optic intubation in case of patients?
In case of fiber optic intubation, the first and foremost challenge is the patient cooperation. As it is, the patient is in agony, and fiber optic intubation can be performed only with the assistance of the patient's cooperation also. So that is one place where we have to take care of. And amongst all the approaches, fiber optic is our gold standard approach because it causes least trauma. And but the only catch here is the patient cooperation.
But pertaining to burn patient, why you are worried about what things you should keep in mind when you are performing fiber optic intubation? As you told, there are chances of oral scarring, also nasal, oronasal scarring is there. So you relatively prefer smaller size tube, and you should check the nasal patency before proceeding for fiber optic intubation. Also, in cases of burn patients, there is deranged coagulation profile, there is abnormal platelet function and count. So you should be aware that there should not be any trauma, and so you should not perform it blindly. You should always perform it under vision, and an expert person should perform the procedure. Otherwise, if there is a trauma, then your fiber optic, you cannot visualize anything with the help of your fiber optic bronchoscope.
Yes.
Okay. Next, over to you, Dr. C.
Yeah, no questions.
Next will be Dr. Neha Vaishnav.
Good evening, sir. Am I audible?
Yes, you're audible. You can share your screen now.
Is it a screen visible? Hello? Is it a screen visible, sir?
Yes, the screen is visible. You can start with your presentation now.
Yes, sir. Good evening to all of you. My topic is the anesthetic challenges in the case of the giant encephalocele. I'm Dr. Neha Vaishnav from the MJ Medical College. First of all, encephalocele are the congenital cranial defects, mainly due to the primary arrest of the bone development, leads to the herniation of intracranial content. From anesthetic point of view, our aim is to avoid the premature rupture of the encephalocele and to manage a possible difficult airway due to inability to achieve optimal position for endotracheal intubation. Inability to achieve optimal position during intubation is our anesthetic challenge. 3 months back, we had a case of encephalocele in which the size of the encephalocele is bigger than the head of the baby. The PND 3 years of female of 2.5 kg weight presented with a cystic swelling in the occipital region delivered by the cesarean section. The mass covered by the pink purplish skin with 30 centimeter in size. The swelling was soft and transillumination test was positive. There was no bruit and murmur heard over the surface of the swelling. There was no history of congenital anomaly in the family. The baby cried immediately after the birth and Apgar score 8 at the 1 minute. The baby admitted in the pediatric surgery department for the excision of the surgery. From how we manage the patient with the alternative airway management plans ready. Patient pre-medicated with injection atropine 0.02 mg per kg and injection midazolam 0.03 mg per kg. We intubated the baby in supine position with the hanging head beyond the edge of the table, supported by heads to avoid the rupture of the encephalocele. In this photograph, we can appreciate the head of the baby is hanging down at the edge of the table and supported by the hand. After induction, patient was intubated using 4 mm uncurved endotracheal tube. Patient maintained on oxygen nitrous CVO and with injection atracurium. Patient intraoperatively, the events were uneventful and the patient was reversed using injection neostigmine 0.05 mg per kg and injection atropine 0.02 mg per kg. The patient was extubated when adequate spontaneous respiratory efforts were returned with the, and maintaining the saturation 100%. In this photograph, we can also appreciate after the intubation, we put the patient in the lateral position for the surgery, and the surgery took for the 3 hours, and then it was successful surgery, and the patient was successfully discharged. From conclusion, anesthetic management of the case of the encephalocele should be focused on the position during the induction and intubation, taking due care to the prevent rupture of the cell, fluid management, and maintenance of the temperature. Thank you.
Nice presentation. Over to our judges.
It was really a huge encephalocele, but what were the complications you anticipated at the time of extubation of this patient?
Ma'am, at the time of extubation, the main problem is we are expecting a bronchospasm in the patient as the intraoperatively there was the uneventful event occurred, but after at the time of extubation we can feel little spasm on bilaterally. That was the challenge we had that time, but without any doing intervention, we appreciate it was just no problem in bronchospasm, but patient was extubated uneventfully, and we don't need any intervention to do. Along with this, the surgical site, the surgeons operated at that site. They don't need to be do much bigger incision, and just only the repositioning of the approximation of the suture. This huge swelling get closed.
How come this huge swelling got closed with a small incision? And you did not observe any delayed recovery or any convulsions with such a huge encephalocele. I mean, there should be a brain matter in this portion of encephalocele.
When biopsy was sent, mainly there was so much of CSF. Along with there is a small portion of cerebellum was there. So the patient was there for 2 weeks here and discharged successfully. But it was PND 3. The tone was okay, and specifically no significant neurological deficit was appreciated.
Okay, and you used 4 mm uncurved tube that I cannot relate to with the weight of the patient, that in a 2.5 kg baby you are inserting a 4 mm uncurved tube. That's a real, and that too you are conducting the surgery for a 3 hours, so your patient might land up into tracheal edema, laryngeal edema. So okay, that's all. Dr. Seema.
Yeah, I totally agree with the size of the tube. I'm also not convinced. Not at all convinced. That's all. Because post-cricoid area is the narrowest area. So it may pass through cricoid. That's all.
Thank you, ma'am. The next candidate will be Dr. Rakesh. Dr. Rakesh, if you can hear me, please
Yes,
unmute.
sir. Oh, yes, sir.
Please unmute.
Am I audible, sir?
Yes, you're audible. Please share your screen with us.
Okay. Sir, my screen is visible, sir.
Now you can start with your presentation.
Okay, sir. Good evening, respected judges. My topic is anesthesia management of lumbar discectomy with mitral stenosis under general anesthesia. Moderator is Dr. Seema Shindevam, Associate Professor, Gajaraja Medical College. Introduction. Mitral stenosis is almost always rheumatic in origin. Incidence of rheumatic heart disease has declined in most of the developed countries, but remain an issue in many developing countries like India. It is most common in female compared to males. The normal mitral valve RFI has a surface area of 4 to 5 centimeters square, and symptoms of mitral stenosis typically develop when the size of the orifice is less than 2 centimeters square or less. I am presenting a case of a 61-year-old lady who was diagnosed to have L2, L3, and L3, L4 prolapsed intraventricular disc, posted for discectomy, and was referred for pre-anesthetic evaluation. There was no history of any medical or surgical illness in the past. On examination, her general condition was normal. There was mild diastolic murmur in the cardiovascular system examination. Under blood investigation, including CBC, RBS, LFT, RFT, and serum electrolytes are within normal limit, and chest X-ray was normal. Our ECG shows P pulmonale, T wave inversion in AVL, tall T waves in V2 and V3, and features suggestive of ventricular premature contraction. And a 2D echo shows severe mitral stenosis with valve area of 0.9 centimeter square with moderate mitral regurgitation, thickened and calcified aortic valve with mild aortic regurgitation, and moderate to severe tricuspid regurgitation with dilated left atrium, and left ventricular function was normal with ejection fraction 60%. There was no clots in the left atrium. On the day of surgery, our pulse rate was 80 beats per minute, regular and rhythmic. BP is 110 by 80 mm of Hg. There was no Krebs and Ronchi and respiratory examination. Our iris consent with in the view of cardiac pathology was taken. Cardiac drugs were kept ready, and urinary bladder was catheterized. Intravenous access with a 18 gauge intracath in the left forearm was taken. Our central venous catheter was put through the subclavian vein. ECG monitor and pulse oximeter were attached. Our arterial vein was secured, and invasive blood pressure monitor was attached, and defibrillator was kept ready. Patient was pre-medicated with injection midazolam 1 milligram IV and fentanyl 150 microgram IV, and pre-oxygenated with 100% oxygen for 3 minutes. Patient was induced with injection double diluted thiopentone in a titrated doses, and succinylcholine 100 milligram. And IPPV done for 60 seconds, and intubated with cuffed DT tube number 7. Anesthesia was maintained with medical air and oxygen 67 to 33%, and injection vecuronium 1 milligram every 25 minutes, and sevoflurane. Blood pressure, pulse rate, saturation, and EtCO2 monitor was done whole time during the surgery, and pulse rate was maintained between 70 to 80 beats per minute with the help of beta blockers, and systolic blood pressure was maintained between 110 to 120 mm of Hg with the use of intermittent infusion of noradrenaline support. Central venous pressure and invasive blood pressure monitor was done throughout the surgery. Fluid input and urine output was monitored throughout the surgery. After the surgery, patient was reversed with injection neostigmine and injection glycopyrrolate and extubated and oxygenated for 10 minutes. Mitral stenosis prevents the emptying of the left atrium, resulting in the left atrial increase in left atrial pressure and left atrial dilatation, which in turn increases the pulmonary arterial pressure, which in turn causes right ventricular hypertrophy and final right ventricular failure. Main signs and symptoms of mitral stenosis include dyspnea, hemoptysis, chest pain, right heart failure, thromboembolism. Auscultation may reveal diastolic murmur and loud first heart sound and audible fourth heart sound and an opening snap. The ECG may show left atrial enlargement, atrial fibrillation, right ventricular hypertrophy. Echocardiograph helps in confirming the diagnosis. The main anesthetic goal in the patient with mitral stenosis are maintaining the slow heart rate in a sinus rhythm, aggressive treatment of the acute atrial fibrillation, maintenance of adequate venous return, maintenance of adequate systemic vascular resistance, and prevention of pain, hypoxia, hypercardia, and acidosis, which may increase pulmonary vascular resistance. Caution are indicated in the use of drugs that can cause tachycardia, including atropine, ketamine, pancuronium, or meperidine. Conclusion is valvular heart disease is very common in people coming to the hospital for various intravenous interventions and surgeries. Most of the patient would need some form of anesthesia to undergo an uneventful surgical encounter. Stenotic lesion do well with a tight fluid control and under general anesthesia with appropriate monitoring and adhere to the hemodynamic goals. Smooth intubation and smooth extubation of this patient with pain-free post-operative period and judicious volume titration and cardiac support play a crucial role in clinical outcome and uneventful recovery. Thank you.
Your patient was diagnosed for the first time with MS or?
Yes, ma'am. First time with MS, ma'am.
But it is too late to present at the age of 60 years to present with critical mitral stenosis, as the area is 0.9. So your patient was on any cardiac medication or not?
No, ma'am, not on any medication, ma'am. She was first time diagnosed with MS. For the first
Okay,
time,
so were there any hemodynamic variability you observed with the change in position at the spine surgery might be conducted in the prone position?
Yes, ma'am.
So,
Yes, ma'am. Did
so did your patient experience hypotension or a hypertensive response? Because you added that you have given noradrenaline infusion to maintain the BP.
We encountered episodes of hypertension in between, ma'am. In between the surgery, we used intravenous intermittent noradrenaline support, ma'am. And while positioning, ma'am, we kept a patient in a deep plane of anesthesia, and we encountered tachycardia during positioning, ma'am. We used beta blockers like esmolol in.
Okay, you might have preferred phenylephrine also in case. Okay, that's all, Dr. Seema. You can go ahead.
The patient was not referred to a cardiothoracic surgeon?
Yes, ma'am. We referred to cardiothoracic surgeon, ma'am. And we discussed the conservative management with neurosurgeon also, ma'am. Surgeon told we need emergency surgery.
That you have mentioned, but that consultation of a cardiothoracic surgeon is not mentioned since it is already near to critical MS.
Yes,
so that option should also be shown to the patient.
Yes, ma'am.
Okay, that's all.
Thank you, ma'am.
Thank you. Next will be Dr. Vaishali Kanodia. Dr. Vaishali, if you can hear me, please unmute and share your screen. Dr. Vaishali? Okay, I think Dr. Vaishali is not here. Next is Dr. Vibha Jageshwar Sakhare. Dr. Vibha, if you can hear me, please unmute. Hello. Dr. Vibha? You're audible, but it's very light. You can just please increase your voice.
Thank you so much.
Can you be a bit loud? Yes. Dr. Vibha, please share your screen.
Yes.
Is it visible? Hello? Hello?
Hello.
Yes, sir. Is it visible? My screen.
Yes, it is visible.
Shall I start?
Dr. Vibha, have you registered for a poster or a paper?
Poster.
Poster. So I think so you are presenting it in.
Sure, it was a case report, so I didn't see options very well.
Okay, ma'am, can we allow this presentation?
As far as I have seen the slides, this is a very large presentation. So please, you present the important part and skip the rest of the slides.
Yes, that is very nice, ma'am. Okay, ma'am, your time starts now.
Hello, myself Dr. Mpisacon. I am senior resident in Department of Anesthesiology, Raipur Institute of Medical Sciences. My case for presentation is thoracic epidural for modified radical mastectomy. So, as we know that breast cancer is most commonly seen cancers among the females.
This part, I think this is
okay. Fine. So this case was of 67-year-old female patient with left-sided advanced breast cancer, and she was planned for modified radical mastectomy. She was a known case of diabetes mellitus and hypertension for 5 years on medication, and both of them were well controlled. She has a habit of Gudaku usage since 10 years and no known allergy of food drug history, no past medical or surgical history. So on examination, her vitals were stable and investigations were within normal limit, except that ECG was showing old ST changes and echo study was normal with 50% EF. Her airway examination revealed class 4 Malampatti grading and teeth were missing with nicotine staining. So she was a case of difficult intubation. She was hence counseled for thoracic epidural anesthesia and written consent was taken for her. So she received her usual antihypertensive dose till the day of surgery, and hypoglycemics were omitted on the day of surgery. She was advised to stop usage of Gudaku till the day of surgery, and on arrival in operation theatre, her multipara monitor was attached to the patient, and vitals were baseline values were within normal limits, and fasting blood sugar was 110. In sitting position, she was given thoracic epidural at T4, T5 level, and epidural catheter was inserted up to 4 centimeter inside. Basically, 4 centimeter of epidural catheter was left in situ in epidural space, and it was adhered with the catheter was adhered with adhesive tape. Test dose was given of 3 ml of lidocaine with adrenaline, and afterwards a loading dose of 8 ml of 2% lidocaine with bupivacaine was given. Later on, epidural infusion of 0.2% bupivacaine and 0.02% of nalbuphine was given to the patient. 5 minutes later, it was observed that sensory block height was from T1 to T10, and hence surgery was commenced for to reduce anxiety. She was given injectable midazolam 1 mg IV, and she was given oxygen via face mask at 4 liters per minute throughout the surgery, which lasted for 2 hours. Her estimated blood loss was 1 liter, and she was hemodynamically stable throughout the surgery and comfortable. Post-operatively, she was kept in ICU for observation and pain management, and continuous infusion of epidural was started. 0.1% bupivacaine with nalbuphine at 4 ml per hour, and intravenous paracetamol was given to complement the analgesia. The patient resumed oral feeding 6 hours post-operatively. So to conclude, thoracic epidural is feasible and safe alternative to general anesthesia, and it is advised for breast surgeries, especially in cases with multiple comorbidities and difficult airways. So these are my references. Thank you.
Nice presentation. Over to our judges.
Did you notice any intraoperative or postoperative complication in your patient?
No, ma'am.
And you kept any backup plan if your thoracic epidural failed?
Yes, ma'am. Difficult airway cart was ready in operation theatre along with fiber optic intubation.
Also, you need to take the consent that anytime you may require to convert.
She was counseled for thoracic epidural, as well as she was given a consent that if thoracic epidural fails, if regional anesthesia fails, she would be given a general anesthesia. That could be difficult, and that she might need a awake intubation for that.
Okay. Dr. Seema, you may proceed.
Why the patient was shifted to insulin?
Sorry?
Why the patient preoperatively you have given insulin to your patient? She was managed on OHA. It is not mentioned whether the diabetes was controlled or not.
Diabetes was controlled. It was basically advised by physician to shift the patient from metformin to inhuman insulin.
I think usually it is a surface surgery, so not much hemodynamic changes and not much fluid shifts occur. and the patient can take orally after few hours. And in case your case, so she can start even early also. Okay, that's all.
Thank you.
Thank you, ma'am. The next participant is Dr. Vaishali Kanojia, LNMC Bhopal. Dr. Vaishali, you can unmute yourself and you can share your screen now.
Yes, yes. Just a minute.
Yeah, please share your screen.
Just a minute. I'm just. Yes. Can you see the poster? Hello?
Yes.
Yes, yes. Good evening, respected sir and ma'am. Myself, Dr. Vaishali Kanojia. I am presenting post of Dr. Nupurti ma'am. He is an head of the department, and Dr. Anuj sir, he is an associate professor. And my topic is difficult intubation in case of ranula. So, first of all, this case as an anesthetic, why did we choose this case of ranula? As it was a very difficult assessment of the airway, and the plunging ranula, just as an introduction, it is a form of a mucus cyst arising from the submandibular or sublingual salivary gland, which may become huge, occupying the whole of the floor of the mouth, extending into the neck. As in my case, it was a 20-year-old male who presented with a right-sided gradual proliferating mass over the sublingual region. And in this case, the X-ray was normal, and the CT scan was showing a benign cystic lesion with the extension, which was extending from the sublingual to submandibular region up to a genioglossus superiormedially, which was also making the neck movement, which was also restricting the movement, and ultimately making the airway management difficult. So first,
Suddenly the connection lost.
hello.
Yeah.
Yes, Dr.
Hello.
Vaishali.
Yes, yes. Just a minute. I'm sharing.
Yes,
The
share again and resume from the.
Yes, 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 yes. Yes. So initially, the patient was explained and reassured about the procedure, and well-informed consent was taken. And preoperatively, patient was optimized, and then he was nebulized with a 4% lignocaine for around 10 minutes, and then oxymetazoline and nasal drops were given instant both the nostrils for decongestion. And patient was taken OT, and all the standard monitors were attached, and pre-oxygenation was done for with 100% oxygen for 3 minutes before the procedure. Then bilateral superior nerve block was given, and pre-medication done with the injection of glycopyrrolate, midazolam, and fentanyl. And then fiber optic was done with the left nair with continuous spray of 10% lignocaine throughout the suction channel, through the suction channel, along with the continuous flow of oxygen. And a 7 mm ID flexometallic curved tube was railroaded after the fiber optic scope was passed beyond the vocal cord, and along with the visualization of carina. The tube was inflated, and bilateral air entry checked and confirmed with the auscultation. And then the tube was fixed. Throat packing was done, parallelly induction and maintenance, and done with the propofol VEC and oxygen, nitrogen, and isoflurane. Intraoperatively, patient was hemodynamically stable throughout the procedure, and vital parameters were also stable. And then extubation was done, and then patient shifted to the PICU for the further management. And the management of this difficult airway is very challenging. And also life-threatening complication. In my case, the plunging granula, the huge intraoral swelling was occupying the oral cavity and hindering the glottic visualization completely, as thus making the ET tube intubation very difficult. And many of the literature shows that difficult airway can be easily approached and managed effectively with the help of fiber optic bronchoscopy, as it has been established that it is superior to conventional laryngoscopy. And huge swelling making the conventional laryngoscopy difficult preoperatively. So we planned the awake fiber optic nasal intubation as a strategy to secure the airway. And fiber optic intubation is also a gold standard approach for managing all the difficult airway cases. So finally, the conclusion was that the difficult airway should always be managed by a planned strategy to avoid any catastrophic situation which can lead the life threat to a patient. And in our case, we overcome this difficulty by throughout thorough post preoperative assessment, optimization, careful monitoring throughout the procedure, and obviously with the awake fiber optic bronchoscopy. Thank you so much.
Thank you. Very nice presentation. Now over to our judges.
No question from my side.
Okay, no questions from my side also.
Thank you, ma'am.
Thank you, ma'am.
Next presenter is Dr. Sukriti Jain. Dr. Sukriti?
Yes, am I audible?
Yes, you're audible. Can you please share your screen with us?
Yes. Is this visible? Screen? Hello?
No, it is not visible.
Okay, one second. Is this visible now? Excuse me, is this visible now?
No, Dr. Sukriti, we are not able to see your screen.
Uh,
Are you using your laptop?
No, sir, I'm using my mobile because in laptop there is audio problem.
Okay. Okay.
Going from here.
Dr. Sukriti,
Yes, sir.
We will give you some more time at the end of our session.
Okay.
Till then, you can sort out the problem. The
Achha,
next
okay.
participant is Dr. Twinkle Patel.
Good evening.
Yes, Dr. Twinkle, please share your screen.
Yeah. Just a second.
Dr. Twinkle?
Yeah, just a second, I'm sharing. Just a second.
Yeah, we will.
Is it visible?
No.
No, we are not able to see your screen. Your laptop?
I'm sharing the screen. Is it visible?
Yes, it is visible.
Okay. Actually, it's not visible to me.
See your screen, but we are not able to see your presentation. Just go to the multi-screen and open your presentation.
Okay. Is it visible now? Hello?
Yes, Dr. Twinkle, it is visible. You can start with your presentation now.
Okay. Good evening, respected judges. The topic for my poster presentation is the anesthetist role in avoiding obturator jerk in the transurethral resection of bladder tumor under guidance of Dr. Sangeeta Bansal Agarwal, ma'am. Transurethral resection of bladder tumor is a common procedure to treat bladder cancer. The incidence rates are higher in older males than females. A serious complication of TURBT is bladder perforation, which is increased due to obturator jerk, which can lead to perforation which associated with TUR syndrome, tumor dissemination, and the need for laparotomy, leading to overall morbidity. Anesthetist might be unaware of the fact that obturator nerve is spared in subarachnoid block, and this leads to serious complication for which surgeon might prefer to perform the procedure under GA. However, an approach of performing obturator block followed by subarachnoid block provides equally excellent operating conditions with added benefits of better patient outcome. Obturator jerk. Tumors are more common at lateral side of bladder, where also lies the obturator nerve, and its direct electrical stimulation during electrosection can result in a powerful adductor spasm of leg. The anatomy of obturator nerve, it's a mixed nerve arising from anterior primary rami of L2, L3, L4 lumbar plexus, descends vertically within the psoas major and travels with lumbosacral trunk crossing into pelvis at sacroiliac joint and runs anterolateral to the ureter. Here it runs laterally to the wall of bladder, followed by superior part of obturator foramen and passes through obturator canal before entering adductor region. The anesthetist techniques for preventing obturator jerk include either neuromuscular blockade achieved by using either non-polarizing neuromuscular blocker or depolarizing neuromuscular blocker, both of which requires GA. And selective blockade of the obturator nerve can also be performed by either of the three approaches. The first approach by Labat is a classical approach. In supine, position of the patient is supine, ipsilateral leg is abducted to 30 degrees. Needle is inserted perpendicularly at 1.5 centimeter laterally and caudal to the pubic tubercle. Needle advance at the obturator foramen and contractions of the thigh are observed. The second approach is interadductor approach. Needle inserted behind upper end of adductor longus laterally upwards and posteriorly towards the obturator canal, and nerve stimulation allows the nerve identification. The third approach is inguinal approach. Patient in supine position, legs abducted, midpoint of the inner border of adductor longus tendon and femoral artery is observed, and needle is inserted in cephalic direction till contraction of gracilis and adductor longus is observed. If we perform obturator block after followed by SAB, the advantages offered will be less risk of respiratory and airway manipulation like GA, better hemodynamics. It also avoids systemic side effects like using opioids in GA, less bleeding, less chances of DVT, overall reduced morbidity and mortality, and overall patient satisfaction. The discussion part. TURBT is relatively common urological operation performed to remove tumors of the bladder. These tumors occur predominantly in the elderly population. Every measure should be taken to avoid serious complications both from anesthesia and surgeon side. One of the most serious complications is perforation of bladder, which is associated with obturator jerk. Surgical measures to reduce the likelihood of obturator jerk include reducing the diathermy current, using bipolar as opposed to monopolar diathermy, and avoiding an over-distended bladder. Anesthetists should factor in obturator jerk when considering the most appropriate anesthetic technique for a particular patient, and should consider the use of neuromuscular blockade or an obturator nerve to reduce the risk of bladder perforation. Thank you.
What are the complications of obturator nerve block?
First complication can be, ma'am, inadequate block can be achieved if not performed if not performed in a proper way, ma'am, actually USG guided or PNS guided nerve block is best. But if the failure chances are more common in blind technique.
No, what complication can occur with either of the technique? Is there any technique related complication?
Yeah.
Since you are inserting a needle, there may be chances of bladder perforation, or there may be chances of injury to the bowel or rectum.
Bowel, rectum, and any nerve vessel injury can be.
You can perforate obturator vessels, and then you can develop systemic toxicity of the local anesthetic. So that might be the complications that you may encounter with the obturator nerve block.
Yes, ma'am.
Okay. That's all.
What are the complications of obturator nerve block?
There can be injury to surrounding vessels or.
What can be the complication that have already been discussed? What are the side effects that, what are the contraindications for performing this obturator nerve block?
Patient anxiety, any coagulopathy, patient if the patient denies to perform the procedure.
Yeah,
and
that's common for all.
Yeah, ma'am. And infection at the site of block.
Yeah, inguinal lymphadenopathy.
Inguinal lymphadenopathy. Yeah, ma'am.
And one entity is there, pre-existing obturator neuropathy.
Okay. Yes, ma'am.
Also a contraindication. Okay.
Thank you, ma'am.
Our last contestant for the session is Dr. Sweekarti Jain. Dr. Sweekarti?
Yes, sir.
Please share your screen.
Yes, sir. Sir, is this visible?
Yeah.
You can start with your presentation now.
Yes, sir. Sir, myself, Dr. Sukriti Jain, presenting poster on challenges in the anesthetic management of a case of mucormycosis under Dr. Sangeeta Bansal, ma'am. Introduction. Mucormycosis is a fulminant opportunistic fungal infection most commonly seen in diabetics and immunocompromised individuals that spreads very rapidly, causing tissue infarction and necrosis. It is a highly lethal, locally invasive with propensity to involve rhinocerebral, GIT, pulmonary, burn wounds, CNS, endocarditis, and vascular organs. Here we are reporting a case of successful anesthetic management in a patient with post-COVID mucormycosis posted for intraoral surgical debridement. Various factors in mucormycosis which needs to be considered to deliver safe and quality anesthesia. Post-COVID systemic effects like residual pulmonary dysfunction, adrenal suppression, myocardial dysfunction, difficult airway due to mucormycosis, and adverse effect of amphotericin B can alter anesthetic outcome in these patients. Here our anesthetic challenges are, our patient posed us 3 challenges. One is difficult airway in view of black discoloration of palate, reduced mouth opening, poor oral hygiene, and broken teeth, limitation of space of laryngoscope, and a traumatic intubation. Second is long-standing diabetes mellitus. Third is continuous infusion of amphotericin B, which could interact with anesthetic agents and produce an adverse outcome. Fourth is post-COVID status. Now our case report is a 67 years old diabetic male admitted with complaints of high-grade fever with chills and right-sided headache with swelling of face since 7 days. Vomiting and abdominal pain. Vomiting and abdominal pain and bleed from oral cavities. Giving history of COVID infection 1 month back. He was treated with injection amphotericin B at 5 mg per kg per day and antibiotics and planned for surgical debridement.
On pre-anesthetic checkup, he was found to be a case of uncontrolled diabetes with mouth opening 2-finger, MPC grade 3. All routine investigations and electrolytes were found to be normal, except TLC was 13,067 per microliters. Fasting blood sugar was 282 mg per deciliter. HbA1c was 9.2%. His ECG, chest X-ray, echocardiography, and PFT were all within normal limits according to age. For pre-op optimization, he was put on regular insulin for sugar control and antifungal amphotericin B along with antibiotics to control sepsis. After control of blood sugar, the patient was taken for surgery with informed written consent. In OT, difficult intubation card was kept ready. Patient was connected with the NS and standard monitoring including ECG, non-invasive blood pressure, pulse oximetry were applied. Injection GPL, fentanyl, midazolam as premedication were given, and the patient was induced with IV propofol and rocuronium. After a smooth laryngoscopy and securing the airway with flexometallic endotracheal tube and with the help of bougie, anesthesia was maintained with oxygen, nitrous, and isoflurane with controlled ventilation. Intraoperatively monitored with capnography and adequate hydration was done to maintain mean arterial pressure and urine output. Patient developed ventricular ectopics more than 7 per minute with BP reading 92/66 mm of Hg, which was treated using ventilation with 100% oxygen, injection lidocaine 1.5 mg per kg, bolus dose, and with 0.5 mg per kg of infusion over 20 minutes. And we withdraw the amphotericin B infusion. Ectopics reduced to less than 2 per minute with a BP of 116/70 mm of Hg. After completion of surgery, he was reversed and extubated on return of his spontaneous respiratory efforts. Postoperatively, he was shifted to ICU for management, including amphotericin B and monitoring of all the renal parameters and blood sugar. Patient was kept on hyperbaric oxygen to aid revascularization with subsequent healing in poorly perfused acidic and hypoxic but viable area of tissues. Now discussion. Post-COVID-19 patients have residual shortness of breath and deranged PFTs, which are suggestive of restrictive lung disease. So respiratory assessment, including PFT and chest X-ray, is needed. For emergency surgeries, risk stratification with post-op ventilatory support should be planned. Pre-operatively cardiac assessment, including echocardiography, is needed. The risk of thromboembolic phenomena due to hypercoagulable state associated with post-COVID infections should be kept in mind. Use of succinylcholine should be cautiously done in patients recovering from prolonged critical COVID-19 illness to prevent myopathy-induced hyperkalemia. Isoflurane can be the preferred inhalational agent as it has been found to halt fungal infection in vitro. Patients with mucormycosis may have difficult mask ventilation and endotracheal tube intubation as a result of epiglottitis and supraglottic edema associated with fungal debris. So a difficult airway cart with a backup of tracheostomy must be kept ready. Blood and blood products, transfusion, and intra-op inotropic support may be needed in some patients due to extensive nature of surgery. Due to amphotericin B-induced side effects like nephropathy, hypotension, hypokalemia, hypomagnesemia, arrhythmias, and fever, continuous monitoring of invasive arterial pressure and arterial blood gas analysis should be considered for extensive surgeries. And summary is, or conclusion is, systemic antifungal therapy, early complete surgical debridement are the mainstay of the treatment of mucormycosis. Post-COVID patients are on risk of anesthetic complications due to suppressed immune response, ciliary dysfunction, cytokine storm, and microvascular coagulation due to COVID has put these patients at risk for anesthetic complications. So we must prepare ourselves for these challenges and problems and reevaluate our anesthetic approach towards these patients. Thank you.
Did you monitor blood glucose intraoperatively?
Yes, ma'am. We monitored hourly blood blood glucose.
And did your patient require insulin or not?
No, ma'am. No, ma'am. Intra-op, we didn't require insulin. It was uncontrolled before surgery, and continuous insulin is already given. Intra-op, we don't need it.
Okay. What about the electrolyte disturbances in your patient?
Ma'am, it is, ma'am, post-operatively, we found electrolyte disturbances after 2-3 days. So we reduced the dose of amphotericin B from 5 mg per kg to ma'am 2 mg per kg. We have reduced after 2-3 days because post-operatively we are also seeing that KFT and serum electrolytes.
But what was the reason? What can what have attributed to ventricular ectopics intraoperatively for your patient?
Maybe the electrolyte disturbances.
Apart from that, what are the other possible causes?
Cardiomyopathy may be the reason because it.
But you have performed 2D echo and it was absolutely normal. You have told
It
PST was
right,
also normal. So I think your patient was absolutely all right, except for uncontrolled blood sugar level and somewhat of difficult airway. But that too you managed very easily and successfully in a single attempt. So I don't think there was issue with this patient.
Yes, ma'am.
Okay, so over to you, Dr. Seema.
Yeah. Could your patient have adrenal suppression?
Ji, ma'am, sorry.
Could your patient have adrenal suppression?
No, ma'am, we didn't find it, ma'am.
How will you find it? I mean, clinically, I'm asking the intraoperatively your patient developed ectopics and hypotension. Why adrenal suppression should occur in these patients of mucormycosis?
Ma'am, because ma'am, cytokine storm is there, and ma'am, catecholamine release may be there.
They are on long-term use of steroids is there, and so these patients are prone for adrenal suppression, and that can cause hypotension. If
Yes, ma'am. Yes, ma'am. Yes, ma'am. This may be the reason, ma'am.
Yeah. Okay.
Thank you, ma'am.
Our one more last contestant is there, Dr. Palak Deep. She's from Subharti Medical College, Meerut. Dr. Palak.
Yes, sir.
Screen.
Can you hear me?
We can hear you. Please share your screen with us.
Okay, sir. Just give me a second. So is it visible?
No, Palak, we cannot see your screen.
So just give me a second. Just give me a second. So is it visible now?
Yes, Palak, it is visible, but we are not able to see anything. Can you zoom it in?
Yeah, sure, sir.
You can start with your presentation now.
Yes, sir. Good evening, ma'am. My topic for poster presentation is a patient with Marfan syndrome for cataract surgery and anesthetic challenge. And I have done this case under the guidance of Dr. Bhavna Rastogi, ma'am, Professor and Head of Department Anesthesia, Subharti Medical College, Meerut. Firstly, we talk about the introduction. Marfan syndrome. It is an autosomal dominant multisystem disease. Mutation in FBN1 gene on chromosome number 15 encodes protein fibrillin. Features are, in facial features, we have microgenetia, microglossia, high arched palate, crowded teeth. In ocular, we have lens dislocation and myopia. And in cardiovascular, we have aortic root dilatation with aortic regurgitation, mitral valve prolapse with mitral regurgitation. In musculoskeleton, we have features like long bone overgrowth, scoliosis, kyphosis, joint hypermobility. This is a case report. 25-year-old male, he was diagnosed with Marfan syndrome, posted for cataract surgery. His chief complaint was diminution of vision in right eye. He was mentally challenged since birth. On examination, he was tall and thin, long arms, legs, fingers, and toes. BP was 110 by 60 millimeters of mercury. Pulse was 80 beats per minute, and saturation was 98%. Uh, he was anxious, not oriented to time, place, and person on valproic acid, olanzapine, and colanzapam. On airway examination, he had crowded teeth, large tongue, narrow high-arched palate, Malam patti grade 1, mouth opening more than 3 fingers. In investigation, we have sent the routine investigation, ECG and 2D echo, which were all within the normal limits. On chest X-ray, we saw pectus excavatum. On ultrasound, there was minimal pleural effusion. In preoperative management, patient was nilperoral and patient was anxious and mentally challenged. Monitoring of ECG, non-invasive blood pressure, and SpO2 was started. And IV line was secured with 22 gauge cannula because his veins were very thin and fragile. Now, the plan of anesthesia, we have planned it in 3 ways. We have 3 plans, plan A, B, and C. Our first plan was to give sedation, retrobulbar block, and oxygen with nasal prongs. Second was GA with LMA Prosil with spontaneous breathing. And third was GA with laryngeal tube with spontaneous breathing. We gave the patient butyrophenol 0.6 mg plus glycopyrrolate 0.2 mg as a pre-medication. Oxygen plus halothane with face mask was given, and patient was on spontaneous breathing. So patient developed apnea, so plan A was abandoned. Then anesthesia was deepened with oxygen plus halothane. Then we used LMA Prosil number 3, which was inserted. Patient could not be ventilated with it. So we removed it and we took a second attempt for LMA Prosil in number 3, which was again unsuccessful. So then we had a plan C, in which we put a laryngeal tube number 3. In first attempt, it was successful and patient was ventilating. There was one episode of bradycardia after this, which was treated with atropine. Rest, the surgery was uneventful. Discussion, anxiety and irritability, valproic acid, olanzapam, and clonazepam was given. In preoperative evaluation, we'll focus on the cardiopulmonary abnormalities such as valvular diseases, aortic insufficiency, mitral regurgitation, mitral valve prolapse, or any aortic arch aneurysm, aortic rupture, and dissection risk, any arrhythmias and conduction defects, prone to the early development of pulmonary emphysema. And overgrowth of maxilla results in high arched palate, protruding jaws, coupled with crowded teeth, anticipated difficult intubation. Proper planning and preparation is the key to successful management. Having difficult airway equipment at hand and quick decision can be life-saving. Proper positioning and limb support and muscle relaxant used with caution. Conclusion, Marfan syndrome is a challenge for anesthetists. The pre-existing cardiovascular disease and airway difficulty, careful preoperative assessment and skillful anesthetic technique to avoid the fatal complications, and perioperative morbidity and mortality, including unexplained death and high risk to be taken. And these are my references.
It was a nice presentation.
Thank you, ma'am.
Why did you prefer butorphanol over other opioids in your patient? Was there any reason behind using butorphanol?
No, ma'am. No, ma'am. Actually, we thought of using butorphanol or tramadol, and then we gave Butram to him. And there was no specific reason.
And did you have you given any anti-aspiration prophylaxis?
Yes, ma'am. Ma'am, we have gave him Midas before this.
I'm asking aspiration prophylaxis.
Aspiration, ma'am. No, we haven't given any aspiration prophylaxis.
Why? It is important since you are planning to conduct the case in general anesthesia and you are inserting LMA. You have not given any aspiration prophylaxis to a patient. Post-operative nausea, vomiting is an important issue which should be covered.
Ma'am, intraoperative, ma'am, before the surgery was going to finish, 15 minutes before the end of surgery, we gave MSET. Ma'am, but not
So that what?
Not pre-op, ma'am. Actually, we have not given it in the pre-op.
Okay. And was there any interaction of drugs he was receiving pre-operatively with your intraoperative medication?
No, ma'am.
There was not any chance of delayed recovery? Or...
No, ma'am. There was no drug reaction.
Okay. Thank you.
Thank you, ma'am.
No questions from my side.
Thank you, ma'am.
Thank you.
Thank you, ma'am. Thank you for this marathon session that we had. Thank you for your patience. We have completed 15 participants, ma'am. I think that is a record. We haven't had that much participant in any of our groups. And with this, this was a very interactive session. New ideas we had, and the guidance and the expert opinion that we had from our judges was exceptional. And with this, we are going to end this Hall B session for our 35th annual conference, Mpisacon. Everyone, I want to thank from the behalf of ISA, MP Sagar, and Bundelkhand Medical College Sagar. Thank you, everyone. Thank you, ma'am.
Thank you, Himanshu. You are also so patient to conduct it since morning. You are in the Hall B and you are conducting very smoothly. Thanks a lot.
Thank you so much, ma'am. Thank you, ma'am.